लेकिन वो टाइमली नहीं हो पा रहा।
दो हाथ तो लगता है तो मैं कर सकता हूँ। दो हाथ
आपके पीछे ये है ना, ये क्या कर रहा है?
नहीं, ये तो वहाँ दूर है ना।
ये वाला तो बहुत देखो वहां से भी होता है। एक बार अभी इसको थोड़ा टाइट कर लो, तो थोड़ा टाइट कर लो। टेप लगा
इधर नहीं आता टेप वाला।
क्यों नहीं आता?
टेक्निकल आदमी है, टेक्निकल
अरे कोई बात नहीं भाई यार, सब अपने घर के लोग होते हैं वो मुझे करता है। टेप है ना, देखो आपका काम आ जाता है।
हमें नहीं आता मुंह पे लगा सकता हूँ टेप, आप बताओ कितने लगाना है।
अपने खर्चा में काम ना सब ये कहना चाहिए कि मेरे को ये नहीं आता, वो नहीं आता, ये मेरा काम है, सबका काम है। ये थोड़ा सा
वो आगे से ट्राई करता हूँ। वो भी कितना भी जोर खा रहा है ना, वो पूरा लगाया ये गैप है। हाँ किसी को या देख काम कर बाकी तो ये एक्स्ट्रा है ये काम
प्रेजेंटेशन के लिए मैं मेरा लैपटॉप ले। हाँ हाँ आपको हाँ मेरा हाँ हाँ तो मंगवाइए। presenting Dr. Naina and the session coordinator.
अच्छा
And
presentation
the presenter will be here and the discussers will be here. Suppose sir will be sitting here.
तो आपको भी कराना पड़ेगा
Extension extension.
टेंशन पे आई हाँ लगा तो ना
Swati,
yes
ma'am, you've not given the introduction. Sir had asked 50 lines introduction.
आप लिख लो you are going to introduce her
Yes.
Dr. Swati Purohit Joshi Associate Professor Department of Radiodiagnosis
Department of Radiodiagnosis, MGMC.
Same term, there was associate professor.
Associate Professor Radiodiagnosis. MGMC. Dr. Manpreet भी
हाँ
साथ में बट एमजीएम से लास्ट में खोल के भी नहीं देखी
हाँ हाँ बिल्कुल आगे क्या आपका
third पे back पर. The discussor. Maybe the discussor for the first. Yeah. Fine. We keep it there.
Budget
The presenter will be here. Ma'am, Swati ma'am. Wherever ma'am is comfortable. Ma'am, are you comfortable there or uncomfortable?
as long as
All three of you
extension
have
man
to
comes
sit here because the camera will be here
जाने वाला है
on all of you. So, आप इधर आ जाओ मत.
extension
ठीक है, तब तक इधर आ जाओ.
जल्दी जाओ
I think the presenter can sit in the middle.
Presenter is
बंद हो जाएगा
तो डीके के सेंटर में
वो उधर ही बैठते हैं.
तो खराब ये लैपटॉप पास ऑन कर दोगे
नहीं हुआ
नहीं हुआ ना
वो बंद हो गया
कोई बात नहीं टाइम नहीं
लगा उसको एक्सटेंशन तो आगे रखना चाहिए ना एक्सटेंशन बहुत
ठीक लगता है
हरी स्लाइड होते हैं
हाँ
जाको
I'm good कैसे हो? ठीक अच्छा, कल शाम को shunts।
तो आप यहाँ से
मैं friend
यहाँ से वहाँ से खत्म करोगे।
गुड मॉर्निंग।
हाँ, अब हो रहा है चार्ज। जब तक नहीं आता तो इस पे जानी। मैं यहाँ से
ठीक है, आप यहाँ से कर लो, मैं यहाँ फिर ये रात को
पर मुझे चार्जिंग चाहिए तो बैटरी चार्ज नहीं चार्जिंग पर एक्सटेंड बोल दिया
सर एक्सटेंशन आया, मेरे भी इसमें सेम प्रॉब्लम है। मैं भी यही लगा
बस कोई टाइम नहीं मिला बैटरी पैक चेंज करने। मुझे खाली चार्जिंग चाहिए हो, ठीक है, और बाकी सब कुछ मेरे पास है। एप्पल लग जाएगा ना आपका यहाँ पे? तो देखो मैं एप्पल लगेगा आपका नाम
सॉरी,
एप्पल
11 को है मेरा। हाँ,
हाँ
इसमें डाल।
We joined this room. You are stipulating
नहीं, उससे ये होगा
You have to check up your own backup. हाँ, क्या? ऐसा कर सकते हैं?
हाँ
कर सकते हैं?
उसके लिए सर तुम ज्वाइन कर लेते हैं, स्क्रीन शेयर से हो जाएगा।
मेरे पास नहीं है।
मैम सर आप है ना ब्रेकफास्ट कर लीजिए।
मैं ये तो 5 मिनट हाँ जल्दी
ठीक है।
हाँ ये बात
वाईफाई का पासवर्ड पीछे।
It's written outside JS.
हाँ, वो तो है for energy.
But even I told them, they just asked the stuff.
Because I'm thinking we can join the Zoom. And then उससे screen share हो जाएगा.
वो पेन ड्राइव में usually they put it and the screen share option is also there. He coordinates. I don't know. वो there's a person. हाँ, सुरेंद्र जी हैं.
I think he's
He
like
coordinates.
having his breakfast.
बट हम
क्योंकि इसमें ना वो वीडियोस वगैरह रहते हैं ना, तो वीडियोस चलते नहीं है जल्दी।
आपको मैकबुक से लग रहा है यहाँ पे
ये वाली
एक
माइक
ट्राई करना है।
अच्छा चले मैं
नहीं वो आई सेंड हिम टू गेट दैट that was कनेक्शन नहीं तो नहीं लगेगा।
मेरा तो नॉर्मल HDMI पे हो जाता है।
अच्छा मेरा तो है नहीं
नहीं, you don't sir, you want to
स्पीकर
आपको करना है क्या?
हाँ भेज दो नहीं तो मैं दोबारा बोल देता हूँ।
मैं आपको भेजा होगा सर.
Sir, you want to present through Mac क्या?
हाँ
ये कनेक्टर है मेरे पास।
वो है ऑलरेडी बट आई सेंड समथिंग
अच्छा
सो कनेक्शन नहीं तो आप मुझे दे
हाँ हाँ चलेगा
सर आपको बता दीजिए.
आप मुझे बता दीजिए।
तो सुन रहे हैं
हाँ.
एचपीवी सर्जन
फर्स्ट पे आपका info।
हाँ मेरा फर्स्ट पे
भी सर्जरी टाटा मेडिकल से
आपका आया नहीं क्या अभी तक?
Right.
So he doesn't come.
I sure
No problem. Because Viraj problem. काम करो. What's going on? तो फिर हमसे बीच में लगा.
इसको क्या है एक्सटेंशन वाला?
You are the first.
इसको नहीं इसके से नहीं
इसको
मैंने पीपीटी खोल के तो देखी.
इन्वेस्ट करना कैसे
हम आपने ज्वाइन किया है जिम पे।
हाँ
फिर उससे आप स्क्रीन शेयर कर सकते
से डाउनलोड किया है।
तो ये पासवर्ड पता है क्या सर?
आप ना उसको बोलिए वो जो अभी मेरा कर रहा था ना.
वाईफाई सॉरी रिटर्न
आपने किया ना?
I
You had and came from home.
yeah.
पासवर्ड विल स्टार्ट विल MGU at the equal to
And username is MGU
yeah
तो ये SRCC वाला है क्या ये?
हाँ
Yeah.
SRCC वाले. हाँ मुझे भी बता दो ना फिर.
MGUMS के
All is small.
All in small because this acha.
The username is all small. Password is capital M and all small.
Right, thank you.
आप सबके breakfast की है?
Maybe tell me.
Breakfast.
TC पे हो जाएगा.
एक सेकंड बस रूम ज्वाइन करके आपको.
Good morning, sir.
Documentary.
Yes, yes.
Good morning, sir. Good morning, sir.
What is it?
Yes.
Ready?
Thank you.
ये Zoom का लिंक ये इधर पे वाईफाई यूज की.
Share by vision.
Sorry.
Avinash. इसमें से उनका नंबर तो लो डॉक्टर DSRS पर कॉल कर लो.
Distal is the designation.
Director of Center for Digestive Science.
It's very common to
Very good. Oh, so, I think about 6-7 next year. Yeah.
Good morning, everyone, and welcome to the second day of the 5th edition of Jaipur Surgical Festival. Yesterday, we discussed the surgical anatomy of the GI tract, and today we are going to devote the whole day to the surgical anatomy of the hepatopancreaticobiliary system. I'm very happy to report that we have almost 300 online registrations, 200 from India and 80 plus from various countries, which I mentioned yesterday. I'm also happy to note that the technical team has informed me that Dr. Shastri's keynote lecture yesterday has already had more than 300 views, and several other videos which were uploaded are being watched by the students. So I think that this innovative hybrid mode of Jaipur Surgical Festival is probably reaching out to a large number of students and practicing surgeons. So we'll start the liver session today, and the first presenter for today is Dr. Swati Purohit Joshi. She is my colleague in the Department of Radio Diagnosis, and I don't think I would be exaggerating to say that she is the sheet anchor of reporting our CT scans and educating us about the surgical anatomy and the pathology happening inside. We also have discussers, Dr. Manpreet Uppal. She is in the surgical gastroenterology department at AIIMS, Nagpur, and Dr. Vineet Mishra, who is my colleague again in the Department of Radiology and an expert on MR imaging. So over to you, Swati.
Good morning, everyone. Thank you, sir, so much for the kind introduction. Good morning, everyone. Hello. Thank you, sir, so much for the kind introduction. I'm Dr. Swati Purohit Joshi, Associate Professor of Department of Radiodiagnosis, Mahatma Gandhi Medical College and Hospital. I will be talking today about the CT-MR anatomy of the liver. Starting with an overview of what my presentation is going to be. So I will be speaking about the basic CT and MRI protocols, followed by the segmental liver anatomy, the arterial blood supply of the liver, the portal venous system, the venous drainage, and the biliary anatomy. So the basic segmental anatomy used in both CT and MRI is the same, with CT preferred for vascular and MRI preferred for the biliary anatomy. Before we delve into details of the radiological anatomy of the liver, a contrast CT is essential to understand the CT anatomy, and we should be familiar with the protocols. Otherwise, we will end up with suboptimal quality scans. For any diagnosis, we should remember that an optimal scan is the first priority. So CT is the most commonly preferred cross-sectional imaging for the evaluation of the liver. CT of the liver is usually performed as a part of the whole abdomen imaging, and contrast is often used, and the technique is termed as a triple phase imaging to denote the different phases of perfusion of the liver. We are giving around 1 to 2 ml per kg body weight of the patient, contrast at flow rate of 3 to 4 ml per second, and it is triggered using real-time bolus tracking at 180 HU in the lower thoracic aorta for accuracy. So in short about the triple phase CT protocol before we start with the radiological anatomy. So when we talk about the triple phase CT protocol, it actually means we are taking the left arterial phase, the portal venous phase, and the delayed phase. But of course, we have to take a plain or non-contrast scan because we get a lot of information from there also. And an early arterial phase is mandatory if we want to know about any tumoral details about the encasement or the vascular anatomy, so on. Talking about the portal venous phase, this is most important, and mostly all our anatomy, whatever images I'll be showing is going to be of the portal venous phase, because here the parenchymal perfusion of the liver has peaked with optimal opacification of both the portal and the hepatic veins, and this phase often stands out the hypovascular metastasis and other portal vein pathologies on a well-perfused background liver. In short about the pre-contrast abdomen, because it helps in the evaluation of liver parenchyma and assessing the fatty infiltration. So here we can see that the liver appears to be much more darker than the spleen. So this is the spleen, and the liver, it appears much more darker than this. So normally what happens that the attenuation of the liver is greater than spleen. And if liver attenuation is less than spleen, that means there is steatosis. Why is spleen an ideal comparison? Because stable attenuation, no fat deposition. Since the hepatic vessels here appear denser than the liver parenchyma, then we understand that the steatosis is approximately 30%. Now, the normal liver Hounsfield unit values on CT are typically between 50 and 65 HU, while normal spleen values around 40 to 60 HU. So the interpretation of the liver attenuation or the LAI index alone is according to the liver HU value. If it is 40, it's approximately 30% fat. If it is 30, it's approximately 50% fat. And of course, we measure the multiple 1 centimeter ROIs across all segments as seen. We take an average and then we subtract and then we get the HU value. And accordingly, if it is greater than 5 HU, then there is no significant steatosis. If it is between -10 to 5, it's mild to moderate, and so on. In short about the MRI liver protocol, it is superior to CT for characterizing the liver masses. Of course, CT has better spatial resolution. That is, it has the ability to distinguish between two adjacent structures. But MRI has better contrast resolution. That is, it is able to distinguish difference between similar but not identical tissues. We take a non-contrast T1 in and a post phase for fat identification and post-contrast images, and the DWI, or the restricted effusion, seen in abscess and malignancy cases. Starting with the liver anatomy, we will be talking about the segmental anatomy and so on, but not necessary in that sequence. To give an introduction, basically it was the French surgeon and anatomist Claude Quinault. He was the first to divide the liver into 8 functionally independent segments, allowing the resection of segments without damaging other segments. So the liver is divided into 8 functionally independent segments, each with its own vascular inflow, outflow, and biliary drainage. There is a triad of the portal vein, hepatic artery, and the bile duct at its center. We have the hepatic veins at the periphery, intersegmental. The middle hepatic vein is a very important landmark, and it divides into the right and left lobes of the liver. And below the middle hepatic vein, it is a cancellous line, which is important. The right hepatic vein is again another landmark. It divides the right lobe into anterior and posterior segments. The left hepatic vein divides the left lobe into medial and lateral segments. And the portal vein is important as it divides the liver into the superior and inferior segments. So, for the systematic approach to liver segmentation, we should have the knowledge of the anatomy of the portal and the venous system on which it is based. So first, we will discuss the hepatic and the portal venous anatomy, followed by the liver segmentation, then the hepatic artery anatomy, and lastly, the biliary anatomy. Coming to the hepatic veins and variants, we can see that this is a schematic diagram. Here we can see this is the IVC, this is the left hepatic vein, this is the middle hepatic vein, and this is the right hepatic vein. So here, these are the VR images. Basically, we have the 2D CT images, stacked 2D CT images, and we acquire these VR images through post-processing. These are also known as the volume rendered images. And it is good for both the radiologists to understand the anatomy, and it is very important for the surgeons also. So this is the IVC. We have the right hepatic vein, and we see that the segments 5, 6, and 7 veins are draining into it. We have the middle hepatic vein. So the segment 8, 5, 4A, and 4B are draining into it. And this is the LHV, where the segments, veins from the segments 2 and 3 are draining into it. So the right hepatic vein, largest, draining majority of the right lobe. The middle hepatic vein, left hepatic vein. And we should remember that the middle and the left hepatic vein always are in close proximity. And in 60 to 70% of cases, we have seen that it presents as a common trunk. A very important thing is that we should also see the accessory inferior right hepatic veins, because in 40 to 50% of the cases they are seen. And if it is greater than 4 mm, it should be identified. This is just a schematic diagram telling us about this is the middle hepatic vein, because as we will discuss, it's an important landmark, and we can see that it is also draining the segment 8 and the segment 5 veins. These are the inferior accessory right hepatic vein. As we can see, this is a schematic diagram showing the right hepatic vein draining into the IVC, the left hepatic vein, and the middle hepatic vein. And this is the accessory inferior right hepatic vein. So this drains segments 6 and 7 directly into IVC. Important if it is greater than 4 mm, inferior RHV, it must be preserved and separately anastomosed to recipient IVC in case of liver donors. And on coronal CT scans, we can measure the inferior right hepatic vein distance from the RHV. This helps in surgical planning in cases of liver donor and radiological. Next, we come to the portal vein and variants. So the portal vein is formed by the union of the superior mesenteric vein and the splenomesenteric trunk. This is the splenic vein. This is the inferior mesenteric vein. Both are joining together to form the splenomesenteric trunk. This, along with the superior mesenteric vein, they unite to form the main portal vein. So this is again a VR image. And we can see that the main portal vein is dividing into the right and the left portal vein branch. So in the hepatic hilum, the conventional portal bifurcation found in 70 to 80% of the cases presents a right branch 1 to 3 centimeter long, then splitting into the anterior and the posterior sectoral branches, and a left branch with the portion horizontal at first and then a concave umbilical portion in front in the direction of the round ligament. This is again just a schematic without the arrows showing the same anatomy. So this is the classic portal vein branching pattern or type A. So for the portal vein branching system, we have the Cheng and the Nakamura classifications, almost the same. Here we are using the Nakamura et al. Classifications, where we can see that at the porta hepatis, the main portal vein, it bifurcates, and this is the right portal vein, and it gives off branches at variable length. And this is the right posterior portal vein branch. This is the right anterior portal vein branch, and the 6 and the 7 arising from the RPPV. The RAPV gives rise to the 5 and the 8. And this is the left portal vein. It is ascending along the falciform ligament, which is nothing but a peritoneal fold seen in the umbilical fissure. And this is giving rise to the 2, 3, 4, and 4B segments. This is another. So type A was a conventional branching pattern which we saw of the portal vein. This is type B, where there's a trifurcation with this is a schematic diagram. Again, here it is showing that this is the main portal vein is trifurcating and giving off the right posterior portal vein branch, right anterior sectoral portal vein branch, and this is the left portal vein branch. This is found in approximately 10 to 15% of the cases. So this is this is the type A which we saw, the typical branching pattern. This is type B. The blue arrows are marking the right anterior portal vein branch. This is the type B, where there is a trifurcation into the left, the RA anterior branch, and this is the right anterior, and this is the right posterior portal vein branch. So this third image shows the type C variant, where the right anterior portal vein branch is arising from the proximal or the extrahepatic left portal vein. And this is another variant, the type D variant, where this is showing that the right anterior portal vein branch is arising from the distal or the intrahepatic left portal vein branch. So these two figures denote the type C and the type D variant. Of course, there are other rare portal vein variants besides the anatomic variants, like we have a separate segment 5 and 8 branches. Left portal branch is sometimes absent, so there is absence of the left lobe, less than 0.3% cases. Right portal vein branch is absent, resulting in the absence of the right lobe. And the left portal branch comes from the right anterior sectoral vein without horizontal segment, found in 0.2 to 0.4% of the cases. Besides the anatomic variants, remember there may be congenital malformations such as agenesis of the portal branches, the portal vein itself, duplication of the portal vein, and the portal vein communicating with the vena cava or the aneurysm of the portal vein. Now we are done with the portal vein and the hepatic venous anatomy, so it will be easier for us to understand the systematic approach to the liver segmentation. So we've seen this figure before. There are 8 liver segments. In the frontal projection, we are not able to see the segment 1 or the caudate lobe of liver, which lies posteriorly. And the segment 4A is divided into segment 4A and 4B. And there are 8 liver segments, and the number of the segments is in a clockwise manner. So this is the portal vein dividing the liver into superior and inferior. And this is the middle hepatic vein dividing into right and left lobe, and this is the left hepatic vein, and this is the right hepatic vein. So we will be following certain steps to understand the segmentation of the liver. So the step 1 is that just locate the hepatic veins and so these are the 3 hepatic veins, the middle, the left, and the right hepatic vein, and just locate the level of the portal vein bifurcation. Next step is we should distinguish the right liver from the left liver. So in the purple disc, we have the right liver. This is the left liver. This is a middle hepatic vein. So above the plane passing by the portal vein bifurcation, the right and left is corresponds to the plane passing by the middle hepatic vein. And below it is determined by the Cantley's line going from the middle of the gallbladder to the left border of the inferior vena cava. So we are done with the right and left lobes. Step 3 is identification of the caudate lobe of the liver, which is this. It is lined by the ligamentum venosum anteriorly and the IVC posteriorly, not seen on a frontal projection because it is lying posteriorly, as we can see. The step 4 is that we are dividing the liver, right liver, into the anterior and the posterior sectors. So above the level of the portal vein bifurcation, here we can see the right hepatic vein. So we can see the right hepatic vein in almost all the sections of the liver. So it is easier to demarcate the segments. Above the portal vein bifurcation, the anterior one is going to be segment 8 and segment 7. At the level of the portal vein, we use segments 5/8 and posterior one as 7/6. And below the level of the portal vein bifurcation, we have the segment 5 anteriorly and the segment 6 anteriorly. The next step is identifying the segment 4. So this is the segment, this is the umbilical fissure. And above this, we see this is the middle hepatic vein. On the medial aspect, we have the segment 4. And here below the portal vein bifurcation, here this is the fissure again. So this is the segment 4B. So above the portal vein bifurcation, it is 4A, and below the portal vein bifurcation, it is known as 4B.
Kathy, you have 5 more minutes.
Yes, I'll just type. So this is the portal vein bifurcation. So this is the sixth and final step, involves the division of the lateral segment of the left hepatic lobe into segments 2 and 3. Above, so it will be on the medial aspect of the umbilical or the umbilical fissure, and above the portal vein bifurcation 2, below will be 3. So we are done with the segments. This is a video to show the portal venous anatomy. Here we can see the portal vein, the 3 hepatic veins. The right hepatic vein is continuing downward, so it is easier for us to understand the division of the right lobe of liver. Coming to the hepatic arterial anatomy, so schematic diagram, this is the celiac trunk giving off the left gastric, the common hepatic artery, and the splenic artery. The common hepatic artery, it gives off the right gastric artery, which anastomosis with the left gastric artery along the lesser curvature. This is the hepatic artery after giving off the gastroduodenal artery branch, the right and the left hepatic. So there's a classification of the hepatic artery variant anatomy. This is the standard anatomy, as I have already discussed. This is the type 2 replaced LHA from the LGA. So this is a left gastric artery. We have a replaced left hepatic artery, whereas the right hepatic artery is arising from the common hepatic artery after giving rise to the gastroduodenal artery. This is the type 3, where we have the replaced right hepatic artery from the SMA. Type 4, 1.3%, where the replaced RHA is from the SMA and the left hepatic artery is from the left gastric artery. Type 5 is the accessory left hepatic artery from the left gastric artery. The 6 is the accessory right hepatic arteries arising from the SMA. Type 7 is accessory RHA and LHA. The type A is accessory right hepatic artery and the accessory LHA or the RHA. And here we have the type 9, where the common hepatic artery is replaced. It has a replaced origin from the superior centric artery. Arterial anatomy, we just skip this one. So these are the VR images and these are the MIP images, all acquired by post-processing the 2D stacked images. So here we can see that the celiac trunk gives off the left gastric, the splenic, and then this gives off the RHA and the left HA, and this is the left gastric artery. Same is seen on the VR images. So these are few hepatic artery variants, few of our cases. Yes, we can see that the celiac trunk is trifurcating into the left gastric artery, splenic artery, and the common hepatic artery. The common hepatic artery. So here we have the replaced left hepatic artery from the gastric artery, and this is the right hepatic artery, and this is the gastroduodenal artery.
2 minutes.
And this is another where we see that the replaced, this is the superior mesenteric artery, and we have the replaced right hepatic artery from the superior mesenteric artery. This is a type 3 variant seen in 7% of the cases. This is again the VR image. We can see this is a common hepatic artery, the left gastric, the splenic, and this is the replaced right hepatic artery as seen by the arrow. This is type 9, which is 1.7% only, where the common hepatic artery we can see is arising from the superior mesenteric artery. So this is the common hepatic artery giving off the gastroduodenal artery, and then further it is dividing into the right and left, and the celiac trunk is dividing into the left gastric artery and the splenic artery. For the biliary anatomy, my colleague Dr. Vineet Mishra will be taking over. Thank you so much for your attention. Thank you.
Good morning to everyone. Thanks, Dr. Swati ma'am, for the excellent presentation.
You will have to hurry up because 20 minutes were total for
Rush through.
because one breathe and then, or are you covering it as a part of
Yes,
your
as
discussion? Okay,
discussion.
then it is fine. Then you have 5 minutes. No problem.
So there are a few various techniques are available for the evaluation of the biliary anatomy. After this intravenous cholangiography, it requires contrast injection, plus the resolution is not great, so it is not preferred. ERCP and intraoperative cholangiography have got wonderful resolution, but these are invasive procedures. So the preferred method is MRCP. It's a non-invasive method which can be done on OPD basis. It requires only 4-hour fasting so that the fluid around the biliary tree is reduced. And also there is a reduction in the peristalsis and hence the motion artifacts. It also promotes the distinction of the gallbladder and the IHBR. There are a few modifications like secreting enhanced MRCP and functional MRCP done after the injection of the hepatobiliary specific contrast agent, but these are not routinely done. MRCP has got slightly poor resolution as compared to the intraoperative cholangiography or the ERCP. So basically MRCP is nothing but is a heavily T2-weighted images. As we can see on the left, this is the normal T2-weighted images. We can see liver, bowel loops, stomach, everything. But in MRCP, these organs are suppressed, giving a black background, and only the static fluid or the slow moving fluid are visualized so that we can visualize the biliarity against the black background. Coming to the normal anatomy, as we know that the biliary drainage system is parallel to the portovenous supply. Segment 8 and 5 form the anterior sectoral duct, which is relatively vertically oriented. Segment 7 and 6 form the posterior sectoral duct, which is relatively horizontally oriented, and it passes posterior to the anterior sectoral duct to open along its medial aspect, forming the right hepatic duct, which is slightly shorter in length as compared to the left hepatic duct. On the left side, normally we find segment 2 and 3 ducts forming a common duct, and then segment 4 duct joins it to form the left hepatic duct. Caudate can drain either into the left hepatic duct or the right hepatic duct. Now, right and left hepatic duct forms the primary biliary conference, and this is the common hepatic duct. Cystic duct joins it to form the CBD. In a non-distended, non-obstructive biliary system, this is how it looks like on the MRCP. Segment 2 and 3 forming the common duct. Then segment 4 joins it to form the left hepatic duct. Horizontally oriented posterior sectoral duct, vertically oriented anterior sectoral duct, and this is the CSD, and this is the gallbladder. Now, if the biliary system is obstructed, we get this kind of picture: vertically oriented right anterior sectoral duct, horizontally oriented posterior sectoral duct, right hepatic duct, left hepatic duct, segment 2, segment 3, and this is segment 4 joining to form the left hepatic duct. This is CSD, CBD, and this is the MPD. Now, there are this kind of picture is seen only in the 55 to 60% of cases. We have got a lot of variations. Few are the common, few are uncommon. Variation can be seen on the right as well as the left-sided biliary system, as well in the cystic duct insertion. There are variation in the GV and pancreatic duct as well. So these are the most common 5 kind of pattern that we see in the right side, the hepatic duct system. This we have already discussed. In type A2, there is common confluence of the right anterior sectoral duct, posterior sectoral duct with the left hepatic duct, giving a trifurcation pattern. This is aberrant right posterior sectoral duct, which passes posterior to the RSD to open into the left hepatic duct. Also, RPSD can open into CSD or into the cystic duct, giving type A4 or A5 respectively. Now, coming to the examples, like this image shows RPSD, which is horizontally oriented, passing posterior to the vertically oriented right intersectoral duct, opening into the left hepatic duct. Another case of the cholecystectomy, again, the RPSD is seen opening into the left hepatic duct after passing posterior to the left hepatic RASD. This is a case in which there is a calculus in the distal CBD. There is RPSD, which is there. RPSD, RASD are forming common confluence with the left hepatic duct, giving a trifurcation pattern. Two more examples of the trifurcation pattern: RPSD, RASD, and left hepatic duct. Again, horizontally oriented RPSD and RASD forming common confluence with the left hepatic duct, giving a trifurcation pattern. This is another variation in which right posterior sectoral duct is opening into CSD just below the confluence of the RASD and the left hepatic duct. This is a very important variation in which we can, in this image, you can see the aberrant right posterior sectoral duct opening to the CSD along with the cystic duct. And this is a very important variation, as the surgeon might get disoriented and he may inadvertently ligate or section this aberrant duct, resulting in complications. In this image, we can see there is an accessory duct which is arising from the segment 7 and is opening into CSD below the confluence which is found by the rest of the right-sided segments in the left hepatic duct. This is a case of the pancreatic head mass with resultant upstream dilation of the biliary system. There is an accessory duct arising from the segment 6, opening into the CSD just below the primary biliary confluence. Can I take 2 minutes? Now, it's a 7th aberrant duct from the segment 7, opening into the left hepatic duct. Now, coming to the left side system, this particular pattern, the normal pattern, we have already discussed. Now, instead of segment 3 and 2 forming a common duct, segment 4 and 3 forms a common duct and fuses with segment 2 to form the left hepatic duct. The left-sided ducts may also form a common confluence and then form the LSD, and also they might directly confluence with the right-sided hepatic duct to form a quadrivarication pattern. Now, this is a variant in which segment 3 and 4 are forming a common duct, and then segment 2 is joining the left hepatic duct. Another variation in which the segment 3 is joining the right hepatic duct, and the primary biliary confluence is formed by the right hepatic duct and the segment 2 and 4. This is an aberrant duct arising from the segment 6, which is opening into the CSD. Now, there are a lot of variation of the cystic insertion as well. This is the common pattern in which the cystic duct is opening along the lateral aspect of the CSD. It might have a spiral insertion. It may be inserted anteriorly or posteriorly. It may insert in the CSD proximally, or it may insert lower down in the lower 1/3. And lower 1/3, it may have medial insertion or the lateral insertion. And at times we see cystic duct opening into the right hepatic duct. As in this case, this is a cholelithiasis, and the cystic duct is quite short in length and is opening into the dilated right hepatic duct. In this case, there is high insertion of cystic duct along the CSD or at the primary biliary confluence, better appreciated in this axial T2-weighted images. There is the cystic duct which is opening low into the common duct along the lateral aspect. There is also trifurcation pattern cranially. This is the right aberrant posterior sectoral duct. Then the cystic duct is coming down and is opening at the distal CBD in the region of the ampulla of Vater. There is dilated MPD with calculi within it. Now, often we come across the complex biliary anatomical variant in which the pattern doesn't follow a particular systemic, which has been given by Huan. As seen here, the segment 2 and 3 are confluencing with each other to form a common duct. And then these again are joining the right posterior sectoral duct to form this duct. And this duct is joining with the right anterior sectoral duct to form the primary biliary confluence. The segment 4 is opening into the common hepatic duct. There are a lot of variation of the gallbladder as well. This is a small gallbladder which is seen in the intrahepatic region with calculi within it. Then there is pancreatic divisum which opens into the MPD, into the minor papilla. So we need to be aware of we should be familiar with the segmental hepatic biliary anatomy, as it is essential for the both staging and the localization of intrahepatic tumors and bile duct tumors like cholelithiasis. And we need to have a better idea of biliary anatomy before we proceed with any hepatic surgical procedures or biliary intervention. Thanks for your kind attention.
So while it is uploading, when the right posterior joins above, we say it is joining the left hepatic.
Yes.
and right anterior we say is the confluence. But when the other way happens, then you said that right posterior is joining the common hepatic.
Yes, sir.
But if I remember correctly,
So I will label as 3 and 3B at some places. Like if it is joining, some say that if it's joining the left hepatic duct, and above the somewhere higher in the level, then it is called like aberrant right perceptual duct. And if it is confluenced somewhat below the higher level, that is called as right posterior septal opening into the
but
CS.
can you make that out on the image?
Sure.
Because according to the Japanese philosophy, Dr. Namish may correct me if I am wrong, the first point where a right and left duct joins is called the confluence.
Yes, sir.
So when the right posterior is joining the left duct, after that it becomes the common hepatic duct.
Hmm.
And then the right anterior is joining the common hepatic duct.
This is what
नहीं वो शायद आपका stop हो गया शायद. It's okay. It's okay. ठीक है रहने दीजिए. Let Dr. Manpreet continue.
you're asking about this variant, sir?
In one of the MR images, you showed that the right posterior is joining the left.
This one, sir?
And we say that CST starts when the right anterior joins, which is below that.
Yes, sir.
On the other hand, when right posterior joins below the joining of right anterior and left, then we say that that is the confluence. So
About this, sir, this is the anterior sectoral duct.
what is the confluence? Where all three ducts have joined, or where first right and first left have joined?
This first right anterior sectoral with the left hepatic duct, sir.
Anterior sector or any with the left is the confluence.
I'm not very sure. I think it's most probably
With the left.
right
Anyway,
anterior.
that is semantics, but more important is to be aware of these anomalies, and especially the right posterior joining below the joining of right anterior and left is of importance during the cholecystectomy, where it will be running in the gallbladder bed and Calot's triangle and can be mistaken for the cystic duct. Manpreet.
Good morning, everyone. I'm Dr. Manpreet Uppal. So currently we got a perspective from the radiologist point of view about what normal anatomy is like. As a surgeon, would just like to highlight how important it is to very carefully read the anatomy, see the CTs and MRs before planning a surgery. So this is a patient who came to us with a bile duct injury. If you look at her anatomy, first of all, there is a variation, aberrant anatomy, where the right anterior duct is joining into the left duct. However, you can see a common, over here, you can see a common channel duct, which is present. So initially, this was reported as a type 2 injury. But if you see carefully, this common channel is inside the liver. So when we opened the patient, there was no bile duct seen outside the liver. Thankfully, we had a PTBD in situ, which we had to use. We had to do a coring of the liver to be able to reach the duct, which we had, again, was very difficult to do. So a part of the liver had to be resected just to be able to reach the ducts, which were intrahepatic. So it is very important as a surgeon to see the anatomy before planning a surgery, because sometimes what is reported as type 2 might be actually a type 4 injury, like it was here. Second anatomy that I would like to discuss is something which we as GI surgeons face commonly, confusion. One of the case we see commonly is EHPVO, extrahepatic portal vein obstruction. Now that is confused commonly with cirrhosis of the liver. The findings in cirrhosis of the liver would be an irregular liver margin, caudate hypertrophy, and fissural widening. Some of the findings in EHPVO, which I am showing here, is there is sometimes a fissural widening with atrophy of the left system and hypertrophy of the right system. Because of this particular finding, this is often reported as a cirrhosis of the liver. So we ourselves need to be aware of these variations and carefully see them before interpreting the CTs or the MRs. I have a particle that I think, so just to show that
Yeah.
as a surgeon, it is important to read our own CTs or MRs to be aware of how to interpret them so that we don't miss any findings.
Yeah, read our own images along with the radiologists. Any other faculty? We have a few minutes. Any other faculty would like to make any comment? Dr. Namish, would you like to add anything? Sudeep? So for the students who are watching or who will be watching these proceedings, these anomalies are very, very important. Some anomalies which are intrahepatic are important from the point of view of liver resection, and some anomalies which are extrahepatic in the Galois triangle are important from the point of view of cholecystectomy. And as Dr. Vineet did mention, just for repeating, that the so-called normal biliary anatomy is present in only around 60% of people. So as many as 40% of patients will have some or the other variation, and it's very, very important to study the images very carefully and very diligently, and be aware of these anomalies in advance rather than encounter them during the surgery and then have problems. So we'll proceed with the anatomy of the liver, and the next presenter is Dr. Sudeep. Nana, you would like to? Sorry.
Good morning, everyone. So we'll proceed with the next session, and the presenter will be Dr. Sudeep Banerjee, sir, who's the head of the department of the hepatopancreatico-biliary surgery at Tata Memorial Center, Kolkata. And the discussers will be Namish, sir, who's the chief and director of the Center of Digestive Sciences, Mahatma Gandhi Medical College and Hospital, Jaipur. And Siddiqui, sir, who's the director of the liver transplant and HPB, Max Super Speciality, Lucknow.
So before Sudeep starts, I would like to add that Dr. Namish, who was earlier the chief of liver transplant program at the prestigious Sir Ganga Ram Hospital in New Delhi, a few years ago accepted our invitation to join our team. And after his joining the Mahatma Gandhi Medical College and Hospital, our liver transplant program got a boost. And now we are performing on an average 4 to 5 liver transplants every month, including various difficult situations where a living donor liver transplant is done. Sudeep.
Backup laptop, no? If it doesn't work. We have done this, but it doesn't work. We have to backup laptop. नहीं सर हो जाएगा सर नहीं तो खोलो ना यार अरे बैटरी का प्रॉब्लम है डोंट ओपन दिस बंद हो गया यार चल रहा था बंद हो गया नहीं वो चल रहा था ही वही ओपन है इसमें ठीक प्लीज डोंट ओपन दिस प्लीज डोंट ओपन just give me one it doesn't work then I will
there's any problem, we can do Dr. Deepak Chabra's lecture first.
Okay, sir, that is.
In the meantime, you
Yeah,
can
I'll
sit.
show you.
Dr. Deepak?
Don't open this, sir.
Oh, yeah.
Hi, good morning, sir. Am I audible?
Yes, yes. Just. Are you
Yeah,
okay?
no, Dr. Deepak Chabra.
Okay.
Thank you, sir.
So while Sudeep is setting up his presentation, maybe we can have yours first.
Sure, sir.
Dr. Deepak Chabra. Dr. Sandeep and Dr. Nikhil.
Just give me a go ahead, sir, when I can start.
Yeah, so Dr. Deepak Chabra is GI and HPB surgeon at Lilavati Hospital in Mumbai, and again, because of the recent Indigo issues, he could not travel, so he will be making his presentation online. And the discussers will be Dr. Sandeep Jain from Jaipur and Dr. Nikhil Bansal, who is my colleague in interventional radiology at the Mahatma Gandhi Hospital. Deepak, please.
Thank you so much, sir. At the outset, I would like to congratulate Professor V.K. Kapoor and his entire team of JSF for this continuous medical update and enlightening all the students as well as all the practicing surgeons about various different topics. I've been associated with you guys for the last 4 and 5 years. And thank you so much for the opportunity once again. Today, Dr. Kapoor has entrusted me with surgical anatomy of liver resections, and that is specifically dealing with hepatic artery and portal vein. Part of my talk has already been covered in the surgical anatomy of the radiologist view, and I will try to give you a slight different perspective because I understand that these are all overlapping zones, like how the liver has overlapping territories of the hepatic arteries and the portal veins. So let me begin with the talk that when I, as a surgeon, when I look at surgical anatomy, I am looking at what is it for me as a surgeon, what are the implications during the surgery. So we are looking as HPB surgeons, we are looking for segmental resections and segmental oriented surgeries. We are looking at vascular control during the liver surgeries. We are looking at the pre-operative planning, which again, as a radiologist and a surgeon sit together as a team to plan. And we form a roadmap for making liver resections, especially in the setting if we need some kind of a portal vein embolization or maybe sometimes the ALPS procedures. So when I look at the vascular anatomy, I look at 3 different levels of complexes. The first is the conventional level, where we talk about vascular anatomy as a common clinical language. And this common clinical language has been highlighted by Professor Claude Cuno, and our earlier speaker has given the beautiful introduction of what the anatomy is, so I won't dwell into it. I talk about the third level, which is the vascular anatomy for the anatomist. And when I say vascular anatomy for the anatomist, we are talking about the territories which are second order and beyond. You will find details of it in HPB surgeries, but we are slowly coming to the third level, which is not only the academic, but I would say more complex level, which is towards the China, towards the Japan and the Korea, when we are doing monosegmentectomies and subsegmental resections. And I'll come to it. But my talk will purely concentrate on the second level of complexity, which is the surgical level, which as surgeons, we talk about the vascular anatomy, and which talks about the hepatic artery, the portal vein, hepatic veins. And I will restrict my talk to hepatic artery and the portal vein as the topic has been entrusted to me. Why are we talking about that? Because we need to do liver resections in general, but we need to plan specific resections for HCCs, for colorectal metastasis and transplants. Now, what is different? For HCCs, we are looking at specific portal vein territories. For colorectal metastasis, we are looking at preserving the liver of as much as possible. And one of the discussants in the group, Professor Naimesh Mehta, is one who's doing the transplant. It's a very complex, challenging situation to sit back and read your anatomy before execution of a liver transplant. So this brings us to the concepts of what is called as the plates and the gates, because this involves technical approaches where we need to go into the Glisonian pedicles, and I will slowly talk to you when I deal with a part of the portal vein anatomy there. So anatomic relationship. Now as surgeons, the HPB surgeons, we are more looking into variations of the arterial anatomy when we are doing procedures apart from the liver. Not that it's not very important from the liver anatomy, because most of the dissection is extrahepatic, and that's what the advantage of the hepatic arteries that give us over here. So if you look at these variations, the type 1 is the common, which has already been discussed. The type 2 is the left hepatic artery, either it's accessory or the right. The type 3As is the right hepatic artery, which is either accessory or replaced. The type 4As are accessory hepatic arteries arising separately. The type 4Bs is separate right and the right replaced right hepatic arteries and the replaced left hepatic arteries, where the type 5 is the common hepatic artery. The good part about the arterial relationships when it is compared to the liver is the hepatic artery usually divides first, followed by the portal vein, which creates a long extrahepatic course for the arterial branches, which is important to consider during liver surgeries. As liver surgeons, whenever we are resecting the liver, we are probably never looking at intrahepatic arterial anatomy. We are more concentrated on the extrahepatic arterial anatomy. So from a practical standpoint, I think the CT scan today, with its conventional imaging as well as the volume rendered imaging, gives us beautiful images, and we are very well aware of the variations of the arterial anatomy. So that becomes important, especially when you're looking at major liver resections, more than 2 segment resections or monosegmental resections. The diagrams or the surgical photographs typically show you how we would isolate the portal vein, the hepatic arteries, as well as the bile ducts. Just a technical tip, we would use the red loops for the red vessels, for the arterials, and the blue loops for the venous vessels, and yellow loops for the bile ducts. So relatively extrahepatic dissections. The complexity comes when we are dealing with the portal venous system. If you see the portal trunk enters the hepatic pedicle obliquely at the top, goes slightly right, and then again forward. This is the conventional portal bifurcation, which is in case of 70 to 80%. Now, if you look at these photographs, which was also shown earlier on, the right branch 1 to 3 centimeters long, and then splitting into 2 anterior and posterior sectoral branches. And this is actually what I am trying to make everybody aware, that when you look at the liver, you have to close your eyes and think of as a 3-dimensional anatomy. Only then you will be able to successfully perform a liver resection. This is the complex diagram that you see on the right side, whereas on the left side, you see that the left branch actually comes forward as a horizontal portion into the concave portion, which is the umbilical portion, comes in front, which goes into the falciform ligament. And then there is a direction which goes to the segment 4, the segment 2, and the segment 3. Now, look at the portal vein variations. This has again been discussed, but I will quickly recap on this. The first one, A, is the right or the normal portal vein branching pattern. The B pattern is the portal trifurcation. Basically, it's a separate origin of the right anterior portal vein. Type C is the right anterior portal vein branch coming actually from the left. The type D is the right posterior portal vein having an early branching from the portal vein, which actually is a very, very favorable anatomy for the liver surgeons, because we can pick up the right posterior pedicle much earlier, and it makes the dissection a little more easier for us. For students who are going through that, Nakamura and Cheng have already classified these. Basically, they are all the same, except for the Cheng 4 is Cheng 4 and others. I would not go into too much of detail. It has already been discussed in the earlier lecture. When we look at the portal vein patterns of the right posterior sector, there are again various differentials that you can have, something like, which is the arch-like anatomy of the right posterior sectoral. In the second figure, you see that there are divisions of the right posterior sectoral, which is going separately to segment 6 and segment 7. You have an accessories portal branching. You have segment 5 and 6 together in from the posterior portal. So there are various differentials that come into it. Now, the problem comes is how much can you identify all of these during your routine course of practice? Modal anatomy, the trifurcation, the type 3 or the Z type, and the right anterior sectoral, as well as the quadrification. I will not go into details covered already in the first lecture. I want you to pay attention to this particular slide, that this is the typical slide that we will see in our books like Bloomgart or any other HPB books, or for that matter, any other GI, surgical gastroenterology books. When you rotate the liver slightly, you start realizing that what you see, the segment 5 and 8 over here, and segment 7 and 6, which is lateral to this, it's not actually lateral, they are behind. So if you see the 5 and 8 are more anteriorly, the 7 and 6 are more posteriorly, which makes you understand that the right posterior portal vein has to dip down backwards and slightly in a 30 or 40 degrees tilt to be able to supply these particular sectors. When you look at a modular 3D anatomy, this is how the portal vein would look like. You have the right anterior sectoral, you have the right posterior sectoral, and when you look at radiological VR images, this is the complex tree that you get, and you are sometimes lost in this jargon of spider web as to which branch are you actually dealing with. I think this figure gives you a beautiful idea of how our liver anatomy has developed and how you will understand what's happening to the liver. So if you look at the figure in the center, imagine these to be as 3 boxes. The liver is slightly rotated and curved to the right, and it's also twisted like how you would kind of fold a particular paper. So when you look at that, the left part of the liver is slightly front, the right part of the liver or one of the sector goes posteriorly behind, and the pink block, which you actually is the posterior sector, is pushed backwards. So if you see all these 3 diagrams together, you will be able to exactly understand as to what is happening in the embryological development of the liver to understand what's happening to the portal vein. Imagine these 2 figures as 2 balloons, that you have the top balloon as the right anterior sector and the bottom one as the posterior sector. Now you know that you're twisting the balloons, you're bringing one balloon forward and you're taking the second backwards. That is where you realize that the right anterior portal vein is actually coming upwards, the right posterior sectoral vein is actually dipping downwards. And from there, because you have 2 monosegments, that segment 7 and 6, you will have one draining anteriorly, one draining posteriorly. And this is exactly what you need to correlate with your radiologist when you sit back on your consoles to check which is the segment which is draining well. This is an extended diagram of the same figure, giving you the entire structure of the portal vein as to how the anterior sectoral portal vein comes and the posterior sectoral portal vein dips down and then has a branch supply to the segment 6 and the segment 7, the blue ones to segment 5, and the ones which is going behind is to segment 8. So you have to literally close your eyes. Now, if you have to actually look into an anatomy perspective, when you're doing surgical anatomy, nowadays, a lot of surgeons are getting into AI generated models on their robots as well as the laparoscopic images. You will see a difference between the CT scan as well as the ultrasound. What you see in the CT scan may be very different in the ultrasound imaging. There can be a separate topic kept on the intraoperative ultrasound imaging, which can actually beautifully highlight of how you need to evaluate your intraoperative ultrasound pictures as a surgeon, because from a radiological perspective, it is very different, and from a surgical perspective, it is very different. So this is what I am trying to tell you, that this is what you look at it as a liver when you are opening the abdomen. And this is when you dissect the porta. You basically lifted up the liver and dissected the porta, but this is when you resect. So unless and until you have a 3 dimensions of the anatomy, you will never be able to get to your portal veins, because what you deal with in the most of the liver surgeries, 50% of the times, you are actually at the portal bifurcation and the portal systems for your liver resection. So more than the hepatic veins, I would put a more importance to these portal venous system. Mind you, we always forget that there is a caudate lobe which is also draining into the portal veins, and you will have at least 2 or 3 caudate veins which are actually draining into the portal veins. You can sometimes make them out in the scans. This is a beautiful anatomical diagram which shows you at least there are 2 or 3 which combinedly gets into the segment 1, or which is now separated as segment 1 and 9, the spigal lobe. Okay, I will not dwell on the biliary anatomy, but a word of caution that there can be variations, but the biliary anatomy generally would follow the Gleasonian pedicles along with the portal vein. That brings me to the concept of Gleasonian pedicles. Now, what you see, the hepatoduodenal ligament, the fibrous tissue, whatever one may call it, these are the Gleasonian pedicles. This is nothing but Walloin sheath, or dense connective fibrous tissue, which is engulfing the hepatic artery, the portal vein, as well as the biliary ductal system, which has been way back determined by Cuno and other colleagues way back in 1950s and 60s. Now, if you look at that, there is also a concept which brings me to a concept of what is called as the hepatic plates, or the anatomical landmarks of the liver, which is the plate. Now, what is this? This is basically, there are 4 anatomical landmarks. That's the cystic plate, the hilar plate, the arranchus plate, and the umbilical plate, where actually the Gleasonian pedicles is in contact with the undersurface of the liver. So if I have to show it to you separately, this is the sketch of the anatomy of the plate system. That is the cystic plate, which is above the gallbladder, and the the hilar plate, which is above the biliary confluence at the base of the quadrate lobe, and then the umbilical plate, and you see the umbilical portion of the portal vein. And then there is an obliterated umbilical vein, which goes way back towards the left side of the hepatic vein, which is the Ranchus ligament. Now, that brings us to the concept of why am I dealing with this kind of anatomy, and why is Professor V.K. Kapoor very rightly given this topic for discussion for surgical colleagues, is because most of our time goes into isolating these pedicles. Way back in 1990s, Ken Takasaki from Japan has shown us the extrafacial approach, which is looping up the entire system. But there are three methods to approach this portal pedicle. One is the intrafacial approach, where you open the Glisonian pedicles, the one in A, and isolate every structure or every tubular structure by its origin. The second is the extrafacial approach, where you engulf the entire Glisonian pedicle, which is what Ken Takasaki has proposed. And then the extrafacial transfissural approach, that means you may make some hepatotomies or go through the fissure and then approach into those particular portal pedicles. Now, which also brings us to the recent concept in 2017 by Professor Sugioka, again from Japan. These concepts bring us to a much more visionary ideas of how to go about liver resection. What you see in red over here is actually the Linacs capsule of the liver. This Linacs capsule can be considered as a wallpaper in your rooms and a cover on your books. That means it is only going onto the liver parenchyma. Whatever is dipping into the liver parenchyma is actually dipping this particular membrane inside along with it. That's why you see all the red lines along all the vascular pedicles. The dark green line is basically the Glisonian sheath, and the place where the Glisonian sheath actually gets in touch with the Linacs capsule as well as in the undersurface of the liver is where it forms some dense fibrous condensation, which is nothing but the plates of the liver. Now, this also brings us to the new concept that there are certain points of entry which are called as the gates. These become the strategic point of entries, which are actually some natural gaps between the Linac capsule and either the cystic plate or some areas of the Glisonian capsule, during which a precise dissection can be done. So on the concept of this Glisonian pedicles, Glisonian capsules, as well as the Linacs capsule, we have come to a newer concept in the liver anatomy.
Deepak, we have 5 more minutes, please.
Yes, sir. I should be able to finish up that. So we are coming into the concept of the liver anatomy, which talks about the gates, and we are talking about the gates again in a clockwise manner: the gate 1, the gate 2, the gate 3, the gate 4, gate 5, and gate 6. We have about 6 gates on the basis of those 4 anatomical landmarks which have been proposed into the liver surgery. This is, if you look at the diagram on the right side, A is what is talking about going into the Glisonian pedicle and isolating all the tubular structures. B is the one where you engulf the entire pedicle on the left-hand side. C is you do go through an intrafissural approach on and lift it up through the gate 5. There's the D, which again, you're looking at a different gated aspect. So on the right side, if you have to see, you're going from the gate 6 or gate 5 to gate 6, you're going from gate 5 to gate 4 to lift up your pedicles, where your opposite traction opens up the gates. That means you have retractors which are retracting the liver, and your assistant, or for that matter, an external tourniquet is actually pulling the liver down, which then opens up like a book. There are also a concept called as anchors. That means they are thin cord-like structures which are found around the Glisonian pedicles. And I will show this to you in a short video where these are nothing but a smaller fibrous condensation between the Glisonian capsule and the liver, which can sometimes harbor a small biliary ductule. So quickly, if you have to isolate the extrahepatic Glisonian pedicles in the left liver, you bring the lung ligament down or the falciform down. That exposes your gate 2, and you put your mixture across or your instrument across and come across again at the gate 1, which will isolate your pedicles to the segments 2 and 3. Similar thing, if you want to isolate the Glisonian pedicles on the right side of the liver, you go from the gate 5 and come out at the gate 4, which will isolate your anterior sectoral pedicles. If you have got to go to a posterior sectoral pedicles, you go from gate 5 towards the gate 6, and that is gate 1C, which actually is going to the caudate lobe. So this is what the intraoperative figure looks like. And I will give you a small video again, which is from the presentation of Professor Sugioka. It is available online in the surgical gastroenterology. Full credits to him. And this is exactly what it is. So the first thing that you start with what is called as a cystic plate cholecystectomy. When I say a cystic plate cholecystectomy, it means that unlike the routine cholecystectomy, if anyone has seen Professor Shastri's yesterday's talk on surgical anatomy, the keynote lecture, he has also shown the gallbladder. And if you actually carefully see the laparoscopic cholecystectomy, you will find a defect on the plate when you are bringing down the gallbladder. You actually leave this plate on the gallbladder. So you basically separate it at the base of the liver, and you will see that Professor Sugioka here is actually tearing the cystic plate apart or peeling it apart from the surface of the liver to understand exactly what is the cystic. This is exactly what I'm talking about, that he's peeling the cystic plate from the liver and not actually going within that particular fibrous tissue. So once you peel that off, you will actually directly come to your anterior glyconian pedicle. And this is where a little bit of bipolar dissection you do. You lower the hilar plate together along with it. And that is when you come to an opening, a small between the Linnaeus capsule and the Glisonian. This is the anchor that I was talking about, which can have small biliary ductules. This is the gate 5. And from the gate 5, if you put in your mixture and the instrument, and if you have lowered the hilar plate well, you are actually directly, that's the gate 4, where the mixture is coming out. You loop it. So from your gate 5 to gate 4, you have actually looped the anterior pedicle for the right lobe of the liver. Cystic plate is down. Now, for the posterior gate, you are identifying the anatomical landmark of Rouvier sulcus, and you are going down towards the caudate where you isolate the G1C, which is actually opening up your gate 6. So you have already isolated gate 5, you put your mixture to gate 5 to gate 6, and you've isolated the posterior pedicle. The same thing that you do for the left-sided Grisonian pedicle is for isolation of your segment 2 and segment 3. You open the lesser omentum, you identify, and this is what the Aranches plate is, which goes on the undersurface of the liver and above the caudate. You are actually opening the gate 1 there. Once you have opened the gate 1 there, you get the round ligament down, and that's where you will have gates 2 and gates 3. So once you have this particular direction, you go towards your left, towards your gate 1. So when you are going from gate 2 to gate 1, you are isolating only the segment 2 and the 3 pedicles, not the 4 this time. So this is perfect for a left lateral sectionectomy. If you have to then isolate the segment 4, which is the medial Glisonian pedicle, you have already opened the gate 3. You go downwards towards your hilum from gate 2 to gate 3, and that's what isolates your segment 4 pedicle as well. Now, if you're going for a left hepatectomy, you now know that you have already opened up the gate 3. You don't need to go to the gate 2 at all. You are directly going to gate 1, and that isolates your entire left hepatic pedicle. It's basically that we have been doing these surgeries and these particular dissections way back, but it's just that it's the newer concept of how you can define anatomically by way of gates. So I will leave you with this last slide, Professor Kapoor, that this is the anatomy that depicts about the gates. The 4 anatomical landmarks, that's a cystic plate, your hilar plate, Aranches ligamentum, as well as your round ligament, which is the umbilical plate. And you have these 6 gates from anti-clockwise, from gate 1, 2, 3, 4, 5, and 6, which actually makes your anatomy and liver resections much more stronger. I hope I could do justice to my presentation, and I would be happy to take any questions and maybe some discussions from our discussants there. Thank you, Professor Kapoor. I hope I am in time.
Thank you. Thank you, Deepak. Thank you. Sandeep? Mic, Sandeep, please take the mic.
Thank you, Dr. Deepak. It was a very excellent presentation. I just want to add something about the atrophy-hypertrophy complex and the anatomy, the change in anatomy in that particular situation. So can you please put some light on that also because there are many situations in complex liver surgeries where because of the atrophy-hypertrophy complex, everything is rotated in a particular way.
Yes. So I think that is one of the topics that I thought we will leave it for discussion on purpose, because that's where, as I said, I mentioned about in my surgical anatomy that we have to also look at the planning or the pre-operative planning, and when we have portal vein embolization. So I have not touched on the topic of the hilar cholangiocarcinomas for the sake that we were dealing only with surgical anatomy of the liver resections. But yes, these atrophy-hypertrophy complexes do come in a situation where you have a tumor which is already kind of engulfing one of the portal veins, or you are actually doing something like a portal vein embolization. So your anatomy totally changes in a concept, because depending upon what lobe is atrophied, you have a segmental hypertrophy of that particular lobe. But when you are still looking at the hypertrophy of that particular lobe, it is just that your anatomy changes slightly on the venous images on the CT scan. I think when you are going for a liver resection, the outside or the facial approach or the gated approach, as I said, does not really change, but you will definitely have to take an intraoperative ultrasound guided resection for the livers, keeping your middle hepatic vein. I think the biggest take home message here is that after doing all of this, your entire guide to the liver resections is based on your intrahepatic ultrasound and localization of the middle hepatic vein. Once you have isolated the middle hepatic vein or identified the middle hepatic vein or your intraoperative ultrasound, I think these hypertrophy and atrophy complexes become much more smoother.
Thank you.
Nikhil?
Yes.
So just wanted to, hello.
Yes.
Just wanted to know, in this hypertrophy situations, what is the ideal time you suggest, sir?
Ideal time?
Ideal time for the dissection, sir? For us, it's 4 to 6 weeks. So any suggestions over it, sir?
You mean
No, so
after portal vein
Yes, sir.
generally after a
embolization?
portal vein embolization, yes, generally we don't have clear-cut criterias or well-defined criterias, but you very rightly said that we would generally wait for about 3 to 4 weeks to have a reassessment scan and have our volumetric analysis after we have had clamping or either, I would say, a portal vein embolization in a situation like that. We wouldn't mind repeating 2 or 3 more scans within the interval of 3 to 4 weeks to depend on the hypertrophy and atrophy complex. But generally, as a rule, we would wait for at least 3 weeks.
Thank you.
One point which was mentioned, this is again for students in the audience, which Dr. Swati also mentioned, and which has been an observation by my former colleague, Dr. Richa Lal, a pediatric surgeon at SCPGI Lucknow. Patients with EHPVO, they have this left lateral segment atrophy. We don't know what is the reason or cause, maybe some kind of a portal venous diversion. So that should not make you think that this is cirrhosis, because the key criterion for diagnosis of EHPVO is that the portal vein is not seen, it is replaced by a bunch of collaterals. And she observed that the left lateral segment atrophy is present in a significant proportion of cases. They may also have some derangement, some abnormality of the PT-INR, which again should not make you think that this is cirrhosis. And they may develop transient ascites following an episode of bleed. So these points need to not documented, but these are observations, and I thought I'll repeat that. We still have a few minutes for this session in case anybody would like to. So maybe either Deepak or Sudeep or Dr. Namish can, for the sake of students in the audience, that which are the important anomalies, intrahepatic anomalies, which we should keep in mind when we are doing one of the liver resections, right, left, or left lateral. Sudeep, would you like to comment? Which would be the most important, or the important anomalies which we should carefully look for?
I think the simpler operation, like when we do say left hepatectomy. So we have to be careful about the right posterior sectoral duct joining the left system. So left hepatectomy mostly nowadays done laparoscopic or robotic. We have the use of ICG. So we can use the ICG easily to see the ductal system if there is any doubt. But the safest way is that if the base of the umbilical region is not involved, then staple as lateral as possible. So you just lift it up, and when there is a turn of the portal vein, portal pedicle to the horizontal limb, the vertical limb, there you can staple. So usually the anomalies are inside the Glisonian pedicle. Outside the Glisonian pedicle, there are no anomalies. So that way you can easily safeguard the right posterior sectoral duct, which is joining the left system. If too close to hilum, you might injure it.
Yeah, but that is what I was trying to bring to the notice of students, that agreed that we have intraop ultrasound, we have ICG, but that should not make us subconsciously ignore the preoperative evaluation of the anatomy. And this is a very important point which Dr. Sudeep has mentioned, that if the right posterior sectoral duct is joining the left and you are doing a left hepatectomy, you have to be very, very careful, because that is the duct. And I'm sure the same applies in living donor transplant also.
So can I have one? Can I?
Yes, please.
We have done quite a number of central hepatectomies, and at least 2 patients we had injured the right posterior sectoral duct, and both the patient after maybe 3 months or 4 months disease free, then we had to do a ductal injury in a hepatic resection for cancer is a difficult problem. So we had to do a PTBD, salvage the patient, and then later it was a difficult dissection, but we could do a hepaticogenestomy of the posterior sectoral duct. So there also it is very important that when you take a Grisonian approach to the right anterior pedicle, you should, before applying a clamp or a stapler, it should be 100% sure that there is no, there is no hook or something where the posterior sectoral duct is joining anterior sectoral duct is little high up. And usually the transaction is not complete. It is a partial or lateral transaction with usually strictures of maybe a small bile leak pre-op. So it's best to do a intraop cholangio. Anatomy is definitely very important pre-op, but still step a little far away from the confluence.
Although the theme is liver, but since the extrahepatic biliary anatomy, as I mentioned earlier, concerns laparoscopic cholecystectomy, also I would request my colleague Dr. Ajay to make some comments about these aberrations of the right ductal system, which come in the Calot's triangle or in the gallbladder bed, and how they are important for a surgeon who's doing lap chole, and how one should be careful about them.
But I think it's a very valid, important thing that I think all people who are doing a chole should know that EHPVO is one area where you should not attempt a lap chole. But one area where, as a beginner, for initial, maybe till you have done at least 500 cases, you should not attempt. All senior people sitting here must have burned their hands. And specifically when you get an ultrasound report saying that the portal vein is normal, and on table you find some collaterals, I think it is one devastating area. Second thing is a right duct sitting close to the gallbladder or having an extrahepatic course is one of the most common area where you are likely to have an injury. So we don't get an MR routinely done. So the only way to identify is that it is not the critical view of safety. This was a statement which has been devised by Biju, my colleague, who is headed JITMER. He says critical view of safety is not safe. It is more safe that you stick onto the gallbladder. Don't go away from the gallbladder. That is the only way that you can be safe. So if you think that if you are into a critical view of safety and everything is safe, and there is a right duct which is going onto the gallbladder and sticking onto it, you may definitely injure it and may hamper. So everybody must have. So Dr. Patricia was one of the surgeons, very senior surgeon from SMS Medical College, retired now, and she used to say there are 2 surgeons on this earth. One who has done a bile duct injury and one who will do a bile duct injury. So you can't escape yourself that I have not done, so it will not happen. So it is definitely a risky area.
Yeah, that point actually is now confirmed by published evidence also. My colleague at SGPGI, Dr. Supriya, and we did a survey of surgeons in the country. And if I remember correctly, about 400 surgeons responded, and 86% of those who responded admitted that so far they have had at least one bile duct injury or bile leak. 86%. And in any survey of this kind, which talks of complications, obviously the response rate is lower than what actually it is. And similar are the surveys from other places also. So it is not I would say it is not negligence or mistake on the part of the surgeon. It is an inherent problem of lap chole, and bile duct injuries do occur and will occur in the hands of each and every surgeon at any one point of time. And volume and experience doesn't give you protection against that. There are surgeons who have done thousands of lap choles and still they have had a bile duct injury. They occur even in prestigious, high volume teaching institutions, including AIMS, PGI, Chandigarh, SGPGI and all. And in fact, in some of these places, there have been major biliovascular injuries also requiring major intervention. So I think it's very, very important for anybody who's doing either a lap chole or a liver resection to be aware of these anomalies, to be aware that these anomalies are very, very frequent. In fact, in my book on safe chole, I have said that biliary anatomy is like fingerprint, no two are same. So with that, maybe anybody else?
One more.
Yeah, Sudeep, please.
So, Dr. Deepak, very nice presentation. So, this Glisonian approach is very, very attractive and very safe as well. But one practical thing is that don't be in hurry. So, what we usually do, we set up the CUSA from the beginning. So, if there is any, like we are struggling, we CUSA it on the pedicle, the liver tissue. You can use the setting little effect little more 2+ or 3+, so that the lateral thermal injury is less. You CUSA it and it has to be absolutely smooth. Like you take a right angle, which is blunt, and it should come easily. If it's not coming easily, then don't push. You might injure something there, and then a straightforward surgery will become complicated. Especially the injury will happen in the bile duct, not in other structure.
Yes,
Thank
I think I agree. I agree with Professor Sudeep, the way he's talking about it. Means these are the concept where we need to somehow or the other start doing a little small hepatotomies just at the base of the liver. But even if you keep the CUSA at your routine, because you're going an extra Glisonian, you generally don't tend to injure there because you're outside the Glisonian pedicles. Unless and until you have breached the Glisonian, the chances of injury to the vessels actually and the biliary ductal system increases.
Okay, I think we can move on to the next session, which is surgical anatomy, segments and hepatic veins by Dr. Sudeep Banerjee. And the discussers are Dr. Waliullah Siddiqui, who's at the Sahara Max Hospital in Lucknow, and Dr. Namish Mehta, whom we introduced earlier as the chief of our Digestive Sciences Center at Mahatma Gandhi Medical College and Hospital. Sudeep.
So thank you very much, and sorry for the delay. Thank you, sir, for inviting me for this meeting, the senior colleagues, teachers, and friends. ये कहाँ चला गया रे? Screen is not getting shared again. I'm a little sorry. I will try to finish it fast.
Maybe we can use that time, Dr. Namesh and Waliullah, we can start some discussion while Sudeep is uploading.
Yes, this one.
Dr. Namesh.
This one.
So very interesting discussions we have been having since morning, and one of the points which is important is for the younger surgeons who are initially starting, the need to know the anatomy is very, very important in liver, because liver is technically a friendly organ, but at the same time it is a unforgiving organ. So if you I tell a lot of my trainees that you really need to handle liver with tender love and care. So if you do that, the liver will love you back. So it will open up the gates for you very easily. If you know your anatomy, you respect these anatomy, you respect your tissues and planes. And So you will be able to access these gates without damaging it. Second point is, when you start doing liver resections, you should ideally try with a full anatomical liver resections, and don't try to do difficult complex segmentectomies. Then it might be better off that you may do a non-anatomical. If it is a smaller lesion, then you do a non-anatomical liver resections. Ready? And in the beginning, you may remove a larger tissue, which may be a functional area of the liver, which may not be involved with the tumor. But I think that's the safer way, so that the patient goes home and you don't damage and cause any complications. I think Dr. Sudeep has been able to start the presentation. So started screen. If there are any questions in the group, we will be happy to
Valiullah, you would like
answer
to
that.
say something?
Dr. Waliullah?
Ye le lo.
Excuse me. Yeah, screen shares.
If it's taking time, should we? Not a small presentation.
Yeah, you can please go ahead while Sudeep is putting. Sudeep, आप फिर
हो जाएगा सर, हो जाएगा
हो गया?
No, हो जाएगा. You can, sir, you can.
अच्छा.
No, if it's ready, you start.
No, I think
It's only 5 minutes.
you present, sir.
Okay.
Yeah.
I start.
Okay.
Start the screen sharing.
उनको स्टॉप करना पड़ेगा पहले. बंद कर दिया? Yes.
So hello everyone, very good morning, and thanks to Kapoor sir for inviting us for this dedicated academic feast. So mine is a very short presentation of 6 minutes. I work in Max Hospital, Lucknow, into HPB and liver transplant. Adventitious ligament exposure, usually open, looks a bit difficult. This was a case of segment 1 caudate lobe HCC in a non-cirrhotic liver. So left hepatectomy with caudate excision was planned. But there is a very short video of 6 minutes. I won't exceed my time. So before going on to the mobilization of adventitious ligament and exposure of the left hepatic vein and the middle hepatic vein, we first mobilized the right lobe, dissected the hepatic veins. We have got a Da Vinci robotic system at our place. And then lifting the left liver and mobilizing the hepatoduodenal gastrohepatic ligament, we divided it. It's almost a very unedited video. So division of adventitious ligament exposes the left hepatic vein and the middle hepatic vein junction. And robotically, it's very good view it gives, and you can isolate it very beautifully. So before going to this division, we mobilized the right lobe, we mobilized the left lobe, and we dissected the hepatic veins also superiorly. And after dividing here, we can loop the left hepatic, middle hepatic vein from this side. So robotic gives you an extra advantage of precision, vision, and dexterity. So you can see the left and the middle hepatic vein that can be seen from here. So caudate 1 or caudate lobe lesions are usually difficult, challenging. Its isolation and segment 1 caudectomy is usually associated with a formal hepatectomies. So initial isolated lesions or a wedge resection for a small lesion is fine, but doing a complete segment 1 excision, it has to be a proper hepatectomy along with it. You can even clip and divide the adventious ligament. Sometimes it is vascular, but you can directly divide it as in this case. So this you can see there's a lesion in the segment 1. There's a small lesion in the caudate lobe for which the section was planned. And this is the looping of the left and the middle hepatic vein. So before going to this stage, the hepatic venous dissection was already performed earlier. So the tunnel was already made partially. As sir told just now that you have to be very patient, you have to be slow. You can't, if you do fast and you do some mishappen, it won't be, it will be just unforgiving.
Will you learn a little louder?
So I was just saying that you have to be patient, you have to be slow, and any misadventure at this crucial stage will be unforgiving. So this you can see the lesion in the segment 1, not very clearly visible, but still. That's all. Thank you.
Are we ready?
You can
Sudeep?
proceed.
Yeah, good, good.
Let us see, sir. I have to pray now.
Dr. Sudeep's much awaited presentation
He's now come.
has now come online. I guess, yes, Dr. Sudeep, please start.
Thank you so much again, and thank you for the invitation, senior colleagues, teachers, and friends. So the topic of presentation, what was given to me is surgical anatomy. How to get the whole screen. The surgical anatomy of liver resection, the segments and hepatic vein. Who's the next? So, towards the safe liver resection, there are important prerequisite. One of the most important prerequisite is the early anatomical description and the advancement and refinement of the anatomical knowledge. So, anatomical liver resection not only needed for oncological purpose, it also shown that if you stay in a proper anatomical plane with a good inflow and outflow control, the blood loss is low, bile leak is low, and also if you have a proper liver volume for the FLR, the liver failure rates are also low. We now have on the imaging like CT and MRI, we have the 3D imaging, we have the 3D volumetry, also we have the AI assisted resection plane imaging. So good anatomical knowledge is probably the best for good liver resection. So any liver resection is divided into three things: inflow, segment, and outflow. The anatomical knowledge has already been discussed in previous speaker. We all know that there is Cantley's line where the middle hepatic vein stays, which divides the liver into right and left. Not going into details, this is the right portal fissure where the right vein stays, the left portal fissure where the umbilical portion of the portal vein and the left vein stays. If you see in this image, these are the liver segments already been discussed. If you see in this image, this is a right portal vein embolized liver. You can see that the right liver is dusky, segment 5. There's a tumor in segment 8. This is a 4A, 4B, falciform 2 and 3. When you open the abdomen, you will be not able to see the segment, posterior segments like segment 6 and 7, unless you mobilize the right lobe of liver. Based on the anatomy, liver anatomy, there are liver resections. What I want to highlight here that if you divide the liver in sectors based on the hepatic veins, the posterior sector is around 30%. The anterior sector, which is 5 and 8, between the middle vein and the right vein, is 30%, and the whole left liver is around 30%, caudate is around 10%. So if you are doing a right trisection, so that means you are leaving behind with only 25% of liver. So in that situation is not sufficient, especially in the setting of biliary obstruction or hilar block. Similarly, even if you are doing a right hepatectomy, you are leaving behind 35% of liver, which also may not be sufficient for a hilar block having a bilirubin high bilirubin level, which you need at least 40-45% of liver. And if you have 1-to-1 functional capacity per volume liver, the right liver functions well than the left liver. So if you have 35% of the right liver is functionally better than the 35% of the left liver. That is the reason now in some centers the extended left is better tolerated, because you still have a 30% little more on segment 6 and 7 in major liver resection. The CT been discussed already, as Professor told in the morning, that we have to discuss with the CT in the console along with the radiologist and not only few images. That is very important. 3-level hilar hepatic vein level at the confluence of hepatic vein region, where you can see the variations, the portal venous level, and below that the subhilar level. And this is the portal pedicle, which has already been discussed. This is a short video. You can see that there is a large tumor which is involving the right lobe of liver. It's a little fast. So if you see here, so this is a large tumor which has gone into the IVC through the right inferior hepatic vein. The confluence of veins as you go up, the confluence of veins are free. This is the right vein. This is the middle vein, the forevein, the left vein. As you go down, the middle vein is formed. This is the right portal pedicle, which is involved by the tumor. especially the posterior pedicle, and the tumor has gone into the IVC along the hepatic right inferior hepatic vein. Similarly, one plane is not sufficient. You have to see this in the coronal plane as well. This is the coronal plane CT scan of the same patient. If you see here, sorry, MR, if you see here, the tumor is there mainly in the right side, and it has gone into the IVC. You can see this is the tumor in the IVC, which is below the hepatic vein, just reaching the confluence of renal veins. So this patient was resected around 7 years back with a vena cava resection. The hepatic vein and the IVC should be taken together like hepatic venous IVC complex. The control of right hepatic vein is a very, very common procedure involving many operations, especially commonly performed right hepatectomy. You have to be patient. You have to inform the anesthetist to keep the CVP low, and you will encounter small hepatic veins. You see here, this is a makuchi, weld form. Makuchi is basically a ligament which connects the segment 7 with the segment 1 on the other side of the IVC. You have to divide the makuchi, then only you can enter the plane between the IVC and the right hepatic vein. And the makuchi, often you can put a stapler. You can use modern coagulation devices as well, or often you can use a vascular clamp, divide it and suture it with a proline. After that, you will encounter the right hepatic vein. In this patient, you can see that there is a right inferior hepatic vein also. If you develop the tunnel there, and also from the top. And if you are unable to pass a right angle there because of some adhesions, there may be adhesions because of embolization or infection, then better not to do anything there. You can again always come after the liver split and take the right hepatic vein within the hepatic parenchyma. Or you can use something known as tunneler, what we use in a pancreatic surgery for a portal vein tunnel. You can use a tunneler and go straight in the junction between the middle hepatic vein and the right hepatic vein, rather than trying to encircle it with a right angle. You should not injure the right hepatic vein here. This can lead to major problem. The similar patient you can see here, there is a tumor and the IVC was resected. Middle hepatic vein anatomy needs to be discussed very in details with the radiologist, especially in a setting of transplant as well as in liver resection, where the tumor is close to the middle hepatic vein. There may be margin on the vein, which is now accepted, especially in colorectal liver metastasis. You can have this nice volume rendered image of the veins, where you can see here the middle hepatic vein is as big as the right, maybe a little more. This is a dominant middle hepatic vein, cannot be sacrificed, has to be there in the FLR. And you can see here the multiple 4 veins and 5 veins here. They can join at various levels. It's not in the gallbladder fossa, it can join deep there also. Nakamura classification for 4A we know very well. You know that we are not going into details, but what is important is here that often there is not very often, rarely there is a 3 vein which can go directly into the in the middle vein, taking a part of the left side of the 4A. This vein, if you injure, there definitely will be liver failure in future, because part of the 4A and 3 will be congested. Similarly, the umbilical fissure vein, which has not been discussed by the previous speaker, extremely important. It is there in 51 to 76%. It is not the same vein as the 4A vein. It is a separate vein which takes supply from the 3 and also from the 4B, runs along the falciform fissure and joins usually the left hepatic vein. If the vein is big, if the vein is there, then taking a right liver graft with the middle vein or doing a liver resection with the middle vein might not have big implication on the FLR. So anatomy of the fissural vein is also very, very important. Some situation taken from the middle hepatic vein controversy chapter by Professor S.T. Fan, a fantastic book chapter. You can see here the 2 dominant 8 vein, which has been taken in a left liver graft with the middle vein, and the 8 is dusky. Usually there should not be a problem in this situation because right posterior sector is big. Here also, as I said, that the vein draining 3 as well as 4. So this is the middle vein, this is the right vein. So this will be the plane of transaction of the middle vein, preserving the venous drainage of the left side. using in the right liver graft or a right hepatectomy situation. Umbilical fissure vein, as I told you can clearly see here, this is a tumor not relevant in this patient because this is a straightforward left hepatectomy. You can see 4B vein, part of the 4 vein and part of the 3 vein joining and forming the umbilical fissure. And they also, umbilical vein, sorry. And you can clearly see here the umbilical vein and the 4B vein are the different veins. You can see here they can these white arrows are the communication intrahepatic between the 4 vein and the umbilical vein. These anatomical things are important for liver surgeons and also for liver transplant surgeons. Left lateral sectionectomy. This lady came to us with a rapidly growing FNH, wanted surgery because followed up for 1 year. 4 centimeter tumor has become 7 centimeter. You can see here this patient lady also had an umbilical fissure vein. This is a left vein. It is a straightforward left lateral section. These are the 2 and 3 pedicle. These are the 4B pedicle. You should offer laparoscopic or robotic surgery in this patient. In this picture, you can see here, this is a 2, mobilize the left liver, start on the falciform left side, split a bit. You can get the P3, divide it, you go split further, you will encounter some veins and go directly on the P2 and this is a short video. And you can see here, I have injured the fissural vein here, not important in this patient. You can see this is the left hepatic vein, this is the middle hepatic vein. The fissural vein is joining between the left and middle vein. You can just use the CUSA and just take the middle vein and left hepatic vein and staple it. One important point is there, don't injure the phrenic vein. Often while mobilizing, you are using overzealous, using hook, going a little far towards the medial side, you can injure the left phrenic vein, which joins exactly the same region where the left hepatic vein joins the IVC. Segment 4B5 resection, commonly performed surgery, very, very important. Gallbladder cancer, the landmarks are 4B vein, 5 vein, right anterior portal pedicle, the formation of the middle vein, and you have to, and the 4B pedicle, 4B vein. These are the landmarks. This is a short video. Usually we all know that how to do this operation. We start with the taking of the segment 4B vein, see the demarcation, and then we go deeper on the either side. You can see here, this is the formation of the middle vein or the 5 vein which has been taken. Once you divide the middle vein, you can do little bit of more dissection on the hilar plate. This is a cystic plate which has been dissected off. And once you divide the cystic plate and the middle vein, you can directly go onto the right anterior portal pedicle. Once you go on the right anterior portal pedicle, you take off the segment 5 veins. That will give you demarcation, and then you can do a segment 5 resection. This is anatomical segment 4B5 resection. In this, if you come here, this photo is almost, the resection is almost over. This is the hilar plate, this is the anterior portal pedicle, this is the cystic plate, this is the gallbladder tumor, and this is the posterior portal pedicle. What I want to tell you that in significant portion of patient, you will get some supply from the posterior portal pedicle to the segment 5. We have recently in one conference we have presented, we have gotten around 24% patient, some major pedicle like more than 3 to 4 mm coming from the posterior portal pedicle to the segment 5. This is a classic photo of segment 4B5 excision. It is, look at the boundaries. Here is the falciform, this is the 4B, this is the middle hepatic vein, this is the hilar plate, this is the whole length of the right anterior portal pedicle. You will get 2 or 3 minimum branches to the segment 5. 5 is removed. This is the posterior portal pedicle. This is the origin of the right hepatic vein. This is the complete excision of 4B5. Left hepatectomy, this patient came to us with a HCC. As I was telling you that the base is free, so you can staple up the base. The 4B vein is played, but on the top side, the middle hepatic vein is completely free. The 8 vein joining middle vein, the fissure vein is also there in this patient, and the top side middle hepatic vein is free. You can staple off the left portal pedicle, as I was telling you that go base of the umbilical fissure, staple it, don't come close. You can easily access this, either a Gleasonian pedicle approach, you loop it and then divide, do a little bit parenchymal dissection and take it off. You can do this operation laparoscopic as well. We are using the harmonic here as a single instrument, and you can just slowly do a harmonic lysis. This is a 4B vein which is joining the the middle vein. This is a 4A vein. And later part, you can easily dissect the left hepatic vein still with the harmonic and pass a right angle. We have a fine long right angle curved the skull stores, which is a very good instrument to passing around the veins, also around the portal pedicle. I will take little 16 minutes more. So control of left hepatic vein, you can see here either you staple or you take a control and suture it. Whole length of middle hepatic vein is exposed and the plane is usually oblique. If you don't mobilize the right liver, the middle hepatic plane is usually oblique, not the horizontal plane. Left hepatectomy with S1 in this patient. This is mainly done for perihilar malignant. This patient has a portal vein thrombus. If you see here, the main dominant segment 5 vein, 4 vein is not seen here going up. The tumor abuts the middle vein, but the top portion of the middle vein is free. The 8 joining here. This is the intraoperative photo. We have taken down the lower part of the middle vein and segment 5 is dusky. Doesn't matter in this patient because the left lobe is atrophic and the segment 8 vein is preserved. The top portion of the middle vein is preserved with the patient. So you need not take the middle vein in the specimen. If you carefully see the anatomy where the tumor is there, where you can transect and cross over on the middle vein from the right to left or left to right. Central hepatectomy is a tumor occupying the central lesion, central liver, child A, HPPG 7. The sound will not come, but I will tell you here that this is the Glisonian pedicle approach. We have one portion of transaction is done, hepatitis B, large tumor. This is the anterior portal pedicle is controlled and the middle hepatic vein is controlled. So don't divide the middle hepatic vein now. You do a little bit of transaction on the other plane, that left trisect plane. Otherwise, there will be back bleeding. Keep the control. Don't divide it now. You can divide the anterior sectoral pedicle, do a little bit of CUSA on the transection plane, and come down later and divide the middle vein. This is the division of the anterior sectoral pedicle. Nothing new in this. Right anterior section with middle vein, without middle vein. Ultrasound is a very good tool in Intraop. You can see the tumor here, the big tumor, right vein, left vein, fissural vein. The tumor is removed because of fissural vein, the 4B and the 4 is not dusky. Again, this is a colorectal liver metastasis, large tumor, post-chemo. We have done a Miriam and the volumetry showed that it is safer to do a anterior sectionectomy with the middle vein rather than doing a right hepatectomy. Extra Glisonian pedicle control, you can see the anterior sector is dusky and the division along the plane. So 3D volumetry will give you the transection plane as well as the tumor volume, which operation is safer. Parenchyma preserving is possible. Caudate anatomy already been discussed, not going into the details. It's a difficult anatomy a bit. And if you mobilize caudate from both sides, if you are doing a left hepatectomy or left trisection with a vascular resection, then you cannot mobilize the right lobe of liver. So you have to mobilize the caudate from the left side. You be a little careful on the left hepatic vein junction because here the arrangers will come, don't injure it. And also there will be a bigger vein, little on the cranial part. It can be easily done, especially in the atrophic situation. You will see this photo. This is a tumor here, is atrophic. This patient need a vein excision. The caudate is completely mobilized. The IVC is fully exposed. And the terminal portion, we are just taking it off from the left hepatic vein. The caudate mobilization right side, loop the IVC. We always loop the IVC because if something happens, we can clamp it. And we can also use a traction here. All veins are dissected. This patient also has an inferior vein. The right vein is looped. The smaller vein going to the caudate is dissected off. So you see here, this is the plane is the middle hepatic vein. This will be the bifurcation of portal vein, and this is the IVC. So this is the caudate boundary for the surgeon. Middle hepatic vein, the portal bifurcation, and the IVC. Right hepatectomy with S1 we do for perihilar cholangio. I would just like to show a photo here because what we do here, we usually do a modified type because not necessary to take out the full 4A. You can deviate below and include the caudate. The transection plane will be oblique, not the straight plane. If you see here, this is a video where we have doing for a perihilar, sound is not there, perihilar cholangio, the same patient with a gallbladder neck cancer. the caudate is fully mobilized, the IVC is fully exposed. Now, as when you will be doing the transaction plane will be oblique, coming from the right of the hepatic vein to middle hepatic vein, going to the taking the 4B and taking the caudate. Careful that if there is a replaced left hepatic artery, don't injure it. Another few minutes. So this is the transaction plane, what I was talking about. Right liver is atrophying in this patient. So come like this and then go like this and directly take the caudate along the specimen. In this photo, you can clearly see that the middle hepatic vein forms the caudate roof. The caudate is completely taken out. This is the portal bifurcation, bile duct is excised, and this is the middle hepatic vein, which forms the caudate lobe roof. Right hepatectomy anterior approach, often you have to do if there is a large tumor. Here I want to show that the hepatic vein is pushed, is not involved. This is the cut specimen I did for the academic interest, and you will see not only the big veins like 5 and this is a right vein like 7 and 6. There will be multiple numerous small veins. The total volume may be quite a bit for these small veins entering the vein from the segments. So right hepatectomy, confluence of veins needs to be seen as a vertical view, not as an oblique view. You have to take full control of that. Do an inflow control, see the demarcation line. Most important point in this slide is wide, shallow approach to the hepatic vein. You cannot work on the depth. You have to have a wide approach to the hepatic vein. Here we are using a water jet, and this is the portion we are exposing the middle vein where the 5 veins drain. Then you divide the right anterior portal pedicle, and here the area of segment 8, you can see that this is the middle vein pulsation. The Biliary is already in place. After this, we have to just transact the right hepatic vein. Right hepatic vein, you can take via stapling device. Don't go towards the IVC, stay towards the specimen. Just fire a stapler, easy. Or if you cannot have a stapler, you can just put a clamp. You can put 2 clamps, divide it and suture it with fluoroproline. In this patient, you can see that anterior approach. There are 2 veins, right inferior, and exactly the same, the right vein and the right inferior vein. Extended hepatectomy is a kid with extended hepatectomy. This tumor, the umbilical fissure is involved. The FLR is, in kid usually the FLR is not a problem. The tumor is removed. These are the key steps of the operation. All glycerol pedicle approach. So this is the pedicle, left portal pedicle. This is the anterior portal pedicle. The confluence of veins of the middle vein and then this and the left vein. This is the right hepatic vein, and this is the segment 6 and 7 FLR. So in a left trisection situation, often you may not have the demarcation. You can use the ICG. Important point is that go to the right hepatic vein plane first. You have to see the right hepatic vein origin, stay on the left side of the right hepatic vein origin and dissect and do the transaction. In this patient, we did for perihilar with vascular resection. This is the IVC, this is the right hepatic vein, and patient had an arterial resection, reconstruction. So this is the FLR, what we see in the extended left hepatectomy situation. One more slide. This is taken from Bloomgart. You see that this is a liver tumor occupying the left system. This is the right hepatic vein. The middle hepatic vein has to be sacrificed here. When they did a volumetry, FLR is not sufficient. So they had to recon the middle hepatic vein with a graft directly to the IVC. But in the modern volume manipulation, where you can do a portal vein embolization, give more chemotherapy, you can do a liver volume venous deprivation. Often you may get away with this sort of these sort of things may not be necessary, but often you have to do a middle vein reconstruction in this sort of situation. Thank you very much.
Thank you. Dr. Nemish.
Thank you, Dr. Sudeep, for such a fantastic presentation. And as we already discussed, I think he has already touched on to the salient points for the younger colleagues that when you start, please respect the anatomy. Then liver will respect you back as well.
Caudate lobe, I wanted to ask. So we know that the number is variable, the veins, both portal vein branches and the tributaries and the of the hepatic venous system. So is it possible pre-operatively in a given case to know how many veins you are going to encounter, or you have to keep looking for them when you are? Great.
My boss, Professor Sitaram, used to say that liver resection, good liver resection is a boring surgery. So again, some big veins you will definitely will see. So like the caudate supply, the inflow is mainly from the left portal vein, or the left portal vein, or the junction of the portal veins, the portal pedicle. There definitely you will get at least one or at least two, three bigger one you will able to see, but dissect slowly, and you will see the inflow. For the outflow, there will be a lot of veins, but what we have seen that at least two major veins will be there, and one definitely will come on the cranial side within few centimeters, within 1 or 2 centimeter from the left hepatic vein and Aranchus junction. So top side there will be one vein there will be there. Aranchus you have to be careful, and replaced hepatic artery you have to be careful. So we do a lot of perihilar because of the cancer hospital. So if you have a replaced left hepatic artery, as the transaction plane is oblique, you have to stay below that, because replaced hepatic artery will join there, and you should not injure it. You have to stay below. So dissect of everything, and usually you will get 2 or 3 inflow, at least 2 big outflow, maybe small outflow as well.
The umbilical vein the umbilical vein, which you said is patent in a good number of cases.
Yes, sir.
So that's an advantage, that if you can oncologically preserve it, so you will preserve the supply to some segments. Again, can you identify that? You did show some images where you did identify them pre-operatively.
Exactly, sir. So there is a chapter on there is an article, I could not find it, on shared to me by one of the surgeons, on the umbilical fissure vein. Very, very important. The umbilical fissure vein and the 4B vein, like the 4 superior vein, 4A vein are not same. So if the umbilical fissure vein is there, and if the size of the 4B vein is smaller, so the middle hepatic vein itself is a big presentation. So if you see the middle hepatic vein origin, the 5 and 4B usually the similar size. But if the 4B is smaller, the 5 is bigger, that means the 4B has a separate supply somewhere. So usually if the umbilical fissure vein is big and the 4V vein is smaller, that there's no problem.
So you have been doing, sir, extended hepatectomies. What's your experience with portal vein embolization, hypertrophy?
In perihilar malignant obstruction, don't leave anything for post-op. Post-op liver failure mortality is 100%. So you have to do everything pre-op. So the volume 30%, 40%, 50%, like we know that 25% normal liver, 30% chemo, 30 to 40%, for more than 40% perihilar. But these are for easier surgery, less blood loss, non-diabetic. For example, a patient comes who is 70, diabetic, and diabetic liver degeneration will be less. I am not happy with 40%. My blood loss, say, for maybe 1 liter, the patient will definitely have post-op liver failure. But usually what we aim, if we have at least 10% increase in the liver volume from portal vein embolization, at least 10%, maybe more, but 50%, I am very, very happy.
So have you used?
Because I have seen that even with 45%, we do at least once a month perihilar cholangio. I have seen that even with 45%, there is liver failure in diabetic patient.
So you use only portal vein embolization, or
So far we have used only portal vein embolization. You can use hepatic venous deprivation as well sequentially.
There is a role for functional assessment.
Yes, sir.
That's why many people are doing nowadays. And by using even mebrifone dye, people are doing, or if ICG can be done, like Rajiv Gandhi have got this one. They are using this ICG clearance test also for every, especially cholestatic liver.
Yes, sir. Very, very important point, sir. Thank you, sir. So mebrifone, like functional liver assessment, is nowadays becoming must because of the high morbidity and complication, especially with low, like small FLR, complication rising from small FLR. CMC failure is doing, like as you said that Rajiv Gandhi is doing. We are still not doing, but we are having a mebrifone. We have done in 1 or 2 cases, but validation has not been done so far. But now, what is now, I would say that it is coming up that you have to probably mandatorily assess the functional liver in perihilar malignant obstruction. Not only volume is sufficient.
What the current discussion emphasizes is that don't just look at the volume or the numbers. You need to evaluate the individual or the patient as a whole, look at the comorbidities as well, look at the parameters of how the remnant liver is going to functional, the functional assessment which Dr. Yadav was trying to point out, and in terms of ECOG status, whether you think that your patient is going to withstand a major liver resection. And then based on that, go ahead with liver resections if at all, whenever required. And then apart from this, you also need to, since morning we have been seeing that you also need to be in sync with your radiologist who will guide you. So many a times these people are actually doing a virtual resection. So you can actually, for the younger surgeon, you go ahead to your console with your colleague radiologist, do a virtual resection, see how much part you're going to remove, how much volume with the newer softwares available. You'll be able to assess how much liver you are removing, how much liver you are going to leave behind, how much is the outflow, and based on that you can make your decision whether to go ahead with a lesser resection or you are happy to go ahead with a formal larger trisegmenectomy.
One more point is that, see, patient comes with a, say, jaundice 15 perihilar obstruction. You know that you need patient needs a right liver resection. Left is usually not any big issue. The commoner thing is right, and you do a PTBD. Now, the bilirubin comes down to less than 2, you know that the liver function is preserved. But the problem starts that bilirubin is static 3, 4, 5, not coming down. Then what to do with this patient? If you resect, there is a possibility that even if the bilirubin has come down from 15 to 3, but not further coming down, then there is a problem. Then in these particular situations, functional assessment has immense role. Or you just don't operate the patient. Because bilirubin coming down after like drainage is one good sign that liver function is still quite okay.
That is again a good point of discussion. Actually, we can go on with it because drainage, whether you want to drain the sector which you're going to remove or you want to drain the sector which you're going to leave behind. Yeah, so it's a completely separate topic for discussion.
The concept that left can be done without biliary drainage also.
Absolutely.
So since the theme is anatomy, we will probably leave it for the next year. So before we break for tea, all of you who are watching the JSF, I'm sure many of you are already students of the Jaipur surgical tutorial, but those who are not, Dr. Anand Nagar is here with me. He is the one who has been handling Jaipur surgical tutorial for the last 4 years. So all the students should be grateful to him. And those who have not yet joined, please send a WhatsApp message to Dr. Anand Nagar at +91, which is the India code 95997 30280 +91 95997 30280. We do a once a week academic activity every Saturday morning, 9 to 10 a.m. India time. And from time to time, we do some other activities also, like we did 20 master classes, 2 hours into 2 days each. All those videos are available for you to watch. So before we break for tea, we'll have a group photograph.
Finally. But what happens Mac video generally don't run on
Come. We have some MBBS students as volunteers. These are boys and girls who want to do surgery. So I am giving them as volunteer for time. Take it. Yeah.
Thank you so much.
Mahesh is our photographer. You will not see him in any of the pictures, but he is going to upload all the photos on a Google Drive link. You can download your photos. So.
Our second session after the tea break. The topic will be vascular anatomy of the pancreas, and our presenter will be Dr. Ashir Kaul, Associate Consultant, Santokba Institute of Digestive and Surgical Sciences, Jaipur. The discussers for the session will be Dr. Ajay Sharma Sir, HOD of the Surgical Gastroenterology, Mahatma Gandhi Medical College, Jaipur, and Abhilasha Ma'am, who's from the Department of Anatomy, Mahatma Gandhi Medical College, Jaipur.
Good morning, respected audience and faculty. Before I begin, I would like to thank the organizing team of Jaipur Surgical Festival for inviting me to give this talk. Today, I'll be talking about the vascular anatomy of the pancreas. We'll be beginning with basic anatomical relations and then dive further into the relations of the vessels and their clinical and surgical importance. So as we all know, pancreas is a retroperitoneal organ. It's about 15 centimeters long, weighing 100 grams. It has excretus, exocrine, and endocrine function. At L1, L2 level, that's where the pancreas is, extending transversely from the duodenal sea to the splenic hilum. And as we all commonly know, it's divided into 5 parts: the head, neck, body, tail, and the uncinate process. This image would describe the important peritoneal reflections on the surface of the pancreas. We see the hepatoduodenal ligament here, superiorly and to the right. We have the splenorenal ligament and the phrenicocholic ligament to the left near the splenic hilum. The transverse mesocolon would lie anteriorly on the anterior surface of the pancreas, and inferiorly we would have the mesentery of the small bowel. Posteriorly, if you would cauterize the duodenum during a Whipple's procedure, you would see the posterior relations in that order. First, the inferior vena cava, followed by the left renal vein. Then you will have the aorta, the superior mesenteric artery with its root, the left adrenal, and the left kidney. Coming to the topic of today's discussion is the vascular anatomy of the pancreas. We begin with the arterial supply. So pancreas is mainly supplied by two major trunks of the aorta, the celiac trunk and the superior mesenteric artery. The celiac via the gastroduodenal artery and the splenic artery with their superior pancreaticoduodenal branches and the dorsal pancreatic artery respectively, and from the SMA via the inferior pancreaticoduodenal artery. So coming to the superior supply, it is mainly from the gastroduodenal artery with its two branches, the ASPDA, which is the anterior superior pancreaticoduodenal artery, and the PSPDA. The ASPDA usually is the smaller branch, but it is more consistent in origin. That is, in almost 100% of the cases, you would find it originating from the gastroduodenal artery itself, and it contributes to the anterior pancreaticoduodenal arcade. The PSPDA, on the other hand, is the larger branch, but compared to the ASPDA, it can have a more variable origin. So in cases, you may find it originating directly from the common hepatic artery, the proper hepatic artery, or in 6% cases, even from the replaced right hepatic artery. And the PSPDA would form the posterior pancreaticoduodenal arcade. So this is a dissection picture of a patient who underwent Whipple's procedure at our center. So you see the major vessels here. This is the common hepatic artery air, which is giving rise to the gastroduodenal inferiorly, and then extending further to give the right hepatic, the middle hepatic, and the left hepatic artery. Kindly note that you won't find the ASPDA and the PSPDA here because this branching is usually behind the first part of the duodenum, which has not yet been transected. And during a standard Whipple's procedure, we would not even bother to dissect these two branches separately because we can take the gastroduodenal artery here right at the trunk. It is also important to note that we see a right gastric vein here, which is not well appreciated in most dissections, but here it was prominent. And then we have the right gastric artery as well, which runs along the superior surface of the first part of duodenum into the lesser curvature of the stomach. The IPDA originates from the superior mesenteric artery at the inferior border of the pancreas. It ascends superiorly to the right and posterior to the superior mesenteric vein with its two branches, the AIPDA, which is the anterior inferior pancreaticoduodenal, and the PIPDA. And these both respectively contribute to the anterior and posterior pancreaticoduodenal artery with their respective superior branches and supply mainly the head and the uncinate process of the pancreas in addition to the C loop of the duodenum. We can have some variations with the IPDA, and the most common and the most clinically relevant one is that the IPDA may originate from the superior mesenteric in the form of a common trunk with the first jejunal artery, which is called as the pancreatico-jejunal trunk. And in certain cases, you can even find it originating from the replaced or accessory right hepatic artery, which originates from the SMA itself, slightly cranial to the origin of the IPDA. So Ishikawa et al. Have described these variant origins of the IPDA with their relative frequency in their series of patients. So as I have mentioned earlier, the most common variation that you would find is the IPDA originating from the SMA in the form of a common trunk with the first jejunal artery, or else it can have a direct origin from the SMA and in certain cases from the replaced right hepatic artery as well, which is very rare and has been described here in this picture on the right. So this is a short surgical video where you see the IPDA going superiorly from the superior mesenteric artery here and going ahead and supplying the uncinate process and the head of the pancreas inferiorly. You would find the superior mesenteric vein here, and that's the trunk of the IPDA where we usually ligate it. The dorsal pancreatic artery is the third artery that supplies mainly the body and tail of pancreas. It originates from the splenic artery, about 2 centimeters distal to its origin from the celiac trunk. And you also find some branches that anastomose with the pancreatico-duodenal arcade as described earlier. And like any other branch, it can have variant origins where it can be from the SMA or the common hepatic artery as well. This branch that goes inferiorly has also been described by many authors as the transverse pancreatic artery. We don't have any clear-cut anatomical demarcation so as to when the dorsal pancreatic artery becomes the transverse pancreatic artery, but for description purposes, other descriptions have also been made. So we don't usually see this transverse pancreatic artery during pancreatic dissections because it lies on the posterior surface of the pancreas and slightly towards the cranial end. But when we are transecting the pancreas during the Whipple's procedure, you will almost always find this spurter, as you will see here in a short while. So when we are cutting the pancreatic neck and we reach the posterior and the superior surface, and we keep cutting it with the energy device, you will see this spurter here, that is the transverse pancreatic artery, which is usually sacrificed during this procedure. Coming to the venous anatomy and drainage, the drainage of the entire pancreas is usually into the superior mesenteric vein, splenic vein, and the portal vein axis. And there can also be numerous small short tributaries draining directly into these major trunks from the surface of the pancreas. Like its arterial counterpart, the head, neck, and the uncinate process is drained via the superior pancreatico-duodenal vein, and the inferior part of the pancreatico-duodenal arcade is drained via the inferior pancreatico-duodenal vein, which both have their anterior superior pancreatico-duodenal vein branches and the PSPDV. And the inferior pancreatico-duodenal vein may have its anterior and the posterior tributary. The body and tail paralleling the dorsal pancreatic artery usually has the centro-inferior pancreatico vein, which drains into the splenic vein. So what is important to note here, this is the earlier picture that I showed, but from a lateral view, you'll find the cranial end here with the transected bile duct and the head of the pancreas inferiorly. This short vein here is the PSPDV, the posterior superior pancreatico-duodenal vein, which drains directly into the portal vein. This vein has also been called the vein of Belcher by Professor Cameron, mainly after his assistant, Kenneth Belcher, because this vein is short, fat, and almost always gets in the way during a pancreatic resection. One of the major venous drainage of the pancreas goes through the gastrocolic trunk of Henle, and this is very important when it comes to pancreatic resections. It was originally described as the confluence of the right gastroepiploic vein and the right colic vein, but this is usually seen in less than 20% of the cases. The most common variation that you would find in this region is the junction of the right gastroepiploic vein, the anterior superior pancreatico-duodenal vein, and the superior right colic or the right colic vein. So essentially, gastrocolic trunk is formed by 3 tributaries draining the gastric, the pancreatic, and the colonic counterpart. It is important because during surgery, this almost always is the site of bleeding, mainly due to overzealous and overenthusiastic traction by an assistant because these veins are fragile. And during operative dissection, you would find the gastrocolic trunk here with the superior counterpart, the right gastroepiploic vein, and the inferior counterpart, the superior right colic vein, forming a common trunk of Henle draining into the superior mesenteric vein. It is important to note that once we get rid or tie off this vein, there are no more major anterior branches to the superior mesenteric vein, and we can safely tunnel the pancreas away from the portal vein. Of course, if there's no tumor infiltration. And the same branch, if you look at it from a lateral aspect, you'll see the ASPDV and the gastroepiploic vein draining here and the superior right colic vein coming from inferiorly, forming the gastrocolic trunk. Another major vein that has been very frequently studied in terms of pancreatic dissection is the first jejunal vein. Now, classically, first jejunal vein is the vein that drains the first jejunal artery. And you may find it going directly into the superior mesenteric vein, or you can also form a common trunk with the second jejunal vein. In that case, the venous tributary going to the SMV becomes the first jejunal trunk. We can have various relations of this first jejunal trunk or JV1 in relation to the SMA. Commonly, you find it going dorsally and posteriorly on the SMA, but in some cases, it can also go anteriorly. Again, Ishikawa et al. Have described numerous classification systems in relation to the anatomy, drainage, and course of this first jejunal vein. So type 1 would be when the JV1 and JV2 form a common trunk, that is the first jejunal trunk, and it goes dorsal to the superior mesenteric artery. This is by far the most common variation that you would find. But this vein can also go anteriorly, which is present in about 21% of the cases. And type 3 would be when the JV1 and JV2 do not form a common trunk and drain individually into the superior mesenteric vein. And depending upon the relative locations, whether one is anterior, one is posterior, you can have type 3-1, type 3-2, type 3-3, and type 3-4. This first jejunal vein is extremely important because it lies in close relation to the IPDA and the first jejunal artery trunk, and also the IPDV. And these two vessels are routinely sacrificed during a Whipple's pancreatic or duodenectomy, which poses this first jejunal vein or the jejunal venous trunk to injury. Now, Nakamura et al. Have described that 1 out of every 32 patients where the JV1 is resected or damaged can develop severe congestion of the proximal jejunum, which is the limb that is used for reconstruction. So it can cause problems with the pancreatic jejunostomy and the hepatic jejunostomy. This problem is more so when we assume this trunk to be the JV1, that is the first jejunal vein, and instead it is the first jejunal trunk. That means it would be draining more than 2 jejunal arterial segments, which increases the risk of ischemia. And secondly, these veins are small and fragile, and if you injure it, where it is not required, it is very difficult to reconstruct it. So the first jejunal trunk should always be preserved unless oncologically indicated. And like I mentioned earlier, this IPDV can directly drain into the first jejunal trunk here or into the superior mesenteric vein. In both cases, you have to be really careful we do not injure the first jejunal trunk during inferior uncinate dissection. This is a short video that would describe the entire uncinate and venous anatomy of the pancreas. So to give you an orientation, this is the head end and the leg end. This is the portal vein, and you find the superior mesenteric artery running here. This would be the uncinate part of the pancreas. The neck has already been divided and lifted off the superior mesenteric vein. This fat vein here is the first jejunal trunk. You see how it is going posteriorly and dorsal to the superior mesenteric artery. And this small vein here draining the uncinate process is the inferior pancreatic duodenal vein. So when we are dissecting it off the IPDV of the first jejunal trunk, we have to be really careful we do not injure this. So that's where we dissect and ligate the IPDV of the first jejunal trunk. So that picture here on the right shows how IPDV is clipped and separated, and then the first jejunal trunk is left intact going posteriorly. And that's the part of the uncinate still attached to the superior mesenteric artery. So after completing the superior and inferior dissection, you would find just this little bit of uncinate attached to the SMA, and dividing this would complete the final transaction and lifting of the specimen. So that's how a classical anatomy would look like after the specimen has been removed. You find the portal vein here, the superior mesenteric vein, the middle colic vein going into the transverse mesocolon here on the left. The GCT has been divided here. No more anterior branches. The first jejunal trunk has been preserved. It is going around the SMA posteriorly. You will find the stump of the IPDA somewhere here. The SMA is running posteriorly. The IVC is here, the transected bile duct, and the preserved right hepatic artery. So the surgical significance is you have to, be careful about certain variation that you may find. Most commonly, you can have the replaced right hepatic artery from the SMA, which lies posterior to the head of pancreas, and it can be damaged during uncinate dissection if not recognized. So always palpate the posterior part of the hepatoduodenal ligament before you divide the bile duct or before you dissect the uncinate of the SMA. Secondly, the PSPDA can have variant origin from the SMA or the right hepatic artery instead of the gastroduodenal artery because it is more variant than the ASPDA. And in that case, if you damage the hepatic or the mesenteric vessels, you can have catastrophic effects. The classical Whipples that we do is a venous first dissection where we dissect the head of the pancreas of the superior mesenteric and the portal vein first and leaving the IPDA intact. So that causes severe congestion of the head and traditionally more bleeding compared to the SMA first approaches where we lift the pancreas of the SMA first, dividing the arterial inflows and hence reducing bleeding. The gastrocolic trunk, again, one of the most common sites of bleeding, usually by excessive traction. And if it drains a major tributary of the colon, then it can cause colonic congestion as well. And like I mentioned before, the importance of first jejunal vein cannot be emphasized more. It should always be preserved unless oncologically indicated because we have to preserve the drainage of the proximal part of jejunum for reconstruction. Take home message, pancreas has an intricate vascular network with variations in arterial and venous drainage. These arterial anomalies, they can alter perfusion, they can necessitate complex reconstructions if injured and it cause unexpected ischemia. Veins are fragile, they can cause bleeding, congestion, or thrombosis, and hence a high quality pre-op imaging and meticulous dissection is the key to preserving all these vessels. And like in our Sanskrit language, pancreas has been called Agnashe, which means the seat of fire. So if everything goes well and we respect it, then it usually produces just enough heat for us to digest our food. But then if we mess with it, then it can light up the entire body. With that, I would like to conclude my talk. Thank you so much.
Abhilasha, you have a formal presentation?
Yes, sir.
So maybe we'll have Abhilasha's presentation and then Ajay and Nishant can.
Suppose the first jejunal trunk is get injured, the first jejunal suppose the first jejunal trunk that is draining 1 and 2 is get injured while doing a tumor of uncinate close to that, then what to do? What precaution you have to take? Do you resect jejunum more?
So, sir, initially during earlier versions of the guidelines that we had, NCCN and all, they said that involvement of the first jejunal trunk would deem a tumor advanced and not amenable for resection. But that doesn't hold true right now because what we have to see, if a tumor or it's involving the first jejunal trunk, mostly it would also be involving the superior mesenteric vein or its ileal branches inferiorly. So that would make it unresectable. Secondly, it is not that we cannot divide the first jejunal trunk, but we have to be really sure that the jejunal segment that remains is not ischemic or congested. If so, that probably you'll have to resect a little bit more of the jejunum so that the end that is taken up for reconstruction is not congested and you cannot have problems with pancreatic jejunectomy and
So you
hepatic.
have to wait or you have to do some ICG test for that or not?
I think clinical judgment would suffice in this case because by the time, if we divide or injure the first jejunal trunk, we would still have ample of dissection left, especially if we are doing a venous first resection. So by the time the effects of congestion would have already shown on the jejunal limb. So there's usually about, in our cases, 15, 20 or 30 minutes before we complete the entire uncinate dissection and then take up the limb up.
That will give an idea.
That will give an idea.
Thank you.
Yes, yes.
Sir, what I have observed that if first jejunal vein is combined with the inferior pancreatic or duodenal vein, then you can resect some jejunal more if you injured first jejunal vein, and it will not be ischemic. But if it is there are more than one vein, like if it is a combination which is inserting like first jejunal vein and second jejunal vein, then definitely it requires the reconstruction because you cannot go for more longer segment to the jejunum because it requires a longer segment. Another thing is you can do infracolic dissection over the jejunal vein and you can find out that which part it's inserting and you can cut there, right? But you need some more dissection in the infracolic part.
I think there are two different issues which are discussed. One is it has accidentally injured. I think that's the question. Second thing is tumor infiltration. If it is tumor infiltration into both first and second, then I think so. Then it is definitely you can't reconstruct it. It may be disastrous, but if it is having a accidental injury, then you can divide more jejunum. You can see that how much of it is getting congested. So that is the only way that you can manage it. Please.
When we talk about the J1 trunk, the jejunal trunk, so it is important that the J1 trunk is usually referred to the artery, and usually the veins are J1V and J2V. So when the vein is injured or sacrificed, it's always desirable to reconstruct or remove that venous segment of the jejunum. If the arterial is resected or is injured, then we can wait or give ICG and check the vascular. But if we have injured the vein, then it is very dangerous.
J1 vein reconstruction is usually not possible because it's a very fragile vein. And second
can lead to post-operative.
most of the studies, if you see, they have tried reconstructing the J1, J2 vein. It is almost always thrombosed.
So that is why
hardly
it is very leads to disaster.
Anyways, it's just a small segment that you need to remove.
Yeah.
Better than.
Keep in your mind. J1 anomaly should be.
So, what Ashir was telling, I would add that when you are resecting, when you're doing a PD, actually you have already divided the jejunum and you get the proximal jejunum onto the right side. That is the reason that you find that the first jejunal vein loops around the vein. Normally, that is not the course. As soon as you divide it lateral, as soon as you divide the tissue lateral and the vein lateral to it, it takes its natural course and goes onto the left side. Getting the point? So because of your traction, so only way you can prevent most common injury, what you are saying is that the traction has to be under control and you have to identify that vessel so that you can just divide that it close to the pancreas. Don't divide the vein, the first jejunal vein. More traction is usually hazardous.
And while taking care of the interior pancreatic vein or posterior inferior pancreatic,
So you have to
also lead to.
So you have to divide both the veins, posterior vein, anterior pancreatic vein, but preventing injury to the jejunal. Your traction actually gives you a misinterpretation that what you are dividing is actually anterior pancreatic vein. It is actually not. It is the first jejunal vein. So you're less of traction and then size. There are two things which I have learned, that these are two things only which can guide you.
So here, basically, at the uncinate dissection, you have to hug the uncinate here. And as you go ahead, as you go more proximally, you have to hug the SMB. That is the.
There is a nodal mass also. Difficult to clear the uncinate at that. Because sometimes the mesentery of the uncinate is thicker, and because of some nodal mass also, it is very difficult to identify.
So the place where you find the first jejunal vein, normally you will not find nodes. Nodes are usually proximal to it, where at the site of origin of the superior mesenteric artery and at the site of the just close to the portal vein, the superior mesenteric vein over there. So
that vein
then give new adjuvant.
Because it is not unresectable. Theoretically, it is not unresectable.
Yes, Abhilasha.
Good morning, all of you. Myself, Dr. Abhilasha. Firstly, I'm glad to be part of 5th Jaipur Surgical Festival, all thanks to Dr. V.K. Kapoor sir. Since yesterday, we have been discussing about importance of knowledge of anatomy. Here, I want to add one thing. Love it or hate it, you cannot ignore anatomy. As Dr. Kaul have already given an detailed overview about vascular anatomy, I will cut it short and only briefly discuss about what are the anomalies that can be encountered in the vascular supply of pancreas. As it is briefly described by Dr. Kaul, that pancreas receives its blood supply from the interior and posterior arcade in the head and neck areas. It also receives its blood supply from the dorsal pancreatic artery and by the branches of the splenic artery in the body area and in the tail of the pancreas. The most important anomaly that have been discussed time and again in these sessions is the high risk anomaly, which is replaced right hepatic artery. A replaced right hepatic artery arising mostly from the superior mesenteric artery is the most commonly clinical significant variation, which has been observed in 11 to 21% of cases. It typically travels posterior to the head of the pancreas and the portal vein. Right hepatic artery normally is a branch of proper hepatic and it lies posterior to the bile duct, but it may be the replaced right hepatic artery is present just posterior to the head of the pancreas. So it presents a surgical danger. During Whipple's procedure, the artery can be mistaken for a pancreatic branch and ligated, which cause liver ischemia. So this artery can also be felt, can be palpated behind the hepatoduodenal ligament. Another anomaly, vascular anomaly, is dorsal pancreatic artery. Dorsal pancreatic artery, in most of the cases, is the branch which is coming from the splenic artery. It is given posterior to the body of the pancreas, and then it divides into the right and the left branch. Right branch anastomose with the arterial arcuate posteriorly at the head of the near the head posterior region of the head of the pancreas, and left branch traverses course, and now it's known as transverse pancreatic artery. It anastomoses with the large vessels, which are basically these vessels are supplied to the body coming from the splenic artery, which are known as the arteria pancreatica magna, and to the tail, which are arteria cordis, to the tail of the spleen. Next, another variation, which is the most commonly encountered, is that dorsal pancreatic artery arises as a branch coming from the superior mesenteric artery. Then it courses inferiorly and then divides into right and left branches, which is been shown in the figure D. In the figure B, it is been shown that it is coming directly from the celiac trunk, and in the figure A, it is shown that it can also arise as a branch coming from common hepatic artery. There is one more variation or the anomaly which can occur, which is known as arc of Buller. What is arc of Buller? It is basically a persistent embryonal ventral anastomotic shunt joining superior mesenteric artery with the celiac trunk. It is present in 1 to 4% of individuals, a very rare anomaly, and it provides a collateral circulation or a pathway between the two vascular territories of celiac artery and superior mesenteric artery. It is a persistent embryonic anastomotic branch between the 10th and 13th ventral segmental arteries, resulting in a connection between the celiac trunk and superior mesenteric artery. It can be a source of unexpected hemorrhage if you're not aware about this arc of Buller. Another variation is the presence of gastrocolic trunk, which is present in less than 20% of the individual. The gastrocolic trunk is a key landmark in the pancreatic head surgery. This is basically formed by the confluence of gastroepiploic vein and superior right colic vein. This is also joined by anterior superior pancreaticoduodenal vein, which drains here. There are again different variations that are noted in the formation of gastrocolic trunk of Henle. In the first, in the diagram A, we can see that there is confluence of right gastric epigloic artery and anterior superior pancreatic duodenal vein, and joining of superior right colic vein inferiorly, which forms the GTH, which is gastrocolic trunk of Henle, and which finally drains into the superior mesenteric vein. In this next figure, we can see that there is also a confluence of right colic vein in the formation of gastrocolic trunk. In the third picture, we can see there are three colic veins which are joining together and draining into the gastro in the GTH. Next figure, it shows that there is that right colic vein and middle colic vein are draining directly into the superior mesenteric vein. There is only confluence of right gastroepiploic vein with the anterior superior pancreaticoduodenal vein. Now, tearing this short white trunk during dissection of uncinate process cause massive, difficult to control hemorrhage from the superior mesenteric vein. Here in this picture, we can see the formation of gastrocolic trunk of Henle, which is formed by confluence of right gastroepiploic vein with the anterior superior pancreaticoduodenal vein, along with the confluence of superior right colic vein and right colic vein. So pancreas, as we know, is centrally located in the vascular crossroads of the abdomen. Procedures like Whipple's procedure require precise dissection around the major vessels, which are superior mesenteric artery and vein and portal vein. So having a knowledge of vascular anatomy will be significant because it occurs in 20 to 40% of the patients. Failure to identify these anomalies like replaced right hepatic artery is a leading cause of intraoperative bleeding and postoperative ischemia. So, routine use of high resolution CT angiography with 3D reconstruction for arterial mapping is required. Another procedure which was discussed by the Dr. Ashish Kohl, artery first approach, in which there is first identification and control of SMA and hepatic arteries. And last is vessel preservation. If there is an anomaly like right replace hepatic artery is found, it must be dissected, it must be preserved. Accidental ligation requires immediate reconstruction. Thank you.
Thank you. Thank you, Abhilasha. So as I mentioned yesterday, we invited and requested our colleagues in the Department of Anatomy to be part of this, mainly to emphasize the importance of anatomy, and a selfish reason that in my institution, I want more interaction and collaboration between anatomy and various surgical specialties. So we have 5 minutes, Ajay and Nishant.
So I think the interest is slightly more than that. I feel the anatomists should become more of clinical anatomists now. What I feel, if they come into these conferences and they see the clinical implications.
Next step is they will come into the theater.
Yes, sir. Sir,
So that will be good, because I feel the pathologists come into the theater and the anatomists come into the theater. They can teach the MBBS students much better than what they presently we see. हमने मीडियन ऑफ कैसे पढ़ी थी, लेफ्ट हैंड के अंदर जो लेटरल जाती है, अब लेटरल समझ में नहीं आता था उस समय फर्स्ट एमबीबीएस में, व्हाट इज लेटरल व्हाट इज मीडियल. तो अगर आपको उसमें एनाटॉमिकली अगर आपको इफ यू कैन अंडरस्टैंड द 3-dimensional इमेज, इट बिकम्स मच मोर ईजियर. I would like Nishant to comment on this rather than Paul, because I think that is important. On the loop of Henle, how do you prevent that injury? Because loop of Henle, the vascular injury is the most common cause of conversion for the beginners. So
Yes.
Nishant, if you can comment on that.
During the dissection, actually we dissect the SMV.
Piyush is having a very good photograph. They did a lab PD yesterday where they had a very good loop of Henle anatomy. So he will be showing it just now.
So we approached the inferior part of the SMV, just inferior to the neck of the pancreas from both the sides, from inferiorly and from the superiorly by dividing the gastrocolic ligament. And first we go inferiorly in the infraduodenal part where we identified the SMV, and then we approach to the level of the neck of the pancreas. And
absolutely,
so there we can find both the middle colic vein, and if
let me introduce you, Nishant. What he's telling is very correct and very specific that we have to follow. Nishant is one of the finest surgeons that I have seen. Specifically in PD when he has been with us, and one of the most fine surgeons who has he was our junior, but he used to taught us so many things about the small tricks that he knows. So I think that is very important what he has said, that loop of Henle, how to loop it and how to identify. Dr. Kaul, can you tell me GDA? Do you palpate the arteries? Do you when you loop the GDA, or you don't palpate any vessel if palpation is important for any vessel? Before ligating GDA.
Before ligating GDA, one of the most important things that we taught is we routinely practice is we test clamping. So we see the pulsation going down behind the duodenum. It has not been transected already. We put a test clamp, or we just loop and sling it tight, or we put a bulldog on over it and palpate for pulsations in the right hepatic artery, because like it has been described, the flow to the liver can be through the collateral pathway to the pancreatic or duodenal arcade through the GDA going on to the right hepatic. So if we divide the GDA in that case and the entire flow is through that arcade, it will be causing catastrophic liver ischemia. So that is one step. We palpate, clamp it, see for collateral circulation, and then divide it.
I felt this is important. This was missed in the anatomy, so I felt this is important that you have to always palpate the vessel. Anatomy, if we can see that loop of Henle pick from Piyush, is it loaded? Okay. In the meantime, how many of us as a routine practice putting two sutures at the one at the upper pole of pancreas and the one at the lower pole of pancreas before dividing?
Or I am not using. I don't use.
You don't use? You use? So we have
what we do
70% use and 30% don't use. Okay, we have a discussion. So it's a good so it can be a
I divide pancreas with harmonic, with fast harmonic.
We'll come to that just in a second. We'll come to harmonic.
Upper and lower end, and in the mid I use pottery.
Okay.
So I don't have many problem with bleeding from the both upper and lower.
And what is the use of ligating it before putting a sutures at the upper end and the lower end? For hemostasis? For hemostasis? Before Dr. Kapoor says anything, let me, I know what he's going to answer. So, for anything else? No, I think what Dr. Kapoor has to say is more important than that. And I think Sir has to.
Gives you a feel of the pancreas.
That is the most
whether the
important.
suture is going to cut through or not. So you get a subjective assessment of the texture, and then you know how much pressure or force you have to apply when you are tying the knots. So that to me is a very important. If you have that picture.
So, yeah, Piyush can explain on that.
So yesterday in the laparoscopic Whipple, so this was the anatomy we encountered. I think this is the
Loop of Henle.
type 3 anatomy. You can see a major trunk draining into the SMV. SMV is slightly gray colored and rest of the vessels are dark blue. So if you can just give a cursor on a SMV, yeah. So this is the SMV in which there is a cursor, and the entire thing is the loop of Henle. So you can see at least 5.
Anatomically, what is this?
This is the common gastrocolic trunk.
And what is this?
So these are the colic vessels, probably the superior right colic 1 and right colic 2.
And what is this?
So this is the anterior-inferior pancreatic vein. And that is the gastroepiploic vein. So there can be variations, you never know. We encountered yesterday in the lab Whipples.
So now I'll come back to Piyush again because he said that he does not like it. He does not put a suture into the pancreas. Specifically, reason being?
So actually, nowadays we do more of a minimally invasive Whipples. So I think we just loop the pancreas and tie off with the umbilical tape onto the specimen side. So that gives a traction and it prevents unnecessary time of taking sutures on the superior and inferior border.
Laparoscopically taking sutures is much difficult.
So it is difficult. So we just tie it with the umbilical tape and just divide it with harmonic, and then we are near the duct, we divide with scissors.
So for those who don't use sutures and those who use sutures for vascular, for bleeding reason, if you want to use it for a bleeding, it's fine but normally we don't want to avoid bleeding from the remnant pancreas. We want it to have a good vascular supply because that is our area of anastomosis. So for having a texture feel, what Dr. Kapoor was saying is you can have a suture onto the head side, onto the to be resected side, which will give you traction as well as give you a feel. And what we use is we use a single suture. We put it on both the sides and put it as a traction wide suture. So that's what combines both the things.
Another point is that even we have observed that after taking both sutures, bleeding does not stop. This is done. Yes, bleeds.
Sometimes it bleeds.
But I have observed that one artery consistently over the upper border. If you take that, bleeding stops. And other points, if you try to control that artery at the transaction border, you have to use multiple cauteries at that.
Bipolar is best for that. I think bipolar works very good for that.
It's helpful for the.
And for artery, you said that you'll do a vein first and then artery later.
That is how classically that.
You also do the same?
Yeah.
How many of us do it? Because yes, please.
Artery first.
I think artery first is different thing, but
I think I think very nice discussion, but I think now time has come that we all should do artery first resection. This is because the era of neoadjuvant therapy, borderline resectable pancreatic cancer, even locally advanced pancreatic cancer, heavily treated with chemotherapy, sequential chemoradiotherapy, chemotherapy. There will be some patient you might have to try even in locally advanced, if the segment of SMA is not a long segment, you can still take out some, maybe 20%. You can take BRPC, you have to operate. Like that definition of BRPC is that unless there is progression, you have to open and see after neoadjuvant therapy. Now, my suggestion to young surgeons that you should start doing artery first in all the patients. This is because in a setting of vein resection, you have to do the vein resection last. So in that situation, you have to completely mobilize the tumor off from the SMA, bare the celiac, and then you cut the vein and take out the specimen. Either you are doing a total or a partial. You might have to do a resection on something known as on the splenic artery, well away from the tunnel where the tunnel is involved. So start doing routinely artery first so that when the situation comes, you can do it easily. That is my message.
So for a SMA first, there are 6 approaches. So keep on trying it on a normal patient with a small ampullary cancer, because so that you get a feel that what are the difficulties you are going to encounter. Because someday when you have a SMA getting closely abutting the tumor and you start on that day, that is a bad day to start. So similarly, as I say always, for lap suturing, best is to do a lap when you're doing a lap chole, put in a suture onto the cystic duct and on both the sides, because there you have best angulation of hands. Similarly, you should start doing the SMA first approach before it starts ringing too much.
So we have the second topic also same. So.
So after an excellent discussion, we'll move on to our second topic, which will be surgical anatomy of the pancreatic head resections. The presenter will be Dr. Kanchan ma'am, from who's a consultant robotic and lab GI HPB surgeon from Jupiter Hospital, Thane, Bombay. The discussers will be Dr. Manpreet Uppal, AIMS Nagpur, and Dr. Hemant Jain, who's a consultant and surgical gastroenterologist, Ananta, Udaipur.
Good morning, everyone. At the outset, I would like to thank Professor V.K. Kapoor to again giving me this opportunity this year to present on the surgical anatomy of pancreas. So mainly for the pancreatic head resections, I would be mainly covering the pancreatic head resection, that is Whipple's operation for pancreatic head tumors and periampullary tumors. And I will touch upon the vascular variations and resections, also some enucleations and ampullary surgeries. So the surgical anatomy consists of the microanatomy, which I will not touch upon now, but the gross anatomy is head, neck, body, and tail, and the ductal anatomy, which has various implications in our day-to-day clinical practice. So looking at the radiology, how do we exactly differentiate the head from the neck and body and tail is we take the SMV portal vein axis as the main central line, and the part of pancreas above that is the neck. To the right of the SMV remains your head, and to the left of the SMV is your distal pancreas, which encompasses the body and tail, which is taken up from the left edge of the superior mesenteric vein. So for the surgical anatomy, we have to understand that it's a retropancreatic organ, and there is a visceral peritoneum covering the anterior surface of the pancreas and excluding it from the retroperitoneum. So you actually have to go into this fusion fascia of Treats, which is at the head and neck level, to actually enter a plane where you can dissect the pancreatic head for your Whipple's procedure. At the same time, for the body and tail, you have to go in at the inferior body of the pancreas and go into the fusion fascia of Told to dissect this part of the distal pancreas. So extended cauterization and lowering of your hepatic flexure is the first step that you do for your Whipple's resection. As you do this extended cauterization, it extends up to the inferior, the left renal vein inferior border, and you have to expose the aorta. So the first step you do is basically to take out all the interaortocaval nodes for staging purposes also. And here you have to safeguard the right gonadal vein and your right ureter. If you go too deep into the plane, you might injure these structures. The next step is you basically lower the hepatic flexure of the colon, and you take your dissection up to the D2, D3 junction, and here is where you basically dissect the duodenum and D2, D3 from the transverse mesocolon. And you will here reach the superior mesenteric vein, and as we discussed earlier, the gastrocolic trunk of Henle. Then you open the lesser sac, and then you reach the head of the pancreas. You reach the inferior body of the head of the pancreas. And here is where you will find your right gastroepiploic vein and your colic veins forming a common trunk and draining into the superior mesenteric vein. So this is how you identify the right gastroepiploic vein, and there is where you reach the gastrocolic trunk. This is where you can see that this is the gastroepiploic vein, and this is the right colic vein draining here, and this is the middle colic vein which is draining separately here. So we already discussed the vascular anatomy and the venous drainage. We have various categories of or the types of gastrocolic trunk. The most common type is the type 1, where we see it's a trifurcation of the right gastroepiploic vein, the anterior-superior pancreaticoduodenal vein, and the right colic vein, which is forming a common gastrocolic trunk. And here is where you have to ask your assistant to exert very minimum traction on the mesocolon, so that these veins are very fragile and it can bleed torrentially, and you can prevent your blood loss over here. The anterior-inferior pancreaticoduodenal vein usually runs anterior to the CBD, and it drains directly into the portal vein at the superior border. And the vein of Belcher, that is the posterior-superior pancreaticoduodenal vein, and it drains directly into the portal vein at the superior border. And the posterior-inferior pancreaticoduodenal vein drains into your first jejunal vein and thereby into the SMV. So here you can see that this is the gastroepiploic vein, this is the right colic vein, and here is your middle colic vein, which is drained separately. Once you have already clipped these vessels, then your road is clear to the superior mesenteric vein, and there is where you can actually do the tunneling, because the rest of the anterior surface of the portal vein or the superior mesenteric vein is an avascular plane, and it's usually free of vessels. So you can easily do the tunneling and assess your resectability. Minor variations in the first jejunal vein drainage, again, we have discussed here. The idea, as we already discussed, is to stick to your uncinate process at the dissection level here and not go towards the superior mesenteric vein. As your left hand is basically pulling the pancreatic head towards the left, there is a traction given. So even if the first jejunal vein is actually draining posterolaterally into the superior mesenteric vein, still, because your left hand is giving a continuous traction towards the left, you actually see the first jejunal vein actually draining into your superior mesenteric vein from the right hand side. So that is where, because of excess traction, you can try to injure the first jejunal vein. Then comes the regional lymphadenectomy. You go into the suprapancreatic portion and you start dissecting the periportal lymph nodes along the right side of the CBD. So this is where you can encounter the replaced right hepatic artery. You have to always palpate the right border of your CBD and look for an accessory or a replaced right hepatic artery. So and also try to palpate the pulsations of the right and left hepatic artery on the hepatoduodenal ligament. So there is a difference in the caliber of the right hepatic artery. If it is an accessory right hepatic artery, the caliber is usually small. But if it is a replaced right hepatic artery, you can see that the caliber of the artery is also big with good pulsations. So during this lymphadenectomy, we have to be very careful. Otherwise, we'll end up losing the hepatic blood supply over the right lobe. Then we switch on to the station 8 lymph node. The regional lymph nodes, according to the Japanese classification, to be cleared in the head and neck cancers during a Whipple's procedure is usually you start with the anterior and posterior pancreaticoduodenal nodes, that is your station 17 and 13 nodes, and then moving on to the inferior head nodes. You may encounter some station 15 nodes, that is over the inferior border of the pancreas, over the middle colic vessels, and then going on to the juxta aortic lymph nodes, that is station 19 and 14A. And then it can get in the last lymph node to get involved is the paraortic lymph nodes, that is the station 16 A2 B1 nodes. Also, you have to clear the hepatoduodenal ligament and the station 8 nodes, that is the station 8 and 12 nodes. So these are the group of lymph nodes that you will encounter in the head and neck pancreas tumors, and there's a different set of lymph nodes to be taken out in the body tail pancreatic tumors as well. The next, you go for a right gastric artery transection. If you don't do this, you will not be able to mobilize the superior border of the pancreas and the duodenum. So you have to take these right gastric artery and the lymph node along with it. Sometimes you might be able to preserve it for a pylorus preserving pancreaticoduodenectomy. Then we proceed towards the left periportal dissection. the one thing that we need to understand in the left periportal dissection, that is, as soon as we take the station 8A lymph node, we proceed towards the station 8P and the 12B lymph nodes. So that is where when you actually do a left periportal lymph node dissection, you have to be very careful that you should not injure the portal vein, which is just behind these lymph nodes. And so your hand should be in the foramen of Winslow, and you should be always palpating the structures behind. And at the same time, if you give a lot of traction over here and there is not enough counter traction given by your assistant on the lymph nodes, then you will tend to injure the right hepatic artery or the proper hepatic artery, which is in close relation to these lymph nodes. Next, we do a fundus first cholecystectomy, and we identify the cystic artery and clip the cystic duct. Then we go ahead with the division of the gastroduodenal artery. Again here, as Dr. Sharma rightly pointed out, we always palpate the GDA, and also we have a protocol of clamping the GDA to look for good adequate pulsations in the hepatoduodenal ligament of the right and left hepatic artery. The second thing, you might encounter another vessel which is just next to the GDA, just medially. When you encounter another vessel at the superior border of the pancreas, you should always think that if there is another vessel, that means there is probably the arc of Buehler, which is enlarged in size, and that is going to give you a collateral blood supply. So if that is the case, go back to your radiological anatomy and see whether you have a significant median arcuate ligament syndrome or a celiac artery stenosis, because that is when you encounter duplex vessels over the superior border of the pancreas. The next, the arc of Belcher, as we as already discussed, is a very constant vessel in its position, and it drains superiorly into the from the pancreatic superior pancreatic border, and this can be taken separately before doing the uncinate dissection very well when you are clearing the fibrofatty tissue of the portal vein. So arterial anatomy already discussed. I'm not going into the crux of it, but GDA and the IPDA are the main vessels, main feeders for the Whipples. And GDA we already discussed. IPDA is the one when you start the uncinate dissection, that is where the IPDA comes into play. The vascular anatomy is variant, and variation is the rule in all HPB surgeries. So we have to look for it in every case in our radiology. So the most common anatomy is the right hepatic artery coursing anterior to the CBD. If there is a replaced right hepatic coming from the SMA, it happens in almost 20 to 25% of the cases. There can be a common hepatic artery separately arising from the aorta. Also, a replaced right hepatic artery in the pancreatic cancer can make it a BRPC. So Hyatt's and Michel's classification already described in the first lecture by Dr. Joshi as well, not going into the details. Then we go on to the CBD transection. We loop the CBD after doing the hepatoduodenal ligament clearance, and we transect the CBD after doing a bile duct aspiration. We then prepare the roux limb. So there was a discussion by Dr. Dash yesterday of preparing the roux limb when you do this uncinate dissection. So this can be problematic if you have a very bulky mesentery, especially in an obese patient with a mesenteric paniculitis. You might find difficulty in doing this. It's better to it's better to open up your ligament of Treats and then push the proximal jejunum onto the right and start taking the vessels here, so that you can avoid dissecting too much of the jejunum in your Whipple's procedure. And then you start with the mesenteric division. During the uncinate dissection, you might encounter few vessels. And again, as we discussed, the first jejunal vein has to be safeguarded. Clipping and dividing all the tissues or ligating and dividing all the tissues is advisable so as to prevent torrential hemorrhage over this area. You will encounter the inferior pancreaticoduodenal artery as you progress ahead. The last bit of tissue above the inferior pancreaticoduodenal artery is mostly a part of the triangle clearance that we do, between the celiac axis and the superior mesenteric artery and inferior to the superior mesenteric vein. So the IPDA, again, it is already discussed. Variations, I will not come into this again. This is a case where we had actually, we were about to do a portal vein resection. So again, what Dr. Sharma was discussing, the first jejunal vein involvement by the tumor, it will not be a complete no-no to a resection. It can still be resected after giving good neoadjuvant treatment. In these cases, you have to divide the specimen, divide the neck of the pancreas, and leave all the specimen onto the vein so that you can actually identify what length of the vein can be preserved. Okay. So you have to loop the vein above and below, and that is when you can actually keep the specimen hanging on the vein and then resect the minimum portion possible. Triangle clearance, I told you already, it's inferior to the superior mesenteric vein and between the celiac axis and the superior mesenteric artery. There is newer advancements coming for vascular resections and even periarterial divestments, even if your tumor is involving less than 180 degree of your artery, wherein you enter the subadventitial plane to do a subadventitial or an extra adventitial divestment, which is called as the LV3 plane. So last step is the division of pancreatic neck. We already discussed we can take it with a cautery, but I prefer doing it with a knife so that we can identify the pancreatic duct nicely. One more thing I would like to touch upon is the mesopancreatic dissection, which is very helpful in your pancreatic head cancers than your periampullary cancers. So the pancreatic head plexus or the neurovascular bundles and the lymphatic tissue which is there in between the uncinate process and the celiac and superior mesenteric artery axis, that has to be cleared off to attain a good uncinate margin or a SMA margin, which is R0 resection. So routinely for a periampullary plane, if you enter in the LV1 plane, that is more than enough. But if you have a borderline resectable pancreatic tumor, you need to enter in the LV2 plane. And LV3 plane is the subadventitial plane, which is done when the arterial involvement is suspected on the preoperative radiology. So SMA first approaches we already discussed. Routinely in non-involved cases, as sir rightly pointed out, we should start doing posterior SMA or the lateral SMA approach, which is very easy and a beginner can also start. So while doing the extended cauterization, when you have reached the inferior left renal vein, that is where just above your left renal vein, you can identify the SMA. You can check for the pulsations and you can start dividing the tissue and you can identify the SMA beforehand in your routine Whipple's operations also. So the various indications for SMA first approach is for judgment of resectability and clearing the SMA margin and identifying and safeguarding a replaced RHA and avoiding venous congestion before resection to reduce the intraoperative blood loss. There can be various ductal anomalies. We have learned about the pancreatic divisum and the various fusion anomalies which can occur. How does it matter to us is that you should always see in your radiological anatomy if there is a separate PD draining above, and if there is a very small uncinate branch which is draining along with your CBD if the patient is stented. So what is the importance is that when you are doing a neck transection, if you see two ducts, what can you do? If you either anastomose both the ducts by doing a dunking procedure or an invagination procedure, or you divide the pancreatic neck to more towards the left so that you encounter only one duct there. Also during enucleation, the proximity of this lesion to the duct is of importance. Preoperative MRCP and intraop USG always helps. Only if the duct is far away, then you can attempt an enucleation of these lesions. So this is a case where we encountered two ducts. We have cannulated both separately. Pancreatic radiological anatomy, we had not discussed very in detail, but the pancreas protocol CT, as rightly pointed out, we need a pancreatic phase CT for differentiation between the tumor and normal pancreas, which happens at 40 to 50 seconds, and then a portal venous phase. So this is what I was discussing. If there is a mesenteric panniculitis, the jejunal limb which is to be brought up is a problem because that can be very bulky and it can be disastrous to anastomose to the pancreatic neck. Okay. Body habitus also has to be taken care of. The distance between the abdominal wall and the pancreatic neck is one of the factors which can be a predictor of your post-op pancreatic fistula. The PD diameter and position, the pancreatic thickness, consistency, and the acinar density. If you can see, if the PD is nicely dilated and more than 3 to 4 millimeters, that is a good PD to anastomose. PD position also, if it is more superior, or if it is central in position, or if it is posterior in position, that is also one of the predictors. On CT, you have to see if there is too much of fat deposition, how much is your acinar density. That is also a very good predictor of your post-op pancreatic fistula. Do you see a replaced left hepatic artery in the fissure, umbilical fissure here? And if you can see this, it's the image showing you a replaced both left and a right hepatic artery coming from the left semi and the left gastric artery simultaneously. If you see, there is a lot of perineural invasion here, and a lot of it's the neck tumor involving the celiac axis and the perineural tumors. So here, your replaced right hepatic artery can be a boon to you. A variation, anatomical variation can be a boon to you if it is not involved in these kind of tumors. So in that, you can proceed with the celiac axis resection as well. Again, replaced common hepatic artery from SMA is also can happen in 2% of the patients. And this is also an anatomy that you can actually safeguard the common hepatic artery. You have to be very careful. You'll again palpate this artery in the posterior portion of your pancreatic head, and you have to preserve it. So we did this case in a head of pancreas cancer, and we have preserved this very carefully by dissecting it from with the help of a bipolar forceps. And this was the last dissection. We had already separated it from the superior mesenteric vein, and we have kept it last to dissect from the the replaced right hepatic artery, common hepatic artery. Celiac artery stenosis, you can see a hook-like deformity at the origin of the celiac axis, and you have to be careful of the arc of Buehler. If you can see it nicely, you have to preserve it very nicely. This artery was dissected from the common hepatic artery till the superior mesenteric artery, and that is how you can safeguard the, even if there is a celiac artery stenosis or a median arcuate ligament syndrome, which is clinically significant, you can still safeguard the collateral supply, and you can still proceed with a Whipple's resection in these patients. A lot of venous deformities which can occur, borderline resectable pancreatic cancers, a teardrop sign. There are various recommendations of calling them as a borderline resectable if there is a, even if there is a 270-degree involvement or a complete encasement of the portal vein or a superior mesenteric vein, and a less than 180-degree involvement, you can still proceed with a neoadjuvant treatment, and these patients can come up for resection at the table. So this kind of contour irregularity or a complete encasement or a teardrop sign, which can be seen in this video, these patients can be submitted to neoadjuvant treatment or a total neoadjuvant treatment, which involves a chemotherapy plus or minus radiation. These patients can come up for resection after a total neoadjuvant treatment also. So like in arterial collaterals, you can also have venous collaterals when your vein is totally blocked by the tumor. You can have the posterior superior pancreaticoduodenal vein, the anterior superior pancreaticoduodenal vein, and the anterior inferior pancreaticoduodenal vein, which gets enlarged as collaterals in view of block of the SMV or PV. So if there is a good collateral supply seen, you can go ahead with the pancreaticoduodenectomy even without a vein resection in these cases. So extensive perineural invasion is seen like this. It will be a total, it will be a pancreatic tissue tumor density around the celiac axis or the SMA axis, and that will tell you that the tumor is unresectable. So even if the tumor is not seen very clearly in the pancreatic head or neck, but if you see this kind of density or fat infiltration around the axis of the arteries, it is still unresectable and a locally advanced tumor. So again, the another entity that we notice here is the circumportal or an annular pancreas. If you can see the pancreatic parenchyma going behind the portal vein also. Important here is when you try to resect it at the neck, you will find the pancreatic parenchyma going above or below the splenic vein and posteriorly. In that case, you have to identify if there is any duct seen in the remnant or the posterior portal pancreas. And if there is a duct seen, you have to make sure that you close it with 4-0 absorbable sutures so that there is no pancreatic leak here, and put an additional drain posterior to the portal vein so that there is a controlled fistula if at all a leak happens. Again, endoscopic anatomy, you have to be aware that the biliary duct is at 11. Okay, sir. That's it, sir. So carefully go through the anatomy, and anatomic variation is the rule. Behold the knowledge of basic vascular isolation and suturing techniques, and beware of this tiger organ. Thank you.
So, good afternoon, everybody. I'm Dr. Manpreet, and I thank Dr. Kapoor for this opportunity. Two parts of pancreatic head dissection that I feel as a surgeon I would like to highlight is to focus on the vascular anatomy, and within that vascular anatomy, to focus on A, presence of any replaced or aberrant vessels, and B, like Dr. Kanchan mentioned, to be very careful about looking at celiac artery stenosis. So I present to you a case of a 60-year-old female who had replaced right hepatic artery arising from the SMA, along with both her celiac and an SMA artery stenosis. So just a second. So here you can see that there is both a replaced right and a left hepatic artery, and the replaced right hepatic artery is coming from behind the CBD here. Here you can see that, and going into the SMA. Plus, what we missed in this patient was that there was a celiac as well as an SMA stenosis. So on compressing the GDA, there was no pulsation felt in the hepatic artery. So we closed the patient, went back, and in this particular case, instead of doing a celiac, we did an SMA stenting because the right hepatic was arising from the SMA. So that is something we need to be very careful about, both looking at the stenosis in the celiac artery as well as in the SMA, and being careful about replaced and aberrant vessels, and if they're present, to dissect carefully and to stent the celiac artery, or in this particular case, the SMA. And this was the final anatomy which was present. Here you can see that this is the replaced right hepatic artery arising from the SMA, and here is the left hepatic artery arising from the left gastric artery. So vascular anatomy as a surgeon, very important to focus, is something I would like to discuss.
Good afternoon. Very well presentation, ma'am. Very well present. You covered all the topics what I want to discuss already. So one thing I want to ask, ma'am, any technically any difference in your technique to encounter the chronic pancreatitis head resection, if you want to mention?
Just that it is more vascular, so that we have to be careful, but it will be mostly peripancreatic vessels only, so that you can easily, there'll be no aberrations. So it's peripancreatic vasculature, so you should have good energy sources with you, and you should be ligating all the smaller vessels also, otherwise these torrentially bleed. And moreover, the head resection or the reconstruction is rather easier in chronic pancreatitis because it's a hard or a firm tissue rather than a soft pancreas.
In fact, there's lesser chance of leak because the sutures can come very easily in a chronic pancreatitis.
As Dr. H. Ramesh says, that in these cases, the resection is difficult because there is a lot of peripancreatic and perivascular desmoplastic reaction, which makes the planes difficult. But once you have been able to resect, then reconstruction is easier and the complication rates and consequences are less.
Also, if there is a pancreatic head mass or an inflammatory head mass, that also becomes a little difficult. But yeah, very meticulous dissection and sticking to the planes.
Any comment on the extent of lymphadenectomy? I think
I have already covered.
You are sending any frozen for the para-aortic?
So yeah, I usually send the interaortocaval nodes for frozen section before proceeding. But again, if there is an involvement, we already do a PET CT scan before going ahead with resection. So if that is not metastatic and if there is only a single node, that will just add to my prognosis of the tumor, but it will not make my resection unresectable. It will not make my cancer
positive,
we still go ahead. We keep in mind about the prognosis or the poor No, this is at surgery. At the primary surgery on table if we find a positive lymph node, but if your scans have already determined it to be non-metastatic.
In terms of, yes.
Please go ahead.
So in terms of lymphadenectomy, I think important to discuss is whether to do a triangle dissection or not, because that is the pressing topic of discussion these days. In my case, I have seen two patients after I did not do triangle dissection at that point, but there was a node which came back in that particular area only where the triangle is located. So I feel that we should try to do it. However, of course, it is associated with complications like diarrhea and extensive dissection causing.
So in periampullary cancers, we have done a study at Tata Memorial Hospital. It doesn't translate into any of the positive nodes coming positive during a triangle dissection. So it doesn't help you with the periampullary tumors, definitely. But yes, if it is a pancreatic head cancer, especially if it is a BRPC, it definitely helps you.
See, till few years ago, we used to practice and teach that in HPB malignancies, if the aortocaval node is positive, you should not resect. But now this new concept of oligometastasis is being discussed more and more, which means a node in a distant region, but the primary is technically and easily resectable. Single or few small adjacent to primary metastasis, mainly in relation to gallbladder or HCC. And people are saying that in good risk patients where you can ensure a reasonably good immediate post-operative outcome, it is worth resecting, because some of these patients with the help of post-operative adjuvant therapy can have good survival. So I think the students should know that this concept of oligometastasis is there even in HPV malignancies. And it's not that every patient who has a metastatic node in the aortocaval region, you would not resect. Some groups probably would go and resect, provided that the resection is not an R2 in the tumor area, in the local area. Yep.
So since we are winding up with the vascular and surgical anatomy, I would like to point out three points that I can remember of. Another common site of bleeding during PD, especially at the hands of beginner surgeons like me, is when we lift off the station A node of the common hepatic artery. Because it's easy to get the node of the artery, but then there are short, small tributaries running into the coronary vein. The bad part is it almost always bleeds, especially when I operate. But the good part is if we just pack it with a gauze and rather than overzealous attempts at hemostasis, the bleeding eventually stops. Secondly, since we are discussing about the first jejunal trunk, mostly we see it going posterior to the SMA, and that's when it drains one or two arteries. But it has been shown in literature by Nakamura and team from Japan, if you find a first jejunal trunk going anterior to the SMA, more often than not, it is draining more than just one or two venous segments of the jejunum. It is usually 3 or 4. In that case, it assumes special importance because the length of congested segment, in case we damage it, becomes more. And thirdly, as you showed a circumportal pancreas, I was lucky to be a part of one case with one of my teachers, Dr. Anand at Ames. We had a circumportal pancreas, and in that case, it has been shown that what you need to do is something called a double tunneling. That is, you tunnel over the portal vein, and again you tunnel over the SMA to get that extra tissue out. So those are the 3 points that I wanted to make. Thank you.
The coronary vein also carries importance. After dissecting the station 8A node, the coronary vein, the insertion of the coronary vein it can be at the splenic vein, it can be at the porto-splenic vein junction, or it can be actually at the supra-splenic portal vein. So if that happens, which is to be carefully seen in the radiology again, because if it is in the supra-splenic portion, then you can easily injure when you're doing a left periportal lymph node dissection.
The coronary surgeon, while performing this pancreaticoduodenectomy, they always resect this coronary vein near the portal vein and just at the origin because of the fear of the bleeding. It may have a torrential bleeding from the portal vein side, so they always resect.
Sometimes it does end up bleeding, and I think ligating it doesn't cause any harm. So ligating it carefully just before, if you're seeing it, is also.
The coronary vein, so usually, we can ligate the coronary vein theoretically, though it doesn't matter. If we get rid of the coronary vein, the right gastric vein is already gone. So mostly the drainage of that remnant stomach, especially the terminal part which you're going to anastomose, relies only on the left gastroepiploic and the short gastric. It doesn't make a difference because when you take a gastric conduit, usually it is one vein that is draining. But I feel that some part of ischemia or congestion at the end of the remnant stomach, if you ligate the coronary vein, can predispose to delayed gastric emptying later on. So if you can preserve it, well and good, but if you have to ligate it, it's not catastrophic.
Thank you, everyone. A nice discussion going on. So coming to the jejunal vein. So you sit in the console and do a coronal recon and see what is the size of the first jejunal vein and the ileal vein. If the ileal vein is close to 1 centimeter, like I would say you can bring down to 8 mm, then in intraop, if you are scared, still scared, and you are doing a vein resection, you just clamp the first jejunal vein before dissecting and see the congestion. Wait for 5 minutes. If in our experience, if the first ileal vein is, because now in many situations you have to resect the first jejunal ileal confluence. Previously it was unresectable, but now because of neoadjuvant therapy, you have to resect and you have to put a long graft and give anticoagulation lifelong. People have done this, we are also doing this. So if it is 1 centimeter ileal vein, a graft can easily be placed. Usually it doesn't matter, but be careful, you can just clamp it and see whether how much congestion is there. In one patient, we had difficulty, so we have to put another graft from the ileal vein to the splenic vein. So there were two reconstruction. One PTFE graft from the ileal vein to the portal vein, another like just portal vein below the SMV below the portosplenic junction, another graft from the first jejunal vein to the splenic vein because that part was getting congested. So if you are trained in vascular surgery, usually you will do something there. Usually it doesn't become unresectable. Secondly, the coronary vein. Coronary vein important comes when you are doing a sacrificing the splenic vein. Usually still also you can sacrifice the coronary vein. Usually doesn't happen, doesn't much happen. But if you can see there is a large coronary vein and your reconstruction is below the coronary vein, portal vein junction, question doesn't arise if this coronary vein is going to splenic vein. Then preserve it and safely ligate the splenoportal splenic vein, nothing happens.
So we'll begin with the last session before we break for lunch. The topic will be surgical anatomy of distal pancreatic resections. The speaker will be Dr. Anand Narayan Singh sir, who is an associate professor GI surgery, AIMS, New Delhi. The discussers will be Dr. Kanchan ma'am, who is a consultant robotic lab GI HPB surgeon, Jupiter Hospital, Thane. And Dr. Kulbhushan Haldia sir, who is an associate professor, Department of GI surgery and liver transplant, Geetanjali, Jaipur.
So good afternoon to everyone. I'm Anand from Delhi. I'm audible, sir?
Yes, please go on.
Yeah. Thank you, sir, for giving me this opportunity. And due to flights problems, we are not there. So my task is surgical anatomy of the distal pancreatic resections. So distal pancreatic resection is actually a group of it's a multiple level of resection is performed when you do the distal pancreatic resection, unlike the pancreaticoduodenectomy in which plane are defined. Here the plane in all the axes are different, and it depends on for which region you are doing the distal this resection. So I will, because the task of this conference and meeting is not the indications, so I will not go in detail, but depending on the malignant potential, probability of benign or symptomatic pre-malignancy, you have to decide how much pancreas you are going to resect and where and how in which plane you are going to do the surgery. So we have already gone through the anatomy multiple times. So I will not go through in the detail, but this is the usual anatomy about the body, about the distal pancreas is neck, that is anterior to the superior mesenteric vein portal vein axis, and just lateral to that, up to the lateral part of the aorta is body, and then from that up to the splenic hilum is a tail. That further divided now is in two parts. The reason of division is that these patients will behave differently. So if you are removing only the tail part, the prognosis and outcome is different than if you are resecting at the level of neck, or even sometimes right if required in those cases. Arterial anatomy are already well discussed by Dr. Ashir and other speakers. So there are three major branches: splenic artery, which supply the body and tail of the pancreas. And as a surgeon, we will encounter these artery, but many times actually, depending on type of resection we are performing, they will not come into the picture when we are doing the surgery. And these arteries, dorsal pancreatic, great and caudal pancreatic artery, but they are important when you are doing the especially spleen preserving and not spleen preserving pancreatectomy without vascular dissection. Then this become very important, how to isolate these vessels and secure hemostasis properly. Veins are mostly, they are corresponding veins, and many a time they are unnamed veins which drain into the splenic vein, or sometimes into the inferior mesenteric vein or other superior mesenteric and portal vein axis. Lymphatic drainage, this is important because it's also decide how much lymphadenectomy you are going to perform, especially in a malignant diseases. If the lymphatic is draining toward so lymphatic drainage is on the both side of the pancreas, and the left lateral part, they are the primary first channel is station is the hilum. On the other, it's on the gastroduodenal and IPDA. Along with that, will go to the celiac, SMA, and 16A2. So 16A2 is again a very important is part of the lymphatic drainage. Sometimes directly lymphatics will go into that part, and so although most of us will take it as a systemic disease, metastatic disease, but yeah, there are a few people who think that that should also be resected, especially from the eastern part of the world. So so just moving from the anatomy in the real world. So in the real world, we are actually not operating this patient because this is a normal pancreas, and what we have to operate actually is like this. When all the planes are pushed, they are threatened by the tumor and by the disease. So we have to decide our plan in each and every patient accordingly. So I believe that whatever we learn in anatomy classes and our basic classes, that's very important, and that's actually the basic for the further management. But as a GI surgeon and SPP surgeon, we need to be very specific. Patient specific anatomy we have to learn. And what I say is know your patient anatomy. That's very important, because before contemplating any surgery, we have to know the anatomy of our patient. And for distal pancreatectomy, I think the three important axes where we have to go. So the first is the anterior posterior axis, and we know that anterior posterior axis is was from Strasbourg group, and now almost from last 20 years is very much people are practicing this in various especially malignant diseases. That is how much posterior we have to go for the achieving the R0 resection rate. The idea is you have to do at least 1 millimeter, that is 1000 micrometer negative margin for R0 resection rate. So we will discuss about in cases. The other axis is the medial to lateral. So depending on the tumor, if the tumor is where the tumor is in the tail or tumor is sitting over the neck, we have to decide what will be the level of the pancreatic transection, as well as so it can vary from the level of neck, yeah, sometimes even to the right of the neck, and then it will go on the left depending on the margin you are requiring. You can do the central pancreatectomy, or you have to do the splenectomy, and this medial and lateral axis is important. And then there is a craniocaudal axis. What we have seen in the CT in the previous slide, this tumor may be big enough, they can involve the stomach, and they involve the cranially, and caudally they can involve the mesocolon, colon, transverse colon, and we have to plan the resection. So before contemplating surgery, I think this anatomy of the patient we should know what in all three plane, what is our plan to do the surgery in these cases. So this is about the posterior plane. That is the anterior posterior plane. So this is Aloysius pancreas, and the portal splenic vein is this is the splenic vein. So normally in a benign, symptomatic benign cases are very low malignant potential. So this green line is the line of resection we do, and in which actually we are not very concerned ki we are taking the lymph node along the superior mesenteric artery and other vessels. We just go beyond the splenic vein and we continue on that direction. It can be the antegrade or retrograde. You can do from left or from right. But in a malignant cases, in a malignant patient, you have to do you have to choose your plane. Like this is the red one is a plane. When you do anterior, we go along below the renal fascia, and you have to go along the anterior to the renal vein, and you have to go to the further move anterior to adrenal gland, and then you have to resect the whole thing. However, if the tumor is going beyond the posterior surface of pancreas, it's better to do the posterior. This is the level 3 resection, because this will there is a higher chance of R0. Theoretically, there is a higher chance of R0 resection rate. Also, literature is still divided. So you have to decide your resection depending on not only the posterior extent, but also where the tumor is sitting. If the tumor is sitting in the neck, it might be away from the adrenal gland. So you might not need that. If the tumor is sitting just anterior to the adrenal gland, you have to remove the adrenal gland along that. And that's actually bring the most, actually I should say it's very famous, is RAMS. So RAMS is three important component of RAMS are radical. So this is for the higher R0 resection rate, integrate from medial to lateral, and the modular. Modular is very important word, because you have to plan your resection plane based on the CT preoperative CT scan, whether you are going for anterior ramps or posterior ramps. So already we have discussed about the left gastric vein anatomy. I think that's very important, especially when as we are discussing that if you are doing the vascular resection and you are ligating the splenic vein, in those cases, left gastric vein is the only vein, main vein, which can actually take care of this gastric congestion. Otherwise, there is a higher than 1/3 of, if you say in Germany, Hackard group, they have around 1/3 patient develop the gastric necrosis in the if the left gastric vein is not properly handled during the surgery. So there are lots of variations that left gastric vein can, and this variation are very common. So in a good CT, actually many times you can identify left gastric vein, how that left gastric vein going, and if this is going into the portal vein, unlikely it will come in your field if you are doing the distal resection. But if it is draining the splenic vein, you have to be careful, and even at the confluence of the splenic and superior mesenteric vein, it might drain, and at that time you have to take care of. The other vein is inferior mesenteric vein for distal resection. Although mostly it's clinically not going to cause much problem, but there is a fair chance that there will be the bleeding if you are not able to identify the vein properly in that area. A few technical tips before we will go to the various cases. So that is one is the splenic, how to, where when you are doing the distal pancreatic resection, you have to identify the splenic artery. And splenic artery, the best is over the anterior superior border of the pancreas. And what I think is better to dissect first common hepatic artery, take out remove the 8A and 8B lymph node, and then go medially towards celiac axis, and you can identify the splenic artery, especially when the tumor is sitting over there. Otherwise, in a good habitus patient, actually you can get the artery up front there also. However, if you're planning for the distal resection and your pancreatic transection line is not at the neck level, you can identify depending on your transection. If you're planning transection here, you can try to identify splenic artery at this level, and you can leave this artery for the rest for the vascular supply of this part of the pancreas. And in some rare variant, the splenic artery may push posteriorly, almost parallel to the splenic vein, and in those cases, you might able to not find the artery at the anterior, superior to the pancreas. Dissection of left renal vein. This is important because in RAMS, our plane lies anterior to the renal vein, that is behind the renal fascia. So anterior renal fascia. So this vein can be identified by multiple way, but most people will do the supracholic approach, in which what we do, we have to identify the neck, translate the neck, identify the splenic vein, divide, and then further you go palpate the aorta and superior mesenteric artery pulsation, and then go further posteriorly to identify the renal vein, and then identify the fascia, and you have to go on the surface of adventitia of the renal vein for the proper plane, and then you have to move from medial to lateral in that plane to for your anterior or posterior ramps, whatever you are planning. However, in some difficult cases, when the tumor is threatening, you might have to go from the infracolic approach through the mesocolon and identify, especially from the DJ side, you can identify your left renal vein, and then you can plan your RAMS procedure accordingly. So these are the few picture we will see in the video. So this is the like common hepatic artery. The GDA is you have to preserve. The GDA is retracted, and then you can make a tunnel from. You can identify the portal vein here, and then from below you can we have to identify the superior mesenteric vein and make the tunnel, and then the pancreas can be divided. Then a splenic vein will be visible in front of you, and depending on the tumor, you have to plan your splenic vein resection, and then further we have to go posteriorly up to the renal vein. So lymphatics, as we have discussed, so if you are doing the surgery tumor in a neck or a proximal body, I think you have to take this lymph node 8A, 8B first, and then proceed in that along the common hepatic artery towards the celiac axis, and then this whole lymphatic can be actually transferred behind, mostly between the aorta and the left gastric artery on the left side, and then when this is on the left side, your plane will be below the anterior renal fascia if you are doing the RAMS, and then you can this whole lymphatics will come along with your specimen. CT protocol we have discussed. This is important, and this is the most I think important part pre-operatively you have to do in all these patients. So I will just discuss few cases. She is a 61-year-old lady having early satiety and upper abdominal lump, and having significant weight loss in the last 6 months. And there was a large tumor. So she was diagnosed with some pancreatic lesion few months before the symptoms, and she was on follow-up. Initially, it was thought a serious only, but because of the increase in size and symptomatic nature, we decided to operate this patient. And intraoperatively, you can appreciate that this tumor is bulging from the lesser omentum, and is although it's not infiltrating in that region, then you have to look what I said, the caudal extent. So you can appreciate the tumor is involving the mesocolon. Luckily, the vessel is away from any major colonic vessels. So we decided we will just open the gastrocolic thing, and then you can appreciate the tumor is infiltrating. It looks like inflating and densely adhered with the mesocolon, and then the further dissection was done. So this was the picture, looked like serous only grossly to us, and then we did the surgery. And this is picture after. So we did actually mesocolic resection without any colonic resection, and we did the conventional distal pancreatectomy because the patient has a multiple comorbid condition also. And there was doubt is serous versus MCN. So we thought we will do. This is the vessels we are. You can appreciate the left gastric vein has been preserved. This is coming from over the common hepatic artery and draining at the confluence. So you need to be careful to preserve these vessels. And this is a splenic artery which has been ligated here. So all the splenic vein. So in this we are not able to because it's a conventional RAMS for serous tumor and gross the final histopathology also suggestive of the serous only. And this is the left gastric vein which are draining just below the splenic vein which is ligated and divided.
Anand, you have 2 more minutes, please.
Okay, sir. Yes. Okay, sir. I will do fast. This is a okay. So I will just discuss this case and we'll stop after that. So this is the
If it is very interesting case, take 2 extra minutes.
no, sir. Okay. So this is the posterior rams. I will just go through the surgical part. So we have to identify. We have did the ultrasound, intraop ultrasound, and then this is actually anterior rams. The tumor was sitting over the neck, and so yeah. So what I said, first the common hepatic artery loop, then this is the left splenic artery which has been looped, and then we we divided we looped the splenic vein. This is splenic vein is being looped, and then vein was divided. So I will just try to show how we will reach the our plane. So both vessels have been divided. Now you can appreciate this is a vein. This is the left splenic artery. Now we are seeing the pulsation of aorta as well as the superior mesenteric artery, and then we will go in this area in this plane and try to go up to the renal vein so that already renal vein has been exposed, and now here the adrenal gland along the adrenal vein you can appreciate the adrenal vein here, and the whole fascia of anterior renal fascia is being mobilized further towards the thing, and then finally we will divide the spleen and all. So I will just move on. So this is the anterior renal fascia. You can see this is covering whole of the specimen. So I think it's posterior rams. I will just show the specimen, and yeah. So this is a posterior. It's after a resection actually. So you can appreciate in this case actually we did the total gastrectomy with posterior rams and segmental colectomy because the tumor was IPMN and infiltrating the both stomach and colon. So this is the this is a divided actually pancreas was dilated also in the head region, but there was no mural nodule, so we left the head portion and we didn't do the total pancreectomy, and then posterior ramp was performed. So I will just move. This is the specimen, and I think yeah. So adrenal gland is removed along with the specimen. So yeah. So this is the I think my last slide. This is the spleen preserving distal pancreectomy was done. So what I was saying that these vessels will come into play when we are doing the spleen preserving distal pancreectomy in this patient. So to summarize, so we need to keep learning and relearning and again learning the anatomy. And the good quality pre-op CT is an MRI is must. And we have to plan our extent of surgery in the pre-operative direction, know your patient anatomy and meticulous surgical technique, and respecting the anatomical plane is the key for better peri-operative and even the long-term outcome for in malignant diseases. Thank you very much, sir.
Thank you, Anand.
Excellent presentation, sir. Sir, I have 2 questions. What is your take on central pancreatectomy for central body tumors? And have you ever left the remnant pancreas, like the distal portion of the pancreas, without anastomosing it to the jejunum?
So, for central pancreatectomy in a symptomatic benign or maybe low grade benign, low grade malignant tumor, even in a SPEN in a young girl, I have done in a few patients, and in all the patients I have drained the distal pancreatic stump. And the thing is in some patient, actually one of the patient who was operated 2 years back, now even that because I did the duct to mucosa, it's a 1.5 mm duct. Now the duct is stenosis, but still the parenchyma is atrophic, but still significant parenchyma is there, and patient is free of diabetic almost 2 years post surgery. So although it's a high risk because there is 2 anosmosis, 2 cut surface at the risk for leak. As far as the non-draining and draining of the stump, I haven't done this, but yeah, in our department, I think couple of cases has been done. They have associated with a significant morbidity. So until unless it's a very small and it's not feasible to do the thing, drain the thing, I think better to drain the distal stump. Yeah, or otherwise just remove the distal stump and do the complete total distal pancreatectomy and not the central one.
But Kanchan, for the benefit of students, please tell, is it an option? If it is an option, when would you exercise it?
So basically, the prerequisite for doing a central pancreatectomy, you should have at least 5 centimeters of the distal stump left. Only then you can anastomose it to the jejunum. But say if you are dealing with a benign lesion and you don't have enough stump left, rather than going ahead with resection of the distal pancreas in younger patients, we do opt for leaving the remnant behind because it not only serves as a drainage function, but it has its hormonal this thing also, hormonal importance also. So it will act as a continuous, hormonal ejection of your insulin, glucagon, and patient could be diabetes free for the rest of the life. So we are still evaluating these set of patients. It's a very small subset of patients, but yeah, it can be done if you have only a 2 or 3 centimeter stump left.
What is your experience with
I have seen
No,
that.
if it
Let Anand. Yes, Anand.
Sir, what I have seen that if you leave the stump until the pancreas is atrophic and replaced by fat upfront, these patients develop a significant pancreatic fistula, and even in one of patient there was a significant hemorrhage. So that's why I'm not very keen to leave the thing. But yeah, I agree with Dr. Kanchan that it will take care of the long-term glycemic control, and definitely it might be a very good idea if the perioperative outcome is okay.
Yeah, Manpreet.
So I wanted to ask Dr. Kanchan's experience with the pancreatic leak after leaving a.
It's a small subset of patients, and we have not had any leaks so far. That's why we are still evaluating these subset of patients.
Kulbhushan.
Thank you, sir. A very nice presentation. Sir, I have a question because we all know that the most devastating complications of distal pancreatectomy is post-pancreatic fistula. So what measures will you take to decrease the chances of this pancreatic fistula?
So the first is that your pancreatic stump, the vascularity of that should be good. So whatever we have decided that this will be the pancreatic transection line. Before that, we have to take care of vessel. Even if you are doing the lymphadenectomy in that region, you need to preserve the vessels and vascular supply of the pancreatic stump we are leaving behind. And second, as far as all the technique we have tried, including the suturing of the duct, and but mostly now we are doing the pancreatic only with a stapler. There is a leak, but most of these leak are manageable, and they might need prolonged drainage for 3 to 4 weeks, but in some patient, but most of the time we'll able to manage the pancreatic leak in this patient.
Which stapler you are using? Like white or blue? Which cartridge you are using for the pancreatic?
Depending on the thickness of the pancreas. So if the thickness is less, then we are using the blue one. But if thickness is slightly on a higher side, we sometimes use the green, but preferably we are using the blue one.
Sudeep wanted to say something. Mike. Yeah, while Sudeep is coming in, again for the students, if you're doing a distal pancreatectomy, before you ligate, clip, or divide the splenic artery, make sure that it is not the common hepatic artery.
Yes, sir. I think that's if you come through the common hepatic artery, and then chance is reduced. So that's
yeah. So same precaution which you take when ligating and dividing the GDA, that you first put a clamp, a soft clamp, look for the pulsations in the HDL. Same precaution. This must be a routine. Whenever you are doing a distal pancreatectomy, it must be a routine that you put a clamp on the so-called splenic artery. Make sure that there are pulsations in the HDL. Yeah, Sudeep.
Nice discussion again. So 2-3 points. One is that we use a golden cartridge 60 echelon routinely when we are stapling the pancreas. We don't staple pancreas in all the situation. If the pancreas is soft, pliable, if pancreas is hard, we don't staple. We cut, identify the duct, suture it, like that we manage. because if you staple a hard pancreas, it will there will be shearing force, it will cut through. So the softer pancreas, when the pancreatic neck size you can measure, there are papers on that in a preoperative scan. If it is around 1.2 centimeter, maximum 1.5 centimeter, softer pancreas, that is ideal for stapling with a very, very low leak rate. We use a 60 echelon gold cartridge. The trick is that you have to close it very, very slow. So you cannot just crush it. So you have to close it slowly. Maybe I close it over 5 minutes and then wait for another 1 minute. And then I fire the stapler. In a suitable pancreas, leak rate is very, very low. This is one comment. Second is, I want to know that distal stump, you staple, keep it when you are preserving, or how do you tackle that? Like
Staple it.
Stapler only. We have done in one patient, but that patient had whatever complication possible on the earth the patient had. There's pleural effusion, pancreatitis, bleeding. Ultimately, he survived. He was 35-year-old man with a man with a benign tumor, rare, but he had. So we preserved around 5 centimeter of pancreas. It was laparoscopic. We did a same stapler technique, but it gave us a lot of nightmare. After that, we never did preservation of the small stump. But again, we will see the result.
Yeah, my colleague at CPGI, Dr. Rajneesh, who has extensive experience with pancreatic surgery, would always tell the students that when using a stapler on the pancreas, take double the time that you will take on any part of the bowel. What Dr. Sudeep said.
Yeah. So thank you, Anand, for a nice presentation. But I agree with Sudeep about use of stapler. It should not be a rule. It should be a selective basis. And if duct is seen, then you can, if you are to take a good suture, duct separately, and then you can take mattress and sutures to the pancreas if pancreas is not good. I was going to talk about all the discussion happened about Whipple's procedure only, but when we are doing anatomy becomes very, very relevant. We are going to do either head preservation in pancreas, or you are going to do duodenal preservation. Here the arcade becomes very, very important. And with the same, many years back, we did this anatomical dissection with one of our resident, Dr. Hemanta. And we found that anterior superior pancreaticoduodenal artery and anterior inferior pancreaticoduodenal artery were more, almost 100% times coming from the present, and posterior was about 94%. The most important point was that posterior arcade was more consistent than the anterior. So once you are doing, and then distance between your mesopancreas, the mesopancreas was more consistent and more loose when we are doing intraampullary. So once you are preserving, and more, there was less of the mesopancreas when you are going supraampullary. So I think other than jejunal anatomy, all other things other than all these things are more important. We are preserving, like we are doing Fry's procedure, or we are doing a duodenal preserving head resection for any malignancy which is brand looking like malignancy, and you don't want to do a pancreaticoduodenal. Second important point I want to highlight about the celiac artery stenosis or clamping. So twice we have found it, and if you are seeing on the CT scan, if you can diagnose that there is a stenosis or something, rather than going and I am sorry to say this, rather than going on the operative table and thinking that this particular arcade might take care, we cannot take a chance. We should be 100% sure. Still, we have a mortality. So in the preoperative period, we have to take care of that either by stenting or whatever. Second is releasing. If you are diagnosing on the table, so gastroduodenal artery, once you are clamping and no pulsation, if you are dissected nicely, you are seeing the course of the hepatic artery, meaning thereby you are not clamped the hepatic artery. You have definitely clamped the gastroduodenal. Here is the indication that there is something in the celiac artery. And then you go and look at it and release this thing. And only release, recently only we did. Only release can bring the pulsation. Then only proceed. Otherwise, chance taking, to my mind, is absolutely not acceptable. And this is what are 2 or 3 points. And two, in one patient, we had to do a graft. In another patient, we released and it worked. So I think it is very, very important to have it. Thank you.
Sir, I want to ask one question. Sometimes it's difficult to differentiate or characterize the tumor in body, that these are the benign and malignant. So how do you approach them? Which plane do you go when it's difficult to differentiate between, like serous and mucinous is difficult to differentiate So how do you approach? You go for posterior ramps, anterior ramps, or remove adrenal, leave adrenal?
So it's all depend on the probability of malignancy. So if the probability is high, in a good risk patient, I will do surgery as a malignancy. Even if there is a benign, I will be okay with that. But if the probability is low and the patient is a poor risk, we have to do decide, we have to do like a benign, and we have to change our plan accordingly. And as far as anterior and posterior ramps is concerned, it's depend on if the any parenchyma is seen between the splenic vein and the tumor in whole of the posterior wall of the posterior parenchyma. If there is any parenchyma is seen on the CT scan, in a good CT scan, you should do the anterior ramps irrespective of the malignant in even the malignant cases. If the parenchyma is lost, there is not seen or is going beyond the splenic vein, posterior ramp should be the preferable thing. Although this is the most of people are doing, but the thing is there is recently a study published which is compared the anterior and posterior ramps, a retrospective study. They didn't find any difference in the R0 rate as well as in the long-term recurrence rate. So it's debatable. It's still not fixed, but this is the norm we are practicing.
I had one question. So we've been discussing distal pancreatectomy, and I would request Dr. Anand if you can elaborate on spleen preserving distal pancreatectomy. Like, what points would you take care? Which specific cases would you choose to preserve the spleen in? Do you ligate the splenic artery when doing it, or do you preserve it? How do you proceed with that?
So it's again the patient I showed is a young girl, 19-year-old girl, having is a likely spin. So spin is locally malignant. There is small, around 3.5 centimeter spin in the distal part of the distal body and tail region. So, and it's very encapsulated. The tumor was well covered with the parenchyma from all over. So in that patient we did. So in a symptomatic benign small tumor, low malignant potential, likely probability is there. Then in those cases we can do, and especially and they are away from the again away from the vessels and lymph nodes are not there. If those things are there, then we have to do the hysterectomy for the better oncological outcome. But otherwise, in those cases, we can do the spleen preserving. As far as vessels ligation, again, is depend on the extent of the size of the tumor and the lymph node. We can do the either vessel preserving, or we have to sacrifice vessel and do the Warsaw procedure accordingly. About the celiac axis thing, as Dr. Yadav said that actually pre-operative you have to look for celiac axis in each and every patient. And now we look for the replaced right hepatic artery, we should look for celiac axis. And then like pre-operative stenting as well as intraoperative, we have to sometimes take care of help of our CTVS surgeon, and we have to prepare and ready for the implant and grafting.
The future surgeon, MBBS student who's timekeeping, she wants to ask something. Yes. Sit. Use the mic.
Good afternoon, respected doctors. I am Sonal Agarwal from final year MBBS student. So my question is that I've studied that necrosectomy is avoided in first 2 weeks of necrotizing pancreatitis. Like, can I give a satisfactory reason why it is so?
So, may I take this question, sir?
So normally,
TD is taking it. Okay.
Yes, sir. Yes, sir.
I am taking on your behalf. So normally what happens, pancreas has two phases, acute pancreatitis of the, if you see the pathophysiology in the first 14 days to 15 days, it is inflammatory mediators, extensive inflammatory mediators. And if you see the course of the patient, it will be very difficult sometimes to differentiate from the sepsis part, other than going extra ahead and doing a procal and all those things. So it is decided. The second half, which is it starts about second, sometimes in third week, where sepsis starts setting in. So what is the role of a surgeon? Role of a surgeon is going and taking the dead tissue out.
So in the first week, what happened, their demarcation between the dead tissue and the living tissue is not very clear. Pancreas, as you have seen, is a extensively supplied vascular organ, extensively, and the drainage is so same. So if you are going in that area period, first is that you are not able to do proper necrosectomy, extensive hemorrhage occurs for no benefit. So suppose this was required, then you can take the risk. But here it has been found that it is a component of because of the inflammatory mediators in the first 15 days. So that's why surgery is not going to help in the first 15 days, except if you have some other indication, like sometimes you have find vascular ischemia or intra-abdominal hypertension. So you are not going to do necrosectomy to take the tissue out. You are going to decrease the problem which has happened because of the acute pancreatitis, inflammatory mediators only.
1 minute more. Anand, Sudha Satwa from Calcutta is asking you, what is your policy regarding vaccination?
So, sir, in a benign and low malignant disease, we give the vaccination and do surgery, plan surgery after 4 weeks. But even in malignant cases, if you can wait for 2 weeks, we vaccinate all the patient before surgery. And this is policy for distal pancreatectomy, as well as this is policy for when we do the shunt in our center. We have changed this thing. And we are doing the vaccination in all the patients who are undergoing ischemectomy. We are vaccinating the patient, all the patients. Sir.
Okay. Thank you. Thank you. So it's time to break for lunch. But before we break, we'll have a group photograph. Quick. And we'll be back at 2 o'clock.
Thank you, sir.
Pronto prova. Pronto prova.
फ्लाइट का भी और वीसा का भी दोनों
Good morning, Dr. Kapuras. Sorry to not be here, but yesterday was a terrible trip.
No, there are problems with flights also in India. Many of our Indian faculty have not been able to join. So it's okay, please.
But because I like India, is a wonderful country. But unfortunately, the company did not give me the authorization because I have a participation for a conference very important. So I forgot to do my visa, and the company ITA say me that I have no visa when I arrive in Rome. So I stay 1 day in Rome, and after I come back to Catania. So sorry.
No, see you next year. No problem. किसको अच्छा मुझे भी देखना पड़ेगा उन्होंने भेजा है? अच्छा मैं तब तक देख के तुम्हें देख लूंगा चलो शुरू करो 1 मिनट वो सुरेंद्र जी जब कहेंगे तो ये ले लो
सही ऑन ही है सर सुधा सेन भी नहीं है ऑनलाइन है टू o'clock नहीं है 2 मिनट 3 मिनट बस यस सर बाकी लोगों की हुई Good afternoon, faculty members and my dear colleagues. So now we are starting the next session. Next session will be on biliary. The topic will be anatomical variations important for the cholecystectomy. And our presenter will be Dr. Ragini Kilambi. She is a senior consultant at ILBS Hospital, Delhi. And discusser for the session, Dr. T.D. Yadav, sir. He is a senior professor at PGI Chandigarh. And Dr. Meenakshi Singhal. She is an associate professor at Mahatma Gandhi Hospital, Jaipur. So
Hello, good afternoon, Ragini. Hello, Dr. Ragini. You are muted.
Are my slides visible, sir?
Yes. Now you are audible also.
Okay, sir. A very good afternoon to all of you. At the outset, I'd like to thank Kapoor sir for giving me this opportunity. I also offer my apologies for not being there present physically because of the Indigo fiasco. But now moving on to the topic of interest, we are talking about anatomical variations that are important for cholecystectomy. So cholecystectomy, as we all know, is a very common procedure. In fact, the first laparoscopic procedure that most people would perform. The overwhelmingly most important complication would be a bile duct injury. Other complications like bleeding and visceral injury are there. So the two of the most important causes of injury in terms of bile duct injury are considered to be misidentification of normal structures and the presence of anatomical variations. So way back in 1948, Leahy stated that cholecystectomy is a dangerous operation unless one realizes that variations are very common. And that stands true today also. While there's a lot of data on anatomical variations that are present in terms of cadaveric studies or intraoperative studies, few have looked at the replication. The small study of about 300 patients showed that whenever you have anatomical variation, there is a higher chance of bile leak, bleeding, and conversion and overall poorer outcomes. And this is why knowledge of anatomical variations is important. So what is the anatomy when we talk about cholecystectomy? So we all know we are talking about gallbladder, cystic duct and cystic artery. Apart from this, the liver, which forms the gallbladder bed, the common bile duct, the right hepatic duct and the CHD, the right hepatic artery, these can be contents of your hepatocystic triangle, the duodenum, colon and omentum, which can be adherent and obscure view of the gallbladder, are important as well. When we talk about anatomical variations, basically anatomical variations can happen in two settings. One is physiological, you're born with it. So nearly 20 to 50% of patients, that is half of the patients, will have some form of biliovascular anomalies when we talk from cadaveric studies. But if we look at intraoperative data, this is much less because not all of these anomalies would be unmasked during our surgical procedures or even are relevant to us during the procedure. But with those which are relevant do increase the risk of a bile duct injury. The other form of anatomical variation that we encounter is pathological variations, where the anatomy gets distorted. You see unexpected structures in unexpected locations, and it can sometimes give the appearance of a variant anatomy when none actually exists. And identification of these pathologies is equally important, and probably more important, because you encounter these more often than the physiological variants. So when you are anticipating a difficult anatomy or a pathology that is distorting the anatomy, and this you can anticipate on the basis of history, physical examination, or certain ultrasound findings, it is prudent to get an MRCP as a biliary roadmap in these conditions in order to at least reduce one confounding factor for a aberrant biliary anatomy, so that you know what you are dealing with preoperatively. So while anatomical variations are important irrespective of your approach, whether you're doing an open, laparoscopic or robotic cholecystectomy, much of my talk is centered around laparoscopic cholecystectomy because that is the standard of care, but it applies to open and robotic approaches as well. So the first step when you're going to do a cholecystectomy laparoscopically is creation of a pneumoperitoneum or axis. So while in a normal situation, it doesn't matter whether you're a proponent of the open method, the Veress needle, or the optical trocar. This assumes significance when you have a patient who has a previous abdominal surgery and you're expecting a lot of adhesions intraoperatively. So here either you do a Veress needle in the palmar point or you use an open technique. What we have often found is in patients who have had surgeries where the lower abdominal surgeries incision extends supraumbilically, or you have an umbilical hernia mesh repair done, we have often had to place epigastric port with the optical trocar as the first port. We've had to alter our positions of the umbilical port because the bowel is densely adherent. Often the umbilical port is not the first, it is often the third or the fourth port to be placed once we have done adequate adhesiolysis from the axillary ports. The second step is once you are inside, you start dissecting. So most of the times, once there's been a gallbladder inflammation, you will see some adhesions. But these are not just pure omental adhesions. Duodenum and colon have a realistic probability of being adherent. So sharp dissection should be avoided till you have delineated the structure. If you want to avoid injuries, you should always look out for the presence of colon or duodenum. Patients who had had acute cholecystitis or Mersey syndromes could have cholecystoduodenal fistulas. Like in this image, you could see this is a patient who had acute cholecystitis with contained GV perforation, also with the tuberculosis of the liver. You have seen, she has a cholecystoduodenal fistula here, and these fistula, once they have been delineated and isolated, you could tackle them with a stapler, clip, or suture, as the case may be. The next step is once you have exposed your gallbladder, dissection starts in the Carrett's triangle. Critical view of safety is being touted as the method of preventing bile duct injuries. Now, critical view of safety has got three important tenets. One is you should see only two structures entering into the gallbladder, as you can see in this image. The second is that your callus should be free from all the tissue. And the third that you can see is that the lower third of the gallbladder should be lifted off. Now, when we say lower third is lifted off, what we're essentially ensuring is that not just two structures are entering into the gallbladder, only two are, there is no structure that is exiting the gallbladder, which would happen if you have lifted up the CBD or the hepatic ducts instead of the cystic duct. So when we talk about aberrant anatomy, the first and the third point are of importance to us. So when you have an aberrant anatomy, you may see more than two structures entering. You could have a supernumerary artery. So you could have more than two structures entering. You could have a aberrant duct, which is forming a part of the calyx also. And the second, but what saves you from having a bile duct injury is fulfilling the third tenet, that is no structure should be seen exiting. You should be able to conveniently lift up the lower one third. At this juncture, I would also like to say something that is often quoted is that the journey is as important as the destination. And this is nowhere is it more true than in the context of achieving the critical view of safety. So a lot of emphasis is placed on attaining the critical view of safety, but how you attain it is equally important. So if you use a lot of energy sources en route you are achieving the critical view, you may have already caused damage with either ischemic damage, or you might have ligated your aberrant ducts, low-lying ducts with your ligature before you have attained your so-called critical view of safety. So first structure we'll be talking about is the cystic duct. So normally we know the cystic duct and joins the gallbladder to the bile duct, and you could have multiple variations, but not all of these variations are technically important for us. The variations could be in terms of the length, the width, or the course of the duct. So while there are multiple definitions of a short cystic duct, what would be universally agreed is that anything less than 5 mm would definitely constitute a short cystic duct. The problem here would be that when you are going to retract the Hartmann's in order to clip it, you might end up tainting the CBD and taking a chunk of the CBD onto the specimen side. Sometimes when you have stones in the cystic duct which you are not able to milk back into the gallbladder, also you might have a much shorter working length of your cystic duct available. In patients who have Mersey syndrome, or when your calyx is getting obliterated because of adhesions, also you may have a very short working length of cystic duct. And in these situations, instead of hazarding to try and get into the space between the cystic duct and the CBD, if you can clear the stones, it may be sometimes better to leave a small part of the gallbladder onto the cystic duct CBD side rather than the other way around. Now, long cystic duct, if it is free from the CBD or the CHD, is technically not a problem. It is a variation, but it is not of much importance to us. The problem that's going to happen here is that sometimes this may be adherent to the it may be adherent to the CBD, and instead of looping the cystic duct, you are looping the CBD, thinking you have a very long cystic duct. Or sometimes you try to delineate your cystic duct and try to dig into the region between the cystic duct and the CBD, hazarding ischemia of the CBD as well as injury to the potential injury to the CBD. In such cases, all that we need to do in a cholecystectomy is define the point of the CBD, the cystic duct and the gallbladder junction where it is funneling, and clip it there. You may have a long stump. There may be some theoretical risk of a higher post-cholecystectomy gallstones, but this is not practically seen, and this is something as much better risk to take than that of digging down or trying to delineate it. But what is important is if you do get a long cystic duct and you are going down, you should be able to definitely fulfill the third tenet, that is you should be lifting off your GB, and this should be a blunt dissection. And once your lower 1/3 is off and you're seeing that the structure is only going into the GB and not coming out of it, there's no return, only then you're sure you're dealing with a long cystic duct. Next is the width of the cystic duct. So normal is about 2 to 3 millimeters wide. Sometimes patients will have a wider cystic duct. Now again, most of these would actually present with CBD stones and you would have had an ERCP done. But what is important in these patients is that once you have a wide cystic duct, the funneling of this gallbladder into the cystic duct is lost. Second, the joint between the cystic duct and the CBD is also not very clear. So here, if you are dissecting very close to the gallbladder, because there is no funneling, you may leave a longer length of the gallbladder, hazarding a residual GB. Or if you're going too lower down, you might, because you do not know where the cystic duct is stopping and the CBD is starting, you might encircle the CBD and clip it there again if you're not fulfilling your third part of the critical view of safety. Again, here it may be preferable to have a slightly longer GB stump than to hazard going lower down. When we talk about course and insertions, normally it is supposed to insert into the middle third on the right side, but there could be a low insertion when it goes into the lower third. This happens in about 10%. Medial insertion happens in another about 10 to 15%, where it enters onto the left side, spirals anteriorly or posteriorly. High insertion can happen into the upper 1/3. Now again, these are important only as in if you have a medial insertion and you try to delineate and you're using the energy source to separate to get your length of the cystic duct, may be causing inadvertent ischemic injury, thermal injury to the bile duct. The second, again here, therefore, identification of only the gallbladder cystic duct junction is important. Sometimes, in case of acute cholecystitis where the stone is impacted, even the entire GB may be, as you can see in this particular image, the first MRCP image, the entire GB may be going on to the left side of the cystic duct, and here a gentle meticulous dissection without using any energy source, blunt dissection to separate it is often useful, and trying to dislodge the stone is often useful to attain the length of the cystic duct that is needed. A long parallel course is similar to that we are talking about of a long cystic duct. Here the only issue comes when the cystic duct and the CBD are encircled in a sheath. Here you risk looping the cystic duct along CBD along with the cystic duct when you are going. Again, attempts to delineate the space between them is hazardous because you can produce ischemia, and leaving behind a longer cystic duct stump is better here. Aberrant drainages can happen. Sometimes the cystic duct can directly drain into your axillary right hepatic duct, sectoral ducts to the right hepatic ducts. Now, these are not something that, MRCP is not often performed in most of these patients, but sometimes when you do perform, like this was our patient who was a 35-year-old lady, acute severe necrotizing pancreatitis, multiple necrosectomies surgically performed, and she had an ileostomy. So after a hospital stay of about 6 months, we admitted her for a cholecystectomy with ileostomy reversal. And when we did an MRCP, we saw that the gallbladder is, the cystic duct is draining into the right hepatic duct, and she has also got a very low lying confluence. So again, here, if you do follow the principles of CVS, you are safe. So if you are going to be in the plane above this right hepatic duct, you will fulfill all your three principles and not have an injury. But if you go in this plane, instead of looping this cystic duct here, if you end up looping the right hepatic duct, only the fulfillment of the third tenet would prevent injury. Otherwise, you can lead to bile leaks and bile duct injuries. Now, dual cystic duct, aberrant or accessory intrahepatic ducts that are draining into cystic duct, these are very rare. And when you get these sort of picture, you should always think about CBD. So things to remember when you are encountering anomalies is that your cystic duct could be long, but will still not go beyond the duodenum. Double ducts are very rare. Think about CBD. Cystic duct does not have very visible vessels traversing on its surface. Now, true absence of cystic duct is so rare that if you're not getting a thing, it is more likely to be adherent and obliterated over actually being truly absent. And one important principle is that your aim is to delineate the cystic duct GB junction and not the cystic duct CBD junction. The prevalence of these variations is much less than that of artery. So nearly 80% of patients will have a normal cystic duct, and the other variations are more in terms of the length of the duct than actual course or the supernumerary ducts. Next important structure is the cystic artery, which arises from the right hepatic artery and enters into the gallbladder near the body or the neck area. Just before it enters, it divides into two branches. The variations of cystic artery are more frequent than that of a cystic duct, but most of these variations, like those of the duct, are unlikely to affect us whether it arises from the left hepatic artery or the common hepatic artery. As long as it is traversing its normal location in the hepatocystic triangle, it is not of much concern to us. Now, normally the cystic artery is supposed to divide into an anterior branch, which is superficial, and a posterior branch, which is deep. And sometimes it can give individual branches to the gallbladder as well. Now, if the branching point is very proximal, it may actually appear as two cystic arteries. So here we can see this here is the deep branch. And if you are not very careful, you can injure this, and this can lead to bleeding. What is also known is that cystic artery gives very constant branches to the cystic duct, which need to be divided in order to get a clear calyx before you can clip. And sometimes it can run very deep into the onto the cystic plate, and we have also seen cases where it has returned back into the liver onto the right side. So early division can give rise to this appearance of a V-shaped dual anatomy, or you can have a Y-shaped thing. So problem is that if you are not very careful and there is bleeding, that can obscure vision. Blind clipping can produce further damage and need for conversion. Here you can also see that if you are getting too many arteries, you may also have a confusion that one of these arteries could be a right hepatic artery, which needs to be clearly delineated before any clipping happens. But what helps is that a cystic artery will usually not pulsate. So if you're seeing a pulsation, think of a right hepatic artery. A cystic artery can occasionally be found outside the calyx. That is, relatively, the cystic duct and the artery positions can be reversed. This often happens when you have got an artery that comes from the GDA or from a replaced artery which has got a low origin. Now, this is important because normally this is the place where you start off your dissection of your calyx, and if you are using energy device and you're not careful, you can have bleeding from the cystic artery without actually it being clipped.
Ragini, you have 5 more minutes, please.
Okay, sir. So cystic artery syndrome, this is described in 2000, not of much importance, excepting that it hooks around the duct and you may have to leave a longer length of the duct here. So arterial variations, as we can see from this table, are more frequent compared to the ductal variations and more supernumerary than ducts. Right hepatic artery, the only clinically important variation for a cholecystectomy is a Moynihan's hump, where it traverses, it becomes a part of your calyx, or may even actually go on to your onto the Hartmann's, or here you can see in this image the right hepatic artery is returning back to the liver. So again, right hepatic, if you're seeing a pulsation, think of a right hepatic artery. Problem is usually these cystic arteries which are given off by these Moynihan's will be short and prone for avulsion. So one should be very careful while dissecting here. Aberrant ductal anatomy, like low insertion of RPSD. Often we've seen patients with bile duct injuries who have presented with divided RPSDs, because when you are lifting the GB off the bed and you're using energy source for it, you can either cause thermal damage or you can actually divide it because of your cautery. Other things like low extrahepatic confluence or duplication of CHD, these are rarer, but one should be very careful for preventing any bile duct injury. When you have a doubt, when you have getting a very confusing anatomy, it's useful to use a cholangiogram, either an intraoperative cholangiogram, an ICG, or a laparoscopic ultrasound to clear it out. And some anatomical landmarks have been found to be useful as points of starting dissection, but it is important to remember that these themselves are subject to variations. So while all of us want a nice open Ruvier sulcus like this, or even a closed one like this is acceptable, sometimes you may not have a Ruvier sulcus at all. It may be completely absent, and there you have to look for other landmarks to guide your dissection. When you get an aberrant anatomy, it is always useful to use timeouts to make sure that what you are getting is actually an aberrant anatomy and not normal anatomy which you are construing as being aberrant. And getting a second pair of eyes which can look fresh at your aberrant anatomy is important. One must remember that case reports are case reports, and if you feel that what you are dealing with is a potential case report in the theater, definitely get in a second set of eyes. While clipping and dividing, one should remember that we could always have a low-lying RPSD or duct in the GB bed, and therefore it is important that you visualize both limbs, and inadvertent clipping, partial clipping in your or nicking while dividing can lead to injuries even if you have done the rest of your procedure meticulously. This I'll skip for want of time. Now GB bed. Now this is also another potential area where we might end up getting aberrant anatomy. So you can see this video. You have a nice hepatic venous pulsation here. We can see. So while all the other structures may be delineated, if you are using an energy source, you could have torrential bleeding from superficially lying branches of MHV. You also can get subvesical ducts of Lashka or Heberland. Now, here I would again give a word of caution. If you are getting these aberrant ducts in the lower 1/3 of your gallbladder, please be very careful that these are not sectoral ducts. In the upper 1/3, it is okay to clip them, but in the lower 1/3, one should probably do a cholangiogram to see what you are getting from. Gallbladder anomalies like a totally intrahepatic gallbladder. Here you may require division of some amount of the hepatic parenchyma, and this could lead to some amount of bleeding also. And left-sided gallbladder, now this is extremely rare, but this is associated with other anomalies. It's often an intraoperative surprise. So I do not have the intraoperative picture of this patient, but she was referred to us from outside after somebody put in a scope, saw left-sided gallbladder and withdrew. But these are all going to be intraoperative surprises. Here the umbilical fissure is going to form your GB bed. So again, one has to be very careful while dissecting. Duplication, extremely rare, more of a case report. Again, pathologies like portal hypertension.
2 more minutes, Ragini.
So I'm wrapping up, sir. Last slide. So portal hypertension, again, one has to remember that you're going to get aberrant vessels, you're going to get large dilated veins, either in your calyx or as you can see in this patient of EHPVO, the GB bed, the calyx, all these have got veins and in the omentum, and these have to be taken care of. A cirrhotic liver may not give you sufficient pliability for retraction, or there will be more bleeding compared to the extent of portal hypertension that you are getting in these patients. To summarize, anatomic variations are a norm in the context of biliovascular anatomy, but not all of them affect our procedure. Preoperative imaging in cases of anticipated difficulty tends to reduce at least one obstacle. Knowledge of frequency of variations can help guide safe dissection. How we achieve CVS is as important as the task of achieving CVS itself. Do not assume aberrant anatomy unless proven otherwise. Do not attempt to delineate a cystic duct CBD junction. Preoperative imaging and intraoperative vigilance are keys for reducing complications. Thank you.
So thank you, Ragini. You had to cover lots of points about bile duct injury, and on the cost of repeating some important points, I would like to just summarize, because I am in advantageous position of being a discussion. So as you said, that variation can be because of the anatomy, and the anatomical variation can be because of the physiology and pathology. So I will just summarize for the benefit of the people that if you take the history, what are the history which can change the anatomy? So if you take the history, if there is a history of acute cholecystitis, patient has been managed. If there is a history of acute severe pancreatitis, if there is a history of CBD stones, if there is a history of people who have removed CBD stone or they put a stent, then obesity and male gallbladder. These are the people, they are the high risk for the conversion as well as for the bile duct injury. So everybody should remember point wise. Then I will go to the imaging. So MRCP, we all know that not used every time. So some anomalies, what Dr. Ragini has told, can be only seen on the table when you are very careful. So second important is what ultrasound. If you are doing ultrasound, you are finding a thick, contracted, packed with stone gallbladder. Second important is on palpation mucocele, and you are finding impacted stone at the neck. Third important point on the ultrasound is, again, if you are having some other association, like you can see some sort of incidentally detected portal hypertension. So people don't have significant portal hypertension, but that happens usually is in CLD as well as in extrahepatic portal venous obstruction. So coming to the third point where on the table. So I think these are the very, very important points. So how you are going to take care of those points, as I have said, when you are doing the surgery on the table, other than what Dr. Agni has said, if you are having a palpable gallbladder, mucocele, the best is just to go and aspirate the gallbladder, put a needle and aspirate it. What happens that the stone which has impacted might fall back in the gallbladder and give some space. Second important will be dissection at the next subserosal dissection. So what Japanese describe, posterior dissection. You go posteriorly and dissect, open the subserosal plane between the cystic plate and another fascia which reflects to the Glycinian capsule. So if you are dissecting in between that, you are away from the chylets, you are away from all the anomalies, and you would like to make a space. So it gives you another 1 to 2 millimeter space in the cystic duct. Then come anteriorly and try to hug the gallbladder and dissect. Try to dissect, open the subserosal layer again. It will make the artery clear. Then the best friend is cystic lymph node, which is missed sometimes. If lymph node is present, it gives you alarming sign that don't come medial to me, just stay lateral to me. So if you are finding a cystic duct lymph node, you stay lateral to it and start your dissection. Third, Ragini will go listen, and if any important point I have some left it, you just go ahead and tell me. So third very important point would be that while dissecting, as Monihan's this hump is there, so you just dissect without using, you said that people are using now ligosure. So the message from Dr. Agni's statement is that in the chylets, until unless you are able to find the anatomy clear, don't use energy sources. You should, as a resident, know the tube temperature of the energy source you are using. So like monopolar cautery, depends on the setting and the timing, what time you are using. And also, you should also remember that magnification you are using. So something about 2 millimeter away, you will be finding that it is very close when you are doing it. So it can generate temperature up to 600 degree. So your hand can burn by monopolar cautery. So it is very, very important thermal injury. Second is all the ligosure and harmonic scalpel has not been shown to decrease the conversion. If they are used without anatomical clearance, as Ragini said, you can injure the hepatic because it will clamp the hepatic artery, right hepatic artery. So it is very, very important that we should use, we say that suction dissection. Dissection in the suction, by the suction, and try to make this thing stay away in a difficult situation. All these tips are very, 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 very important. And one more point, like rubeal sulcus, you said about 70% of the people have rubeal sulcus there, and you draw imaginary line from rubeal sulcus going to the base of the segment 4, and you stay lateral to that. So if all these things you are systematically following, like what we say prayer in the temple, you are following certain rules. So if you are following during gallbladder surgery, because you should know that this is a benign disease and it can have a morbid complication, it can have a mortal complication. So MRCP is not irregularly used, but ERCP, if any prediction, any sign is there, then one should go ahead and do this thing. Now after cutting, so we are applying clip also. As Ragini said, I am emphasizing, you are using clip. You should try that while using clip, your clip is parallel to the axis of the common bile duct, so that partial clipping can be avoided. So it will be parallel, and concavity of the clip should be hugging the superior border of the cystic duct. So the clip should be parallel, clip should be hugging nicely so that it doesn't slip in the postoperative period. Second important, that if you are seeing a bile, so ensure that this bile is from where it is coming. This bile is there. If you are using laparoscopy, so you call somebody, it seems that bile. Everybody wants to say that this is something coming from the cystic duct or some duct of Luska. No. You should clear it. Do echolangiogram, whatever you do, and ensure. So if it is very small duct, 3 millimeter, you might get away with clipping. If it is more than that, then you have to go and do some sort of this thing, do echolangiogram. If it is draining in the same system, your duct, it is open more than 3 mm, but draining to the same system, through the main system, no need to do anything, just clip it. Otherwise, you have to see, convert it, ensure it, call another friend, do everything, put a drain. So I think these are the very, very salient, important points which can help to decrease the bile duct injury. Can we do zero? It's still a very this thing. Certain pathological will come in difficult cholecystectomy. So I think I will end at this stage by just summarizing that how we can take a lead from the history and from the examination.
from the ultrasound, which is a commonest investigation done, and then going in on the table also, use of energy sources. And then one more important point, I was just forgetting that when you are cutting the cystic duct, and if it is going down toward the duodenum, it's not the cystic duct. Remember, so cystic duct should fall back, it should be perpendicular to the axis of the common bile duct. So even if principle you follow every time, and every time before taking a bit of gallbladder, take the gallbladder up and just see the bed area. Any bile leak, anything can happen there. So I think these are the important points. Thank you, sir.
I mean, actually, comments.
I think Dr. Ragini has discussed all the anatomy, so I don't have any new thing. Our Royer sulcus, I find it is very interesting, and it is also present anatomically. Also, we can see that, and it is an important landmark. I mean, it is not being used, but it is a very important landmark for cholecystectomy.
Yeah, so Doctor, yeah.
Sir, after listening so many variations, I'm just thinking, should we do MRCP or imaging, contrast imaging? When
Actually,
should we
there are
do?
few Japanese centers and surgeons who do MRCP as a routine before every cholecystectomy. And the students must understand, cholangiogram for CBD stone can be selective based on low risk, medium risk, high risk criteria. But cholangiogram for anomaly has to be a routine. It has to be done in every case because there are no clinical indicators as to whether an anomaly is present or not. So you're right. But I suppose in our setup, we don't do it. We cannot and we should not recommend it because of costs and logistics. But as Ragini pointed out, if you are anticipating a difficult gallbladder, the point which Dr. T.D. Yadav also re-emphasized, you probably would be safer to have a preoperative cholangiogram.
And so one more thing I would like to add here, that cholangiograms like in preoperative MRCP can be of assistance in telling you that there is an aberrant anomaly. But again, arterial anomalies are more common, and that will not be picked up even with a good quality CT angio. You are going to miss these anomalies. Even an MRCP will not show you the cystic duct insertion always. So good quality MRs also, sometimes you will see that that particular biliary anatomy is not very well seen. So there is no replacement for following your critical view of safety or principles of safe surgery. That is what is most important if you want to avoid biliary injury. Nothing else works 100%.
So just two small points. While people do advocate, there are surgeons who do advocate doing an MRCP all the time. Their own studies don't show that they've been able to prevent bile duct injuries. So bile duct injuries occur despite MRCPs. Second, I think one of the important things that we as surgeons with big egos must remember, that safety is much more important than our egos. And there are times we should not forget that cholecystostomy becomes an option, which is life-saving at times, yours as well as patients. So you must never forget that there is an option called cholecystostomy. If you encounter pathology, which is difficult to handle even after opening, even after a conversion, you should always consider doing a cholecystostomy.
I would go a step further. Even retraction, even coming back is an option. If it is acute inflammation, you yourself can go back after 4 to 6 weeks. If it is chronic inflammation, probably you should refer the patient to a more experienced surgeon. Anand, you want to say something? No, so since we have time,
Sir, you suggested cholecystostomy, so it should be transhepatic or just cholecystostomy? Because again, it will leak, the bile will come in. So
if you are already in the abdomen, you can do it straight away there itself. If you're doing a cholecystostomy because you don't want to venture into the abdomen at that point in time, then you could do it transhepatically. But if you're inside in the abdomen, then doing a safe cholecystostomy is not a
I probably would back up what Nirjar is saying, that if I'm working in a setup where I can request my IR colleague to come in the theater, I probably would still prefer a transhepatic.
Yes, but they're often not very comfortable. Even if I have an IR colleague who's comfortable coming in, doing a number of other procedures, they're not necessarily very comfortable doing a transhepatic cholecystostomy.
So
They're very comfortable in
sir.
their own environment, and they may not be very comfortable in the operation
I mean,
theater.
for the students, the point which Dr. Nirjar is trying to make is that transhepatic cholecystostomy, which the IR people do, is safer in the sense that chances of bile leak around the tube will be less as opposed to a transperitoneal. And if you are doing a surgical transperitoneal, whether laparoscopic or open, I would suggest that if the omentum is available, take the omentum up, take the tube through a hole in the omentum so that the omentum gets plugged on the gallbladder along with the tube, and chances of leak or problems because of leak would be less. Dr. TD wants
So,
to say.
just since we have time, 1 or 2 points, important points I want to re-emphasize. So, suppose you are dissecting in a difficult area and you have clipped and cut something, and then you proceed further, going toward the right side, and you are cutting on the tube, another tube is coming in the way. What you say always that this is the first cystic duct, second cystic duct, duct oblongata, whatsoever, because the surgery laparoscopy, your mind game. You flow of your mind. Your mind is fixed. So that's why sir has described cholecystectomy. So the important message here is that if there is a second cystic duct, which is the mindset of the surgeon, because we feel guilty. So the moment it comes, you have to drill that this is the real cystic duct. The first cystic duct which I cut is a common bile duct. So very, very important subtle points which are, I think it has to be mugged up in the beginning of the career. After certain times, if you see there are literature is supporting that certain people, like people called surgical hemorrhage, have more bile duct injury in spite of the extensive experience they go on doing bile duct injury because of the mindset. So you are seeing the something. So your power of identification of the structure is depends of your power of mind power of reading the image and taking a decision. It's not a direct thing. So I think this varies in every person. So I think this is very, very important. That's why there is a timeout phenomena described.
Just wanted to comment on the second pair of eyes. Ragini said seniority doesn't matter. She put it on the slide, but she didn't say it. So I think it's something that's important to say that get a second pair of eyes. It doesn't matter whether the person is junior to you or senior to you. As long as the person has some experience of doing cholecystectomies, that second pair of eyes is important. A lot of us would look for a senior colleague. Now, if you're white-haired, then you're unlikely to find another white-haired person in the same operation theater at that particular point in time. Don't hesitate to get a black-haired person.
So, but sir, the timeout is described for your staff nurse who is standing with you and your senior agent. Everybody, you stop there and ask, I'm clipping it, am I correct? So it, as sir is saying, it's not that this thing, it's important to take the opinion because once you are committed that this is cystic duct, you are not going to accept. So this is very, very important. That's why I'm saying it's more of a mind game, mind flow of your mind, how it is flowing. Only another person can stop your flow. No, you cannot. So that's why it's very, very important.
I'll just like to add here, like I for want of time, I could not say a lot of these things. But then the fact remains that when you clip, at least all members of your operative team should agree and should be happy enough with to go ahead with, and they should also be, a lot of them times they will be junior to you, but at least they should have the freedom to express their thoughts. It's better to express on table that they think that something is not right than having to regret it later. And it's been said time and again that it's only about misperception, because once you start seeing the anatomy in a particular way, you will not be able to yourself unsee it and see it properly. So therefore any fresh pair of eyes will help us. And whenever we feel something is not right, then stopping, waiting and going. It's been shown that when you start using timeouts, even achievement of critical view of safety becomes better and reporting becomes better, and usage of bailout procedures actually has increased when you start using critical view of safety, because you start realizing that you are not attaining that critical view when you are using proper timeouts.
So for the delegates who are watching and who will be watching, 2 pieces of information. Please go back and watch the entire 3-day proceedings of the first JSF, which was totally on safe laparoscopic cholecystectomy. Number 2, go to Google, put my name, VK Kapoor, and safe cholecystectomy. It will take you to a complimentary download, free download of the book Safe Cholecystectomy A to Z. If you are a member of CELSI, ask CELSI to give you a complimentary copy because Celsi has published 1,500 copies for complimentary distribution. Sometime next year, Amasi has agreed to publish the book, and if you are a member of Amasi, you can get a complimentary copy. And the third edition, I'm being assisted by Dr. Vishal Gupta, who's currently at AIIMS Bhopal.
Yes, sir. Regarding this discussion, I want to add, we always, most probably everyone agree, whenever we are dividing or cutting the cyst duct, we always ask our assistant, who is showing us camera. सही कर रहे हैं ना हम बस डिवाइड कर दें इसको whatever whoever is he we always ask him. So many times our assistant, not even the doctors, nursing staff also tell us that we are doing right thing or not. So after after the discussion we will go to the next talk on the use of surgical anatomy of bile duct to avoid injury to in a difficult cholecystectomy. The presenter for the session is Isidoro D. Carlo. He is a professor of surgery at University of Catania, Italy, and our discussor, Professor T.D. Yadav, sir, and Dr. V.K. Kapoor, sir.
So before Dr. Di Carlo starts, I have to inform everyone that he is an Indophile. He loves India, as he said before the session started. He has been with us in the previous JSF also. This year also, he reached up to Rome airport, but then had to go back for various reasons. But I'm happy that you have joined her online. You are muted, Dr. Isidoro. Can you please unmute yourself?
Yes, we tried to.
We can hear you now. Yes, please.
Yeah, we tried to do the presentation on the computer. We
Not
have
yet.
some,
Yeah,
some,
please
some
share.
Apologize for this.
Yes, yes.
Ragini has to exit.
She wants to go.
Thank you,
ma'am.
Sharing.
Ragini, you have stopped sharing?
Stops.
Yes, I'm
Yes, sir, I've stopped sharing.
Okay, good, good. एक बार सुरेंद्र जी चेक कर लें, उनको को-होस्ट बनाया हुआ है ना डॉक्टर इसिडोरो को? को-होस्ट बनाया हुआ है ना? Okay, okay. You will see a green arrow at the bottom, share.
Share.
Yeah. Once you click on that, then you select your presentation, which is already opened if you have.
Allora, bisogna fare il bottone share. Share. Condividi, questo qua è.
Sto facendo.
Metti solo l'organizzatore, vediamo.
Se così va bene. Non mi fa condividere nulla. Tutti i partecipanti. Condividi. Non mi fa entrare. Accedi per modificare il modello. Mi dovrebbe dare l'invio
If he is using Mac, he has to go into setting and give permission.
Yeah, sorry to keep you waiting.
Are you using an Apple Mac?
Yes.
Then you have to go into the setting and give permission for this sharing. Otherwise, yeah.
Setting.
Yes. Allow to share this thing.
Setting.
Questo condividi. A tutti i partecipanti. No.
Otherwise, can we have the next presentation while you are doing these settings?
Yes, it's much better, much better.
Yeah, we will go through and then somebody can
Thank
help
you. Thank you.
As Dr. TD said, you will have to go into your settings. Dr. Sudha Satwa, you are there?
Hi, yes, I'm there. Am I audible?
Yeah, maybe we will have your Anand, please introduce.
Per togliere la voce intanto.
Yes, sir. For the next talk will be on the blood supply of bile duct. Will be presented by Dr. Sudha Satwa Sen. He is a senior consultant and chief GI HBB surgeon at Kolkata. And for the discussion, Dr. Piyush Sahani sir is here and Dr. Lokesh for the discussion here. So we can start the next talk.
Yeah. Hi, am I screen visible?
Yes. Yeah, please go ahead.
Yeah. So I'll just go into this relevant topic of CPT blood flow and what is the surgical relevance in today's date. So thank you, Professor V.K. Kapoor and team and MG. I'm Hospital, Jaipur, for this opportunity to me, and sincere apologies for inability to join physically due to the Indigo cancellations. Now, just to give you the perspective about the blood flow, that the extrahepatic biliary tree has a dual blood flow, which is one is from the above and the other one is from below. And typically, it is originating from the below, the intrapancreatic part, as well as the supraduodenal part from the gastroduodenal artery and mostly from the posterior superior pancreaduodenal artery, which ascends at 3 and 9 o'clock position, which are also called the paracholedochal vessels of Petrin. And there is 12 o'clock and 6 o'clock positions on the superior, anterior and the posterior surface, which are also called the epicholedochal blood supply. And together they form a matrix all around the extrahepatic biliary tree. And the hilum, the left and the right hepatic duct are typically supplied from the branches of the left and the right hepatic arteries, be it the left and right hepatic proper, be it from the replaced or the accessory vessels, which forms another matrix close to the hilum and the cystic plate, the hilar plate, and then they descend to meet the ascending arteries somewhere around 2 centimeters from below the hilum. So that's the reason that supraduodenal part to the 2 centimeter below the hilum is the area which is probably the relative watershed area of the extrahepatic biliary tree. So this is regarding the arterial supply, and it's a very dense matrix which is adequately vascularized otherwise. And just to give another perspective, so this is the marginal anastomosis area from the retroduodenal and the PSPD and the hepatic arteries, and the hepatic arteries would give to the respective sides, which would come down to anastomose somewhere middle. Now, regarding the venous anatomy, which is also equally important, now you would have the same paracholedochal veins, which are mostly draining into the branches of the portal vein, the superior mesenteric vein below and the portal vein above. It can also drain into the right and the left portal vein along the hilar plexus. Similar to the arteries, they would form a similar course of a matrix all around circumferentially on the extrahepatic biliary tree. Again, the most prominent venous supply along with the arterial supply is at the 3 and the 9 o'clock position. So this is very important when you want to do surgeries on the biliary tract, because ultimately this vascularity is what is absolutely the Achilles heel for any sort of anastomosis, which is very common in biliary surgeries. Just to give a perspective of the biliary anatomy that we deal with, typically we know that's the left system where there is the 2-3 joining with the segment 4A and 4B joined by the left side of the quadrant. They form the left hepatic duct, comes out through the hilar plate having a longer extrahepatic course. The right is typically formed by the right anterior and the posterior sectoral branches, anterior coming from 5 and 8 and posterior from 6 and 7. They join, they can have their own aberrations and variations, joining on the right side, joining on the left side, joining low below. The right posterior sectoral can have problems in the lap cholecystectomy with an aberrant course. So they all join at the hilum to give rise to the common hepatic duct. As the cystic duct joins the gallbladder to the common hepatic duct, it becomes the cystic bile duct. Hello? Is my share shifted? Hello?
Yeah.
So, Professor Isidoro, we request you to stop sharing your.
Yes, we are back to Sudha Sattva.
Sorry.
So this is the basic anatomy of the extrahepatic and the intrahepatic biliary tree. Now, what is the importance of the blood flow is that we need to understand the blood flow and the venous flow to prevent ischemia and congestion of the biliary tree, to have the successful repairs and reconstructions of the biliary tree so as to minimize the leaks, bleeds, and the long-term strictures, with special mention to the surgery in the portal hypertension and significance in liver transplantation. Now, what are these normal unplanned surgeries that we go for where this vascularity becomes very important are bile duct injuries during lap choles. While you're doing a radical cholecystectomy and the cystic duct margin comes positive, you have to go for an EHBR resection. Unplanned hepatopancreatic where you have lymph nodes which you cannot separate from the posterior pancreatic capsule or from pancreatic head in cases of radical cholecystectomies. In some cases of multivisceral resections, and in difficult cases of hepatic artery aneurysms where you had to do something more than you had planned. Now, mostly what we do are planned surgeries, maybe a open or lap or robotic CBD exploration, surgeries for choledochal cyst, radical cholecystectomies with the HDL clearance, VPULS and PPPD, and then there is obviously the surgery for benign biliary strictures. It may be associated with bile duct injury, recurrent pyogenic cholangitis, primary sclerosing cholangitis, or in cases of portal biliopathy. Now, the principles of biliary surgery, the most important, the first point is vascularity, just like any other surgery where anastomosis is an important factor and also is like a deciding factor based on complications and sepsis and the cascade of multi-organ failure. It has to be tension-free to have the adequacy of the vascularity and to prevent the congestion of the venous flow. A wide stoma, watertight anastomosis. Anastomosis of all the ducts are important to get into one common anastomosis, and the choice of sutures. Now, what are the systemic important factors? Because while we are treating the patient as a whole, we tend to focus, surgeons have a tendency to focus more on the surgical and the anatomical factors, but you must not miss out on the systemic factors that in spite of a very good surgery and well vascularized surgery and maintaining MAP and PEEP, still things can go wrong, and for which you need to have pre-optimization prior to even the operation takes over, probably from the day the patient walks into your OPD or chamber. You look for ischemic heart disease, arrhythmia, CKD, whether the patient are on steroids and immunosuppressants, whether the patient has chronic liver disease, whether the patient is diabetic and long-term, uncontrolled or controlled. And obviously, the last but not the least are all sorts of coagulopathy, blood dyscrasia, microvascular diseases, and the mixed connective tissue diseases. Because normally as surgical gastroenterologists, these are the cases which will be more referred to us, because the common surgeries would probably go to any center. Now, CBT dissection in lap chole, I'd be talking on very specific points regarding vascularity of the bile duct. Now, we had already had discussions on bile duct injury. So prevention is always better than cure. Remember the anatomy and its variations, and definitely remember and study well the pathology so that your entire thing is mapped out while you're going onto the theater for your plans A, B, C, D, everything. Take special care in cases of chronic liver disease. A critical view of safety of Strasbourg is absolutely mandate. Ruvius-Sulcus approach, Dr. Agin had already said, it is there, but it is not absolute. It may not be a guidance in every case. Please avoid denuding the common bile duct, and there should be cautious use of energy sources. Whatever energy sources you use at low power, take it away, pull structures, tissues up from the bile duct and then use it, because otherwise the energy transmission is real and it can give rise to delayed bile leaks and strictures and other complications. Stay towards the gallbladder site of the cystic duct. Do not try to expose the cystic duct CBT junction so as to not damage the 9 o'clock position blood vessels. It is better to do a subtotal or a near total than to do a bile duct injury. In some cases, you may do a cholecystostomy, as Dr. Piyush Sahni had already mentioned. And in 1-2 cases, we also had to abandon the surgery because of extreme difficulty in knowing the anatomy and inflammation. We simply could go back in 6 weeks and get the surgery done, re-laparoscopy. So say for surgery like this, where everything is toe stark, there is empyema of the gallbladder, there is Mirizi along with the large stone sitting on CBD somewhere here. This Ruvius-Sulcus, everything is obliterated. So in those cases, either you can do an anterior cholecystotomy and then take the stones out, see from inside, and then you can get to the Calot's triangle, have the safety and clip the cystic duct. Or you can simply go from the gallbladder margin going down till you get the angle between the cystic duct in the cholecystohepatic triangle, get the cystic artery and clip them separately and be very sure you have not injured the bile duct. You may need an intraoperative cholangiography before you actually transect or do anything. You can do it through the gallbladder in these cases. Or it is sometimes better that where you can't have it separated, say for a type 2, type 3 Mirizi, you may have to do a subtotal cholecystectomy, where you do an anterior cholecystotomy. You see from inside, take these stones out, go as close to the GB, CBD fistula area, and then cut out the flaps and repair the flaps on the bile duct so as to prevent narrowing, as well as maintaining the vascularity on the bile duct. Chances of leaks remain, but usually doesn't happen. You may or may not stent these cases selectively. So typically what I was mentioned in a type 1, type 2 Mirizi, when it was very difficult to reach the neck, you go as close to the bile duct. Do not damage the bile duct or its vascularity. Be very cautious about using the energy sources, because even if you're away from the bile duct, since you're relatively close, it can lead to the injury to the vascular arcade and later on biliary fistula and long-term bile duct strictures. And then you can stitch from both the flaps to close like a flap cholecystectomy, avoiding the narrowing, at the same time damage to the bile duct and its vascularity. So this is how you do it. Even cases as difficult as this can be done laparoscopic, gangrene, perforation, empyema. But the problems in such cases, similar approaches, you have to get the critical view in case you want to do a total complete cholecystectomy, otherwise do a subtotal. But there are obviously in such cases, due to spreading endarteritis, due to the pathology, you may get such ischemic bile ducts. Some cases you may have to resect those bile ducts and bypass them. Now, just a pointer on the left-sided gallbladder, we have done 3 so far. A leash of ducts come when you're doing a left-sided dissection, and that is the reason you have to be very sure about the bile duct, the cystic artery, the duct, and then there are all major left-sided ducts that can be seen. So the critical view of safety for a right-sided gallbladder and the left-sided gallbladder are slightly different. So always look for all those structures that is coming in or out from the gallbladder. So staying close to the gallbladder margin and taking the gallbladder up from the liver bed is better, but then you do not have a liver bed as such, because most of these gallbladders would be lying on the recesses of Rex. So there is only most likely fatty tissue on the liver, part of 4 and part of 2, 3 on the 2 sides. Sometimes it may be on the 2 and 3. That makes it easier because the GB can be raised from the liver, lower 1/3, and to get a critical view of safety and go for the surgery. All these are to keep in mind to avoid a bile duct injury and injury to the blood vessel supply of the extrahepatic biliary tree. Now, just key points about HDL clearance in radical cholecystectomy. Please remove all the tissues to bear the HBr, but do not denude the bile duct, because if you denude the bile duct, what happens is bile ducts get ischemic, the venous supply cuts out, and they may lead to later bile leaks, can lead to bile duct strictures in long term, and strictures would also have a difficulty in diagnosing whether there is a cancer relapse in these cases, because primarily these surgeries are being done for cancers. Now, in case extrahepatic biliary tree radical excision has to be done, then please anastomose at hilum or above with a left duct extension. The reason being, as I've mentioned, the watershed area starts from 2 centimeters below the hilum, goes on till the supraduodenal area where the ascending and the descending branches meet. But having said that, the best supply remains along the hilar plate and forming a matrix over the left and the right hepatic ducts and the hilum up to the floor of the hilum. So if your transection and the anastomosis happens at this or above level, then you have nothing to worry about, at least the vascularity. Avoid the injury to the vessels. So when you're taking the left duct down, please stay close to the cystic plate and not towards the bile duct, because the leash of vessels run on the bile duct, rather more close to the bile duct system rather than the cystic, the hilar plate. And definitely, as I've mentioned, cautious use of energy, because energy unnecessarily can lead to delay damage. These damages won't even go recognized at the time, and that is the reason it causes later problem in spite of a very good surgery. So just to give a perspective, we have this PSPD, this is giving the supply to the vascularity. And once you have taken out all these lymphatics towards the liver side, you have exposed the superior mesenteric vein, portal vein, everything, you have taken the hepatic arteries exposure. But for the bile duct, keep the basic fascia on the bile duct so that you do not denude it to have problems in the future. Now, a few words on the bile duct injury. It's already been covered. Vascular injury, we know what are the different Strasberg and Bismuth called it classification for the bile duct injuries. Again, the first and foremost things, prevention is better than cure. It is best avoided. Any surgeon, however good, whoever has done thousands of cases, can still end up with a bile duct injury. And 2 things I think are most important is overconfidence of a very experienced surgeon and underconfidence or lack of experience for a beginner. These are the 2 ends which probably lands up with most of bile duct injuries. But then again, the numbers are coming down. It can be avoided. Call for help if need be, if there is a bile duct or vascular injury. Even if you're a very qualified, experienced doctor, you may need help. 2nd pair of eyes, 3rd pair of eyes. Before you clip anything, it's better to ask your anesthetist, your assistants, even your scrub nurses, because they are all experienced in their own ways and they all have a different angle of view towards the Calot's triangle, which sometimes skews the vision of the surgeon. And that's why asking everybody for safety before you clip or divide or take any sort of irreversible step is always helpful. Stop. There is nothing to worry. The damage has already been done. Do not increase it by making hasty steps. Stop, reflect, assess the damage, and then you plan to repair on a stent or a T-tube if it's partial. And if it is already transected, then considering the vascularity already gone along the HBR, I'm not even thinking of the right hepatic artery injury, which may have happened. Get all the ducts, go to the highest possible level at the hilum or above with the left duct cut, because the first anastomosis, the best vascular anastomosis at the hilum will be the biggest solution in long term, because if you do at the same level, the vascularity is already compromised. It's a small aperture. There are more chances of strictures in the future. And each time, as we know, one stricture progresses to a higher stricture during the recurrent surgery. For biliary strictures, the best is one-time solution, unless you do not have the expertise. In those cases, you can just simply put in drains or clip the duct and put in drains and send the patient to a higher center where the patient can be dealt with better. And most important, whether you have had vascular compromise leading to problems in the long term, you need to have long-term follow-up of this patient. Immunodiarly, MRCPs and blood tests, McDonald's grading in long term. Only then you'll know that what was the true level of injury and what unwinds in the future.
So this
is, for example,
5 more minutes, please.
Yeah, sir. So this is to example of a bile duct injury and then stricture. Then this is how the left duct hepatic hilum AJ is being done. And this is in the post-op long-term follow-up at 5 years showing patency. The vascularity has been maintained. Had we done it here, the vascularity would have been compromised. Now, stoma at injury level, don't rely on supply from the above. Reconstruction of the right hepatic artery, if it is not possible by you, ligate, or otherwise you anastomose it if it diagnosed on table. Most important, operative hypertension has to be controlled, converted open to open surgery if need be, and contained the damage system. Information of team and the anesthetist is important. Hepatojejunostomy is always to be preferred and not a choledochoduodenostomy. Same principles of AJ, stringent perioperative care to maintain the homeostasis and the hemostasis. Look for the delayed complications, BBS, and refer with drains if not needed. Coming to the second point of discussion, a CBD excludation, where do you cite a choledochotomy? It ideally should be at the supraduodenal level because it is roughly at a distance of 7 centimeters, which is also the length of choledocoscope for access to both sides. It has to be on the midline or just to the side of it to avoid any other place, to avoid the damaging the vascularity. Suture retract, minimum handling, avoid denuding the CBD, and then when you repair. So this is an ideal location of a choledochoduodenostomy. And when you repair, this is a laparoscopic CBD. So when you repair, it is with simple interrupted sutures and watertight to prevent a bile leak. Take close bites, take finer sutures so as to not compromise with the vascularity which is coming from both sides from the 3 and the 9 o'clock. In case of a choledochoduodenostomy, similar area lower so that in case it strictures, there will be re-access. In case it is strictures, you can have redo surgeries above. And this is typically a Gliedman-Gold technique, which needs a 2.5 centimeter cut. And this is a 1.5 centimeter cut to have a funnel effect. Coming to choledochal cyst and its importance in vascularity, this is just a picture of a choledochal cyst. So you need to excise complete, and that is the reason you need to go to the intrapancreatic part. But the upper part, you need to go almost at the edge or above, because wherever the vest ends, and the anastomosis has to be done as high up in the hilum and the left duct for the same principle. After lowering the hilar plate, away from the staying close to the hilar plate rather than the bile duct, to have the adequate vascularity, because all these anastomosis, the leaks, strictures, all are dependent on the vascularity of the extrahepatic biliary tree. Now, while doing an pancreatic dissection, please avoid, if you must know that whether there are pancreatobiliary maljunctions, avoid damages to that and the vascular injuries inside, because they may lead to pancreatitis and pancreatic fistulas in the postoperative period. Stay away from the left hepatic duct closer to the hilar plate. Now, regarding the CBD vascularity importance in pancreatorhodonectomy, it has to be a supracystic transection level. In case of Rosen shows positive, you have to go higher up, but then try to avoid anastomosis at the CHD mid-level, because that is the watershed area. If needed, go higher up to get a proper one single stoma. Again, do not denude the CHD during HDL clearance. Preserve all the vessels, or if you have to resect, reconstruct in the borderline resectable pancreatic cancers, resect and reconstruct the vessels. You must take caution about the energy sources. Use in low areas. You pick up the tissues and do it away from the extrahepatic biliary tree to avoid the collateral damage that can happen. Do not unnecessarily mobilize the CHD beyond the point of transection and anastomosis. So this is just to give a perspective of where ideally anastomosis should be done. A point about portal biliopathy, extrahepatic portal venous obstruction, NCPF, CHF, some cases of CLD and portal vein thrombosis, you're going to expect a lot of portal cavernoma, which gives rise to compression. Compression gives rise to congestion. Congestion gives rise to microcirculation problems, back pressure changes, giving rise to ischemic bile ducts. And that's the reason you have very tight, tortuous, difficult strictures in these cases, with very high chances of bleed, because the venous congestion lies in the wall, inside the lumen, as well as outside it. And that is why these are extremely challenging surgeries, keeping these vascular changes in mind and the vascular anatomy, which gets completely distorted. One needs to do a shunt before doing an endobiliary procedure, and surgery being one of the last resort. Or some people, some studies have believed to do a shunt and surgery in the same go, after having done the shunt and seeing whether the hepatic wedge pressure have come down, the portal pressures have come down. So a word of caution regarding portal biliopathy. So this is typically a portal biliopathy which is showing compression by the vascular tortuous cavernomas and giving rise to strictures. Just to highlight on RPC.
Two more minutes, please.
Yeah, just to highlight, yes, sir, I'll wrap up. Just to highlight on the recurrent pyogenic cholangitis, the peribiliary arterial complex plexus, as we have already mentioned, and the portal vein branches supply are affected due to recurrent inflammation and infection, giving rise to ischemic changes, obliterative end arteritis, and also portal vein thrombosis of the branches or of the main portal vein, giving rise to strictures, jaundice, and secondary biliary cirrhosis with atrophic hypertrophic complexes. These cases, due to the vascular ischemia and the ischemic ducts and frequent surgeries or recurrent interventions, have a higher chances of restrictures and reintervention. So access loops, transhepatic cholangioscopy procedures may be repeatedly needed. So these are the cases where you have to operate on difficult situations of blood flow to the bile duct. So do not have compromise more on the vascularity during these surgeries. So this is just to give a perspective about the recurrent pyogenic cholangitis, stones on the left system inside the bile duct. In this case, we did a left hepatectomy, and this is how we control the vascularity of each left portal vein, main portal vein, before and after the chordate branch, so that you can maintain the vascularity as best as possible. Now, last to not the least, hepatic artery aneurysm depends on the size and location. There is always a steel phenomena if it is large. Ischemic congested EHBRs, planes may be very frozen, so careful circumferential dissection of the aneurysm so as to not denude the bile duct or injure it. Bleeding, rupture, and energy injuries can happen, so be very cautious while using energy, specifically to the wall. Though it is of large size, the walls are very thin and it can rupture at both ends, is more likely at the inflow and the outflow. Super selective control of the inflow and the outflow so as to avoid dissecting the bile duct at the circumferential level, especially at the ones which are going right up to the hilum. So this was done by us 14 years back. This was the largest hepatic artery aneurysm in the world then time. So you take the common hepatic artery distal to celiac is not that much of a problem, but the most problem, right, when you have to take the right hepatic artery and separate it from the bile duct just at the hilum level, because they have a tendency to, they become very close. There is a tendency to denude the bile duct, injure the bile duct. So you have to take caution in these cases. You do not need to loop the bile duct. If you feel difficulty, then loop the bile duct and separate it, and then stay close towards the aneurysm without rupturing it. Difficult job, it's easier said than done, because there is strict compression of the aneurysm to the bile duct, and then the aneurysm collapses, you open it, and you do whatever. So coming to the final slides, what are the philosophy of the biliary surgeries? Please remember the anatomy and its variations, the pathology and the complexities, and the systemic factors. Expertise with experience is a combination which helps. Infrastructure and help as and when needed. There is no place for ego for GI surgery. And keeping in mind the medical legal aspects of the documentation and take help freely as and when required. Take home messages: there are 3 and 9 o'clock ascending paracholic vessels which join with the descending ones from the right and the left hepatic arteries. There are also anterior and posterior epicolic vessels. They form a plexus, which is typically from PHPDA, GDA, cystic, RH, LHA. The supraduodenal to 2 cm below hilum is the most vulnerable area. Venous flow is as important as the artery. Please prevent vascular compromise, avoid denuding the CBD circumferentially, incise in the midline at around 12 o'clock or just next to it to prevent the vascular injury. AJ should always be at the highest point, principles followed. Plan well, prepare, proceed in cases of CLD, RPC, biliopathy, colorectal cysts, and the strictures which are more difficult surgeries, more likely to need dissection, more difficult planes and frozen planes, more likely to have changes due to inflammation, cholangitis. Go cautious, go slow so that your steps get fine. Do with best minimal tissue damage. Better to be cautious and be a little afraid and safe rather than being overconfident. Clean anatomic plane dissection. Maintain the vascularity at any cost. Also maintain the microcirculation so that the MAP is well, the CVP is normal, urine outputs are good. Time to time talk to your anesthetist, because that is one thing surgeons tend to forget. Best protection is to follow all these to minimize the morbidity and mortality. And please remember, all our surgeries are interdepartmental liaison. In phases of catastrophe, or best to avoid it. And I think our knowledge would continue to increase as and more we discuss on these topics. So keep discussing academics of passion. It's not just for the conferences, but also you read every night, you talk to people you meet, and that keeps us growing every day. So over to Dr. Vicky Kapoor and Dr. Sani. Thank you so much.
Piyush. Lokesh.
Sir, I have few questions. First one, as you told in the portal biliopathy, there will be multiple strictures and difficult strictures. So after shunt, if there is a persistent stricture, so at what place we should do the choledochotomy? As normal CBD exploration, we usually go for supraduodenal area, but in the portal biliopathy, multiple strictures are there, and most of the strictures are in the extrahepatic portion. So what should be the exact place where should we open the CBD and do the choledochotomy?
See, the point is all depends, because most of these people would be preferred for an endobiliary procedure. Now, in case you want to do a surgery post-shunt on table, then you have to choose the area which is not on the 3 or 9 o'clock position, and where you can get some dilatation. Because see, if the strictured area you obviously can't open. And what is the plan? That also depends on that, whether you're planning to open up and take the stones out, you're planning to stent it, you're planning to do a bypass, a resection. So that would decide where you actually open up, but keep on the midline. Right, the location at supraduodenal or at the hilum would be dependent on what stricture, what tortuosity, and what is your plan. So there aren't exactly fixed plans for this.
But Lokesh, I would add that if you are seeing multiple strictures on the MR cholangiogram, and you are planning a biliary enteric bypass, if the biliary obstruction has not resolved even after shunt, waiting for adequate period of time, which could be 3 months, 6 months, then obviously you will go as high as possible, proximal to most proximal stricture. But the problem is if there are intrahepatic strictures also, then obviously
because most of the time in the left side they are extending to the left side, then it becomes problem.
So
right.
Yes, Sudhasatwa.
Yeah, I mean, that's practically, see, we don't go for upfront surgery. You wait for 3 months, 6 months. You manage with endobiliary procedures, cholangioscopic procedures if needed. If you have multiple strictures, and if you get the hilum and the left duct free, that's fine. But most of these cases, what we have found, or in RPC cases, they're very challenging, because you will hardly get an extrahepatic duct where you can take up for the anastomosis. In those cases, you may need to do a partial excision of the resection of the liver and put an intrahepatic cholangiojejunostomy, so which is again a challenging surgery. It's not a very easy solution.
Thank you, sir. One more question. As you told in the Whipple's procedure, whenever we found the replaced right hepatic artery and borderline resectable pancreatic cancer, we should always reconstruct it. But at times when we are not able to reconstruct the vessels, they are smaller vessels above the tumor. What should be the place of the HJ we should select, and any other extra precaution we should make?
Right. And this is a very pertinent question, and we have faced quite few on this. In fact, in Tata, there was a symposium on the same topic of the replaced right hepatic artery in BRPZ and resect or not resect last year. So most of these cases, post-neoadjuvant chemotherapy we are going in are fibrotic, and rather than actual tumor invasion. So you can dissect it free from the replaced right hepatic artery. If you have not injured it, not damaged it, then fine. In case you have to resect it, which is usually below, just behind the pancreas from where it comes out from the SMA, So if you resect it, you may reconstruct it, or what may happen is you may look for back bleed and then simply tie it off. We have done both in few cases we have done. But still the anastomosis has to be as high as possible, not at the supracystic level, not at the CHD level. You take it to the hilum with a left duct cut, because the more likely chance of the left-sided supply being not compromised along with the hilum from the left side, because there is crossover from both sides, but left hepatic artery would preserve the left side and the hilum. So that is one good anastomosis where you can get an adequate margins also you can get. Now regarding whether this is a replaced right hepatic artery, this is what should be an ideal. But if it is an accessory right hepatic artery, you can just sacrifice and look for the back bleed, because normally there is crossover. So if you get a back bleed, you're safe. If you don't get a back bleed, then also it doesn't matter, because you already have the right hepatic artery in place. But the anastomosis should be high. You cannot depend on the ascending branches for these cases.
Thank you, sir.
Thank you very much for that very interesting discussion on the vascular supply of the bile duct. I think two important points that one needs to remember whenever one is working with the bile duct. We've got plexuses all around the bile duct, but the peri are more important than the epi. And therefore, our incisions on the bile duct are usually at the site where the epi plexuses are rather than at the peri. So you always avoid the peris and not so much avoid the epis. That's why your incision for a corridocotomy, for a CBD stone, a corridocotomy, for a corridocoduodenostomy is all in the midline, and it's not on either side of the bile duct. That's because you want to avoid the pericorridocal vessels. Second, there's a difference between an end-to-side and a side-to-side anastomosis. If you have a side-to-side anastomosis, even if you do it low down, it shouldn't be too bad, because you've got blood supply above as well as below, and you aren't interrupting the supply. On the other hand, if you're doing an end-to-side anastomosis, the higher you go, the better it is. If you're doing a corridocal cystic scission, you need to, even if the waist is lower than 2 centimeters, from the hilum, you still need to go up and do the anastomosis higher up. If you're doing a bile duct injury, a biliary stricture after a bile duct injury, you need to go as close to the hilum as possible, because you get your blood supply now largely, possibly only from the upper end of the bile duct. And therefore, doing it anywhere lower is likely to cause a problem. One of the reasons you see in living donor liver transplants where bile duct anastomoses are done end to end, you see a little higher stricture rate is because you're interrupting the vascularity there. So wherever you have a doubt, you'll see liver transplant surgeons, if they're not happy with the vascularity, going ahead and doing, instead of an end-to-end anastomosis, going ahead and doing a hepaticojejunostomy rather than a corridocal anastomosis. So I think the crucial thing to remember is the way the supply goes and the places at which we can make our incisions. Portal biliopathy is a different ballgame altogether. You've got blood all over the place. So the best place to make an incision is where you do not have collateral seen on the wall. The problem is you put in a needle and you say, I want to hit the bile duct, and what you will hit repetitively is blood. And that's because the pericorridocal and the epicorridocal plexus is now completely dilated within the bile duct. So wherever you hit bile at the top, perfect. If you hit bile in the middle, perfect. Wherever you hit bile, that's the place to start opening the bile duct. Once you open the bile duct at one place, then you've got some control. Before that, you have no control as far as doing portal biliopathy is concerned. Once you're inside the bile duct, then you can take a call on how far up you can go and how safely you can go, depending upon the kind of blood loss you get with each nick that you make on the wall of the bile duct, and the amount of blood you lose trying to control the blood loss that is happening because of that 0.5 centimeter or 1 centimeter incision on the bile duct. Obviously, the higher you go, the better it is, but sometimes it's impossible to go higher. And you end up doing an anastomosis in the middle somewhere. You can't bypass the upper stricture. And there, the option is then to intraoperatively try and place very, very carefully a T-tube, which then acts like a stent for someone else to go in and try and do something endoscopically or percutaneously. But that's a bad bet. The other option, of course, is that you avoid all this completely and go and look at a possible segment 3 hepaticojejunostomy if that area doesn't have too many collaterals. So we've done all these options. You do what is best in a particular situation in patients with portal biliopathy, because you can get into difficulties with all these patients and you can just have no rules. The only rule you can have is don't have a dead patient in your hand. So stop when you can't proceed further. You're losing blood, stop. So have a limit. Say, I'm not going to go beyond this, and stop there.
One question. Sir, I want to ask about denuding of the CBD. It's always subjective. Like I feel I denuded during the radical chole, but my colleague Dr. Manpreet told no, sir, it's okay, we can go ahead, and I left it like that, and nothing happened. So is there any subjective criteria like half denudation or complete circumferential denuding? When to do HJ? When to take decision that we should do HJ? And is there any objective criteria to that to assess this CBD?
I don't think you will ever do a preventive HJ. And actually, I wanted to ask, but time did not permit. All of us have done extended chole. Some patients are surviving beyond 5 years. Have we seen a biliary stricture following an extended chole? So somehow, theoretically, it should happen, but probably it doesn't.
So I think one of the things that doesn't happen is that you don't go from top to bottom and denude or isolate and circumferentially isolate the common bile duct. Usually in some part of the common bile duct, if you go ahead and isolate everything. So as long as there's some tissue around, you must remember the perichoroidal and the epichoroidal plexuses are within the walls of the bile duct. So you need to make a lot of effort to injure those.
Sure. Let's.
No, I just wanted to say the same thing, that you are not going in subserosal plane. So you are going around the CBD. So unlike a hepatic artery, where you are taking all the fibers away, in a portal vein also you try to take all the things away. In a common bile duct, there is another layer between the common bile duct layer and a subserosal cystic plate. So visually we go all around the tissue, take out the tissue all around, but we don't take the tissue. Then at this stage, from this excision done at the porta to the down, usually doesn't something happen, much happens, but sometimes I have found one extensive hepatic artery, maybe denusion and artery went into little bit of spasm, and in the post-op, our patient developed little bit of liver abscess. That is only one case. But here, there is no this suture. Since then, we are just put some papaverine if you are thinking that artery is small and might go into spasm. That usually doesn't happen because we are maintaining the plane, the subserosa. We maintain the serosa. We don't denude the serosa in a perichoroidal plexus. So I think that is the reason. And as sir said, never anybody is going to do unless you are excising the common bile duct, do a hepaticojejunostomy.
Can I add a point? Can I add a point? Yeah. So basically, very rightly pointed out. I mean, we theoretically may talk of denudation, but it hardly happens unless you're actually dissecting the bile duct during a lap cholecystectomy, where you're probably going to cut the bile duct or injure it. I've seen cases where we have been referred and we had to go in and do the repair or the bypasses. So they have completely skeletonized and cut and then dissected off the bile duct up to the hilum, and then they realize they have cut it. So those things can happen, but otherwise, per se, typically this sort of denudation, which is enough to cause a compromise of the 9 o'clock vessels, usually 3 o'clocks are protected, is typically above the pancreas and the right side of the bile duct, where you're trying to dissect for the paracholedochal and the HDL posterior lymph nodes in a Whipples or in cases of a difficult radical cholecystectomy. And usually it's not a denudation that happens. It starts bleeding from some vessel, and the overzealous trial to control or use cautery in those areas gives rise to damage to the wall vascularity and even at times perforation. So that is something which needs to be avoided. So if there is a bleed, minor bleeds are definitely going to happen from the branches, because it's not that you tie off every branch, every small thing, considering some of them to be lymphatics during an HDL dissection. So just use very selective bipolar, or more importantly, pressure to stop it. So unnecessary usage of energy sources or sutures can give rise to actually more damage to the biliary blood flow. So that is the point I wanted to make.
Thank you, Dr. Sudha Satna, sir. Now we move on to the next session, use of surgical anatomy of bile duct to avoid injury in a difficult cholecystectomy. Over to you, Professor Isidoro. Thank you.
Are you seeing my presentation now?
Yes, sir.
That's perfect. So first of all, I would like to thank Professor Vinay Kapoor for this invitation. It's for me a great pleasure, also if I'm in my university, to be with you. And I would like to also thank all the authorities that permit this meeting. And sorry to not to keep with you, but unfortunately I have a problem with my visa. So my presentation today is very simple. What we have to do to avoid complications in case of very difficult cholecystectomy. So I see from previous presenter that there is a problem of legal lawyers also in India. In Europe, Italy and Poland are the two countries in which we have a problem. So we can go in front of the court that can judge us, and process sometimes can be longer, 10 more 15 years. So it destroyed a career. So we have to take particular attention when we do surgical procedure for the patients and to avoid any complaint from the patients itself. So I would like to say that the first cholecystectomy have been done by Professor Calot in French in Europe, and was reported in a thesis that explain to us what we have to do. So now there is some argument that we have to respect. And
in all cholecystectomies, whether emergent or elective, routine or complicated, there are several anatomic features that should be identified in every case. These structures are the following: the sulcus of Rouvière, which is also known as the fissure of Gons, the hilar plate, the cystic artery lymph node, the fundus of the gallbladder, which in some cases may be the only identifiable anatomic feature, the porta hepatis, and the duodenum. All of these structures are critical in orienting a surgeon to the location of the common bile duct and common hepatic duct, such that they may not be injured in any cholecystectomy.
So this is the anatomy that we have to follow and never forget to avoid any complication for this kind of surgery. Can be very easy, but sometimes become very difficult. So what we have to do that laparoscopic cholecystectomy become the gold standard, but the complications increase from the period in which the cholecystectomy was done by open surgery to the laparoscopic cholecystectomy. We have an increase of 0.5%. And this is a problem for the surgeon or for the patient, of course, because the patients can have last stage of this problem, secondary biliary cirrhosis, and very noisy for the patient, but for the surgeon too. So what we have to do to avoid this catastrophic complication when we have to operate acute cholecystitis is very simple. When a cholecystectomy represent the gold standard for acute inflammatory cholecystectomy. But the problem is that we have to do it until 1 week, no more than 1 week. And if this is not possible, because sometimes we have a complication concerning this presentation, do not to have fear about the conversion. We have to convert and we have to do subtotal cholecystectomy because it's the procedure that can save us, can save the patients, and we have avoid any legal complications. So, of course, sometimes if the cholecystectomy to do is very easy like this, like a sample that I see, that slide that I see before, is very easy to do because we can recognize all the structures and we can do cholecystectomy without any problem. But if the cholecystectomy is like this, it's become very, very difficult. So we can use cholangiography, ultrasonography, fluorescent images. We do it, but when we start, when we decrease the lights of this problem, we have same times the same images, and we have to do it without problem for the patient. So we can do all the kind of insertion of biliary duct as before was shown, but do not save us for the complication. In 1954, surgeons described for the first time what we have to do to avoid complications of common bile duct and to do cholecystectomy safe. And was the surgical procedure that still now is well applied. We do a surgical procedure many years ago that we published on World Journal of Surgery to avoid any possibility of complications for this patient, because for us Italian the problem is the complications can be done. The patients do a problem or legal, and we can do to the court, and to solve the problem is very difficult. These procedures have been publicated on World Journal of Surgery. And as you see, we arrived on open surgery until the hand of the gallbladder, and we can suture without any problem. Others, so this is the procedure, but it's not important. So all procedures have been invented by Asiatic surgeons. So the first of all, we have to attach the section of gallbladder from the fundus. Is the first step to avoid any complications. And this procedure have been developed by Canadian surgeons, also from the Asiatic people, that say us we have to attach the gallbladder from the part in which is not interested by inflammation. So we are sure that cholecystectomy is do in a safe manner. So as you see in this slides, what we have to do, we have to attach the gallbladder in which we have no possibility of due problem for common bile duct. So we have to cut in the middle part of the gallbladders. So in this way, we have no possibility to avoid any problem. The Canadian people have said us that probably the best incision is at the fundus. It is just before of the common bile duct, but it's not sure. And for this reason, we have a write a letter that have been published on Journal American College of Surgeons, and we see that probably in this case the risk is to attract the common bile duct and to have a long time stenosis that can damage the life of the patients. So in case of inflammation of gallbladder, as you see in these slides, the much better is to start from the fundus of gallbladders. And in this way, we have to eliminate the part of the gallbladders and eliminate the calculi that are inside. You can see perfectly what happens inside, and you can eliminate all the calculi. And in this way, you can reach the last part of the gallbladder. You can suture it it and you have no problem. Of course, if there is a benign tumor, this is another. If they have the stones impacted, you can do lavage, and in Atman pouch, and you can have the gallbladder free of charge, and you can do your surgical procedure without any problem for the patient. Never forget that in Italy is very important to do damage for this patient. So we can apply endoloops, but we do not agree with this part, because the most important thing that we have to do, we can attract the common bile duct and we can provoke stenosis. For this is not common to do it, and Canadian people, American people do it, but we not agree with the possibility to attract the common bile duct. In this way, we can have a problem in the future for these patients. So what we have to do is yes, I would like to show what is what we have described, because in this case, and published on Journal American College, in this case, you have to attract the common bile duct, and you can have some problem that in the future can appear for the patients. There is another possibility in case in which the gallbladder is completely covered by colon. You can open the gallbladder in two parts, and you can suture the last part of the gallbladder. In this way, you can eliminate the bile, you can eliminate stones, and the patient is saved without any problem. So what we have to do, I would like to say what is the most important thing that Professor Strasberg, that is one authority in the world concerning this kind of procedure, and invented many things that are used in the world, is to avoid the local factors like contraction tissue, dense adhesion, and organ shrinkage, and patient's factor that concern the size of gallbladder, skeletal deformity, and liver disease. Many of my colleagues that precede me call about the disease of the liver, but disease of the liver is a great problem, and probably we have to approach another mind, not cholecystectomy, because sometimes bleeding and so on can be dangerous for health of the patient, especially if they are child B or child C disease. So what we have exactly do is the bailout procedure that have been published on Journal Hepatic Pancreatic Biliary Science, that we and have been described by the Professor Strasberg, is fenestrating or reconstituting. Reconstituting is the best, because we have no bleeding, we have no problem of bile from drainage, and the patient can go home without any problem. So we have to do this procedure. Of course, we cannot do the fenestrating, but we save the life of the patients. We have described this in World Journal of Medicine Surgery in 2021, almost 5 years ago. And it's very important because sometimes, as you see from these images, lace is more difficult in difficult cholecystectomy, because sometimes if you do less, is more for the patients, because we save the life and we avoid any complications. I would like to show you a problem that appears in our department. This is the patients that have been operated for gallbladder calculi, but the young colleague that do it do not calculate exactly when the common bile duct can be. So for this reason, I don't know how many minutes I have, so I could check. So just 3 minutes. So in this video, you can see that the colleague opened the gallbladder to try the right thing, and probably what is cut now is not the cystic duct, but is the hepatic duct. So at this moment, you have a problem. You realize this after we have a bile that come out, and at this moment I realized that there was a hole in the middle of you see now that is very difficult to repair, and you need to do a surgical procedure that's more complicated. But if you see the patients for all life long, you see that probably will be disease for all life long due to the surgical procedure that, never forget, is benign disease. It's not a difficult disease. It's not a malignant disease. So this is the cystic, choleric, and hepatic, and common hepatic duct that have been cut together, and the patients need reconstruction. So what we have to do, this is
It's completely covered by the greater omentum. The dissection gently begin in order to identify the fundus of the gallbladder. When the gallbladder can lift it up, the greater omentum can be detached from the anterior wall. The inflamed wall of the gallbladder is incised by electrocautery into a safe boundary between the body and the neck of the gallbladder. Then the inflamed external layer is separated from the inner layer and the gallbladder is moved upwards, leaving the inflamed external wall down. Gently and carefully the gallbladder is raised more and more, until the confluence of the cystic duct into the gallbladder is clearly identified without any doubt. This maneuver is of the utmost importance. Then the cystic duct can be clipped and sectioned.
We have 5 more minutes, Dr. Isidoro.
Yes, I'm finished. This is the last slide.
The cholecystectomy is completed as usual, leaving the inflamed layer attached to the liver bed, which is subsequently electrocauterized. Extraction of the gallbladder, cleaning of the cavity and positioning of a suction drainage is done.
All right, this is our technique that we have published on 2024, and now we have a second part that will be published soon in What Journal of Emergency Surgery. So what I would like today, this is Strasberg, is a famous sentence. So our surgery is like a plane. If you go on the plane and a pilot think that can do on the airport, but there is no possibility, we have a crash and people died. So we have to think at the same thing. We have to do, the patients can have complications, can destroy the life forever. And so we have to think that the patients is ourselves. What we do for ourselves is the best thing to do. This is our book that have been published a couple of years ago, where all the complication can we do. If you want to read, I invited many people at this moment. I don't know, Professor Kapoor, that was one, in my opinion, is one of the experts in the world concerning this argument. But probably in the next book, you will be invited for sure to write an argument. Thank you very much for your kind attention.
Thank you so much, Dr. P.D. Yadav.
Thank you, Dr. Isidoro, for a very nice video, and whatever we are discussing in the earlier talk also, that points has come. I have to just add 2 points regarding the subtotal cholecystectomy. One is a difficulty in a patients of the portal hypertension. So there are two important issues. One is portal hypertension because of the
early CLD, chronic liver disease, and or secondary biliary cirrhosis. Another would be the portal hypertension because of the extrahepatic portal venous obstruction, or even this all NCPF. So here we suggest that if correct me if I am wrong, if suggest that ideally we avoid doing in a second group where there is a extrahepatic portal venous obstruction or NCPF, we avoid doing laparoscopic cholecystectomy because of the extensive collateralization in the subserosal place where we try to remove the gallbladder. And we suggest that person should do open the gallbladder and try to, as sir was saying, take the switch bites in the all the collaterals and try to leave the posterior wall, subtotal towards the posterior wall, and toward the chylus triangle area also, leaving that particular area, what you call this another important point mentioned by Professor Strasberg. Then you remove all the stones and ablate the mucosa, so that you are not entering the area where there are collateral, because extensive bleeding occurs and it may be sometimes life-threatening. However, in a setting of chronic liver disease where collateralization in that area is not that very high, one can still use many of the sources of the this energy sources and get away with that. So that is one. And second, I saw your ICG slides. So we did not discuss that. That part can be little bit discussed. What we are also using, there are two important issues using ICG to map the anatomy in a difficult situation. One is that timing is very variable. So preferably 1 hour sometimes we take. And second is that every time the things are not seen. So what I can make out and read the literature also recently, that if it's a timing to identify the common bile duct and hepatic artery is lesser in comparison to others, but whether it is translated.
So I can answer? Can I answer? Okay, so just go.
Please go ahead, Dr. Isidoro, please.
Oh, thank you very much. So I agree exactly what you said. I absolutely agree. So cirrhosis is a very difficult situation. So in cirrhosis, the patients depend from child that he have. Child A is a normal patient, so we can operate without any problem. But if you look at the classification for ACC done by Professor Makouchi, patients that have a child A, sorry, but we cannot establish it for until 4%, we cannot be operated as all the patients. So we can do radiological intervention on the bed or in surgical procedure to avoid any complications for cirrhosis. But if you have a cirrhosis A, usually you can, without any problem, you can operate and you can treat this patient normally. Child B now become operated for HCC, so you can operate also for gallbladder. But child C, you can have another possibility to treat these patients. So probably by aspiration of bile, because sometimes it's the bile that provokes the problem, and this is the treatment that we have to do. Can you repeat, please, your second question, because I forgot.
My question was regarding use of ICG in a difficult situation.
Right. So ICG, as you show in during the slides, you can use it whenever you like, because it's very important, ICG and fluorescent image and so on. But when you stop the light, the situation is the same. You don't know where you have to go. And two, as I said to you, in Italy, we have some problem with the penal court. So the damage during surgical procedure is penal, it's not civil. So it not give the money, but we can be condemned by the judge. So to avoid this problem, we use the best solution for the patients and for ourselves. This is simple.
Few points at the cost of repetition again for the young surgeons in the audience. The size and direction of a duct does not decide whether it is cystic duct or common bile duct. Even a normal common bile duct can be 2 to 3 millimeter and look like cystic duct. And if you are pulling too much on the gallbladder, you are aligning the common bile duct from a vertical position to a horizontal position, and then you can mistake it for cystic duct. It was also said earlier that cystic duct usually doesn't have vessels on its wall, whereas the CBD has. Third is because CBD, the wall is thin, the lumen is bigger. Cystic duct wall is thick, lumen is relatively smaller because of the spiral valves. And the color of the bile also is important. The bile which comes out of the CBD, a hole or a cut in the CBD, will be bright golden yellow, watery, and it flows freely, it trickles, it drips down freely from the tissues. On the other hand, if it is cystic duct, if it is gallbladder bile, it is usually thick, greenish yellow, viscid because it is mixed with mucus and it sticks to tissues. So again, the same thing is that in a difficult Calott's triangle, what I say that most guidelines say that in cholecystectomy, you have to and you must demonstrate the critical view of safety. Demonstrate the critical view of safety, you will cause injury to the common hepatic duct, to the right hepatic artery. So if you feel after some initial assessment that the Calott's triangle is fibrotic, is frozen, is obliterated, move away from the Calott's triangle, as Dr. Isidoro said, go to the junction of the body and neck of the gallbladder, open the gallbladder there, remove all the stones, suck out all the bile, put a bag, put a gauze piece there to trap the small stones. And now you look at the neck side of the gallbladder from inside. What was not apparent from outside, where the gallbladder is becoming the cystic duct, because there is a lot of pericystic duct inflammation, you can see from inside the big lumen of the gallbladder will narrow down into the narrow tubular lumen of the cystic duct, or nothing would be seen. So that and then depending on whether you can see the opening of cystic duct, whether bile is flowing back or not, you can either leave it like that with a drain, of course, or you can close the stump, or you can close the suture. While closing the stump also, one has to be very careful. That is why I said leave at least 5 millimeter fringe of the neck wall, because if you don't leave a fringe and take deep bites, CBD is just there, the bite may be now going through the CBD or the right hepatic artery. Fundus first, the only word of caution which Strasberg also has in one of his publications, you have to make sure that your plane is clear. It is very easy to get into the liver. And then if you keep going there, you can cause injury to the right anterior portal pedicle, which lies in the gallbladder bed. So if you are using fundus first, you have to stay very close to the gallbladder. It doesn't matter if you get into the gallbladder and have bile spill. There's no harm if Other point I want to make is about acute cholecystitis. Now, there are enough number of randomized controlled trials which say that lab chole is safe in acute cholecystitis, complication rates are same. The Tokyo guidelines also say that, but we have to remember that these guidelines, these publications are made by people who are working in institutional setups, in corporate setups, in big setups. They have experience and they have expertise. What they say does not necessarily apply to me if I am a average skilled general surgeon working in a small hospital or an individual setup. So my request and my suggestion to all young surgeons who are beginning to do laparoscopic cholecystectomy independently, try to avoid operating upon acute cholecystitis as far as possible. Refer these experience, yes, you can operate upon acute cholecystitis, but although guidelines say 7 days, some guidelines say even 2 weeks. But again, I would say take cases only those which are within 2 to 3 days, where there is not much inflammation. And if it is a difficult case, if it is a case which has gone beyond 3 to 5 days, unless you are a highly experienced laparoscopic surgeon who has done a lot of cold gallbladders and a few acute cholecystitis gallbladders, it may not be safe. And still, if you have gone in and you find it difficult, what Dr. Piyush said, that you do a cholecystostomy and come out, or retract and go in again after some time. Because as has been repeatedly said, and as again I would quote one of my colleagues from SGPGI, Dr. Anu Bihari, that in a patient with gallstones, the aim is not to do a complete cholecystectomy. The aim should be to do
So I think one more point I would like to add about a clip I forgot. So when you are using a clip in a patient where there is no history of CBD stone, and you are requiring 1 centimeter clip to close the cystic duct, it's very important. And remember, you are clipping the common bile duct until unless you prove by any means that this is not the common bile duct. So it's very, very important. A very important point we were just missing for the benefit of this thing. Regarding this achievement of the CVS, now in US probably it is now they are making it compulsory that you should have a double photographs. So before clipping and dividing, you take a photograph after clearing the CVS, and then you revert back, take posterior photograph also. So only one sided is not enough, but you can achieve this one in about 90. The beginning, that subserosal neck dissection, which was start from posteriorly, described by Japanese in the beginning. One can enter in the plane of the subserosal maybe, and then blunt dissection going all around this thing, neck dissection, so that you are too much far away from the Kailash triangle area, and you are not going to do any injury. After that, whether you do take the stone, then do something, or whatever you do, is much safer than the trying to dissect in the Kailash area in a difficult situation where everything is obliterated and frozen. So I think these are the two important. One more important point about anti-grade cholecystectomy. Sir was talking about this thing. That article is being quoted by our colleagues lots of time, because anti-grade cholecystectomy, he showed that about review of 8 cases with the GAUMA, and that all major bile duct injury has occurred in a patient where lab was I'll always try to look into the plane. And if you are trying to go into that, repeatedly we are saying the plane which was described by cystic plate between the glycerion capsule and the plate, then you are going to reach in that right pedicle. If you are staying away from that plane and entering the subserosal plane, because that is not that vascular also, then probably that those things can be avoided. And those injuries occurred in people after conversion. So those injury did not occur before conversion. So I think we should keep that also in the mind, and we should also keep this in mind that certain times it is life saving, it is saves, but this helps us in facilitating our surgery. So I think it is very, very important to understand this. Thank you.
Thank you, Dr. Isidoro. And both you and Dr. Sudha Satwa are invited to join us for a cup of tea before we have the last.
Thank you very much. It's too far, but I'm very impressed, and I would like to thank all of you for this invitation. Hope to see you next year. Bye bye.
Yeah, and in the meantime, you need to invite all of our JSF faculty to Italy once.
Of course, of course.
Yes, for a meeting. Thank you so
Bye bye.
much. Yeah, we will come back at 4:15. Because every session has some new Sorry. Come.
So good evening, everyone. So now we move on to next session. Next session will be on surgical anatomy of the porto-systemic shunt. Will be presented by Dr. Piyush Vashne. He is an associate professor at AIMS Jaipur, and discusser will be Professor Piyush Hani sir. He's a senior consultant at Max Hospital, Delhi, past professor and head AIMS Delhi. And Dr. Manu Gupta, he's a associate professor at Mahatma Gandhi Hospital in Interventional Radiology Department. We can start.
Thank you. At the outset, I would like to thank my teacher and my mentor, Professor Kapoor, for this opportunity. So I've just subheadings, the indication, classification, and then procedures. I'll cover a bit of tips also. So just a brief of it, it's not the part of the talk, just a single slide on what are the shunt indications. So in cirrhosis, there is no role of a prophylactic shunt surgery, and it was rarely done before the TIPS era. But after the advent of TIPS, it's rarely being done as a indication of surgery in cirrhotics. But sometimes when there is refractory bleeding, so a portocaval shunt or a DSRS can be done. In non-cirrhotic, PSRS is an established procedure, whether it is a EHPVO or NGPF. So what are the contraindications? These are the general and pertinent contraindications like cirrhosis, advanced cirrhosis, severe cardiopulmonary disease, age, portal vein thrombosis when the anatomy is not pertinent for shunt, active infection, or uncontrolled encephalopathy. So broadly, shunt can be divided into three types: non-selective, selective, systemic blood flow. The difference in selective shunt is that it compartmentalizes one of the system into the systemic circulation, while partial shunt just use the interposition graft to divert some of the shunt from a portal system. So advantage is that it preserves hepatic function, minimizes liver failure and encephalopathy, and then controls variceal bleeding. So these are the prototypes of shunts. Non-selective shunts are portocaval shunt, mesocaval shunt, and PSRS. Selective shunts are distal splenorenal shunt and Inokochi shunt, and partial shunt is an interposition shunt. When we talk about TIPS, it also is a non-selective shunt. So coming on to a PSRS, so if we see the anatomy, there is an obstruction at the extrahepatic site. So there is some resistance for blood flow to go to the liver, but it finds pathways to go inside the liver. While some of the blood is transmitted to esophageal varices and gastric varices, that precipitates in the form of upper GI bleed, in the form of gastropathy or esophageal. Anatomy and its relevant points. So first step is opening of the gastrocolic omentum and taking the omental vein pressures to one of the omental vein, and then ligation of the short gastrics. So spleen is checked for any adhesions, and the gastrocolic omentum is opened through energy sources, and then gastrocolics are divided, short gastrics are divided. Better to use or doubly ligate these vessels because especially in portal hypertension, then they can bleed and the clips can usually slip. So next step is to isolate the splenic artery. So to isolate the splenic artery, it is usually found at the superior border of the pancreas, and it should not be too distal, like close to the spleen. It should be somewhat proximal so that we do not end up ligating any branch or the polar branch of the splenic artery, which will not lead to proper decongestion of the spleen. So it is important to ligate the proper so that the splenic blood flow is halted and spleen shrinks in size. Next is to mobilize the spleen all around by dividing the splenic attachments like linorenal and splenophrenic ligaments. Sometimes there can be a lot of adhesions due to previous sclerotherapy or perisplenitis. So they has to be done carefully with the help of energy sources like cautery or ligashore or harmonic, whatever you are using. So after this, the spleen is delivered into the wound and then the dissection is done to isolate the splenic vessels. So now we have already ligated the splenic artery proximal to it. We just need to isolate the splenic vein and denude the splenic vein from all other tissues that is around the splenic artery. So important point is that you should always ligate the splenic artery again if it is there, so that there is no bleeding. And you should try to gain as much as length of the splenic vein is isolated and the polar branches or the tributaries of the splenic vein are ligated. And then the spleen is delivered out. So these are the ligation of the tributaries, and then subsequently the spleen is being delivered out. After this, the next step is the splenic vein mobilization. The important point is to remain in the plane that is avascular plane. So if you see the fusion fascia of Treats, there's lung behind the duodenum, continues with the fusion fascia of Told that is around the colon. So this is a relatively avascular plane which is used to mobilize the pancreas. This is how the pancreas with the splenic vein is lifted and some pressure on the splenic vein is given at the site of mobilization of the pancreas, and then a splenic vein is mobilized. So this is how small tributaries to the pancreas are divided and the splenic vein is mobilized for some length. So you can see the So after that, it is the preparation of the vessels and then shunt. So coming on to using continuous sutures, so in the one more point is that before releasing the clamps, it is better to let off some blood or just flush it with Hep saline, so that if there is some clots or any tissue which can be let out. So once the splenic vein is mobilized, it can be trimmed to a specific length so that it can reach the renal vein. Usually what is recommended is around 4 centimeters of splenic vein so that it can reach to the renal vein without any kink or tension. It is flushed with Hep saline and the ends can further be freshened for stay sutures to be taken. Next, the renal vein is being clamped and a venotomy is being made on the renal vein. And again flush with Hep saline. The stay sutures, stay suture is on the middle of the renal vein. This is not necessary, but it helps in opening of both the flaps of the renal venotomy. Then two angle sutures are taken at the corners. Usually the anastomosis begin at the far end where the operating surgeon is standing, and both the corner stitches are being taken. So one corner stitch is being tied off to start off the anastomosis. So these are both the layers. So important point in this is that we should take complete adventitia and media while not playing there. So so that we should not miss the media. So what happens is if we miss the media, there can be increased chance of shunt thrombosis or occlusion of the shunt. That is lying near the. So the last part is to release the clamps. So once the anastomosis is completed, before trying with the growth factor, it can be flushed with Hep saline and some blood can be let out before trying, and then the clamps are released. First, the renal vein clamp is opened up and then the splenic vein clamp. And then we can look for hemostasis. Usually there is some bleed with just the time the growth factor is taken up. It usually settles down with gauge pieces or some slight pressure, and nothing has to be done for that. Then the sutures are being tied, and you can see nicely done. There should be no undue kink in the splenic vein, because once the pancreas falls in the original position, there can be some kink, and that can lead to the thrombosis of the shunt. So this is the completed splenorenal shunt. So this is the picture that looks after completion of the shunt. So what has been proposed by Jipmer group, Dr. Biju, that there can be an impingement of the tail of the pancreas that can lead to the shunt thrombosis. So what they've described in the series of around 80 patients, they've used a caudal pancreatectomy so that the pancreas is divided, and they've shown that it decreases the rate of shunt thrombosis in the follow-up of around 42 months. So shunt, the PSR is relatively a safe procedure with operating mortality of less than 2%. Because of the standardized technique and extensive literature has been published over it. There are some complications like rebleeding, shunt thrombosis, or an operating mortality of around 2% that has been described in literature. Long-term complications are very rare. This is the Porto-systemic. So portocaval shunt can be of three types. It can be a side-to-side or an end-to-side that we do in probably in transplant temporary portocaval shunt, or an interposition shunt. So the steps are basically to isolate the IVC by cauterization, and then isolate the portal vein by hepatoduodenal ligament dissection, and then join them. So this is how the IVC is exposed by extensive cauterization, and IVC is bared to a length of around 180-degree circumference so that a clamp can be applied easily. And then this is how a side-to-side anastomosis is done. So basically the principles of vascular anastomosis remains the same. We should take a full thickness adventitian media and using a continuous non-absorbable suture, probably a 5-0 or 6-0. Important point to remember in the interposition graft is that 8 to 10 mm ring reinforced PTFE graft can be used depending upon the diameter of the 1.5 to 2 centimeter is sufficient. So graft anastomose is also similar. We usually anastomose first to the IVC so that the tension on the portal vein is less. First the IVC anastomosis is completed, and then the appropriate length of graft is cut, and then anastomose to the portal vein. So it diverts the partial blood flow and reduces the portal pressure of around 5 to 10 millimeters of mercury. So advantages are excellent portal decompression. It is easy to do and it has durable long-term patency. Disadvantage is that it diverts sometimes. If we do a side-to-side portocaval shunt of large diameter, it diverts all the portal blood flow and it can increase the rate of encephalopathy and hepatic decompensation. So usually it can be a suboptimal for advanced cirrhosis. Next is the mesocaval shunt. So again, mesocaval shunt is done by mobilizing the root of the mesentery or the root of the mesocolon, where we find SMV, the somewhat a size of around 1 to 1.5 centimeters. Small tributaries are being tied off. Frequently, the duodenum is cauterized and colon is lower down, and IVC to the vicinity of the SMV can also be mobilized, and a venotomy is done of around 8 to 12 mm. So important thing is the graft length determination. So we use an interposition graft of PTFE graft. It should be sufficient length so that it forms a smooth C loop, and there should be no kink or kinking or tension over the anastomosis. So it should be sufficient length of around 4 to 5 centimeters. So steps are basically same. You apply a clamp over a IVC, take a stay sutures on the IVC, do a venotomy of around 1.2 centimeters or the size of the graft, and then anastomose to the SMV. So first IVC is done so that there is minimal tension on the SMV, and IVC to this is how anastomosis is being completed from one end to another, and then the SMV side is completed, and then the clamps are released by flushing it. One of the patient we performed, you can see a nicely formed C shape of the interposition graft from SMV to the IVC, and the patency can be checked on Doppler in post-operative period. So the complications are thrombosis, graft infection, encephalopathy, and persistence of ascites. Next comes the mesorex shunt. So this is basically done in children and most often described in Eastern literature of Japanese and Koreans, where the left portal vein or the rex recess is patent. So what to find in Indian patient is that there is extensive portal vein thrombosis and difficult to find a patent left portal vein, or due to lack of exposure, this shunt is rarely performed in Indian centers. So major advantage is that it restores the physiological portal blood flow because it directly bypasses the blood flow from SMV to portal vein. So it is the most physiological shunt. So outcomes are encouraging and recent consensus supports this use, especially in children with EHPVO. So this is how Rex shunt looks like. You need the portal vein divides into segment 4 and segment 3 through the umbilical vein. So this is how where we find a Rex recess. So there we can open the portal vein and use a interposition graft or a PTFE graft or a stephanous vein to bypass the SMV2 portal vein. Next is the DSRS. DSRS is basically in which the splenic vein splenectomy is not done and the splenic vein is transmosed to the left renal vein. So it is selective decompression and preserves the mesenteric portal blood flow, and it compartmentalizes the venous drainage. Contraindications are refractory ascites. It was way back described in 1970 by Warren and Zappa. So what happens is the portal flow is preserved while you only divert the flow from gastric varices and esophageal varices through the splenic system into the left renal vein. So I think the surgical steps more or less similar, but the important form in EHPVO, it was used historically in cirrhotics patient when there was small size spleen and child A or child B cirrhosis. So this is how PSRIS is being done. Last is the IMV cable shunt. So this is also rarely done. This is one of a case we did around 3 years ago, a desperate situation in which all the vessels were thrombosed. We have only IMV. So IMV is mobilized in entire length for side to side. And we did a side to side IMV cable shunt. And this patient is doing well. We did a bilirubin of around 46 stented. Now the stent has been removed and we haven't done edge till now. So patient is doing fine. And the shunt is patent, but it is very rare indication. So last few slides about TIPS. TIPS is a transjugular intrahepatic porto-systemic shunt. It is basically done for acute and refractive bleeding. So after the advent of TIPS, nowadays surgical shunt for cirrhotics are being obsolete and it's being commonly used for management of bleeding as well as ascites and has been used like DIPS. Like severe pulmonary hypertension, uncontrolled infection, or extensive polycystic liver disease. Relative are advanced cirrhosis, HCC, portal vein thrombosis, or biliary obstruction. So the technique is like you go through the right internal jugular vein, puncture the right hepatic vein, traverse the hepatic parenchyma, and then puncture the right portal vein, create a tract, and then pass it on a stent. So important thing is to measure the HVPG. Nowadays, it is very easy to measure HVPG. So if HVPG is more than 20, it usually denotes that there will be rebleeding. So it has to be cautious in performing TIPS in these patients. Modern modifications like covered stents have reduced the rate of thrombosis drastically, and they can and the chances of encephalopathy can also be reduced if we use a multi-step dilatation. Initially place a small diameter graft and then can be serially dilated. So this is how after portal dynamics looks after a TIPS. So portal flow from the on the left side you can see the video in which there's a fluoro image of a TIPS in which the left coronary vein, so the gastric vein or the coronary vein is also obliterated and a TIPS is formed. You can see the blood is now flowing from the portal vein to the right hepatic vein. On the right, we recently did a liver transplant for a post-TIP patients. So I just showing that the TIPS, if placed intrahepatically, can actually make the surgery easy because it reduces the portal hypertension and the bleeding becomes less. So it is, I have put my Kelly clamp from the hepatic vein to the portal vein, and then now I'm dissecting the tract as well as the stent so that it can be retrieved. The video has just been made to show that how good TIPS can help to make a surgery easy. So this at the dissection at the hepatic ostium was easy, and this is how uncovered stems or the tip stent looks like. Nowadays, there are covered stent also that can be used. This is around 8 centimeters, and so tips have excellent outcome of 95% technical success, 90% bleeding control rate, and around 11 to 15% rebleeding rate, especially if the portal pressure is high. And it has got major complications of around 3% and excellent 1 year survival of around 90%. So this is my last slide. So key consideration in porto-systemic shunt surgery is that patient selection, technical essentials like adequate inflow vesicle caliber and mobility, avoid anesthetic tension or twisting or kinking, and to side or side to side technique which can be feasible depending upon the case scenario, and a patency can be confirmed with a post-operative Doppler or an intraoperative Doppler. Target should reduce the in gradient and obviously monitor the perioperative hemodynamics. Complications can be there, but PSR is usually safe of around less than 2% mortality risk, and they have excellent outcomes in EHPVO. Thank you.
So thank you, Piyush, for a very nice presentation covering all the aspects. Just a few points. When you mobilize the spleen, we generally try and look for an avascular plane between the linear ligament at the back so that we don't lose too much blood. And this plane lies, it's probably very similar to the plane which is at the posterior part of the pancreas and continues on towards the splenic hilum. Finding it is easy if you pick up the lower pole of the spleen, lift it up, look for the tail of the pancreas and pull the colon. You will find an avascular plane which is behind the linear ligament, which is full of collaterals. So the advantage this plane gives you is that you can put your hand in and you can get very good control even if you get bleeding from the while dividing the linear ligament. The second thing that I would like to emphasize is that when you're mobilizing the spleen, especially posteriorly, at times when it is difficult to get this avascular plane, you pulling up the spleen, you can get into the wrong plane and injure the adrenal. If you do that, you get an irksome, troublesome, irritating, frustrating bleeding from the adrenal gland. So before you do that, try and separate the adrenal gland and push it down so that you don't injure it. We are very particular about is that when we mobilize the renal vein and put a clamp on it, we want to be sure that we've got the adrenal vein and the gonadal vein in control. Because if you pull up the renal vein too much, you can tear one of these. And if you tear the gonadal vein, it retracts back very quickly, becomes very troublesome bleeding in that area and difficult to control. So we usually would divide the gonadal vein. It doesn't cause any issue. We would mobilize the adrenal vein, loop it and keep it and not do anything else to it. There have been times when we found we've run short of the length of a splenic vein. You had excellent length in this video, but sometimes you can injure the splenic vein right at the time when you're reaching the point where you don't want to dissect anymore. And you have to then sacrifice that bit of the splenic vein. So the lienorenal becomes an adrenorenal shunt. And this works as well as a lienorenal shunt does. So we generally try to get control of the adrenal vein as well as the gonadal vein. That's all that I wanted to say about the lienorenal shunt. The portocaval shunt, The mobilization of the portal vein needs to be enough for you to be able to bring it close to the inferior vena cava. Sometimes the hepatoduodenal ligament is a little thickened, especially in patients with chronic liver disease when you need to do it for transplants. And that time, sometimes you compromise and say, okay, I'll put a short graft in between. But if you're doing it primarily for, not for a patient who's got cirrhosis and is a temporizing measure, but for a patient who is going to need this on a long-term basis, such as fibrosis, in those situations, we'd much rather mobilize the portal vein, bring it close to the IVC and not put a graft in between. If you put a graft in between, you need to put them either on anticoagulants. If you're using an autologous vein graft, you've got 2 anastomosis, your thrombosis rates become a little higher. So therefore, we prefer to do that. There are times when you can't do it, but if possible, we would always like to do that. Same thing of the, as far as the mesocaval shunt is concerned, we try and do a side-to-side without an interposition graft. If we have to do an interposition graft, we try and do the shortest lengths possible. So it becomes like an H rather than like a C, because the C is actually a longer graft and goes across the duodenum. But we try and do an H so that the length is short. We'd almost always, if we wanted to use a graft for a mesocaval shunt, almost always use the external jugular vein and use it to do the anastomosis. A synthetic graft. So the advantage of the autologous graft is lower thrombosis rates and no need for long-term anticoagulation. That's all that I have to say.
Sir, what about the follow-up of these SPSS graft? Na? Jैसे if you are going for an autologous graft or PTFE graft, so what is the protocol for the follow-up of the patients?
So we do a Doppler every 6 monthly for 2 years, and then we stop. If we use
First follow-up will be on 6 months.
You can do early also, like 14 days, 3 months, but usually a 6 monthly follow-up is being done.
Okay. Sir, I'd like to
Sorry, but you would probably do a Doppler before you discharge the patient to document that shunt is patent. So that's important.
Secondly, sir, if you are going for a anastomosis, because if we are taking out the spleen, there is chances of infections and all, na? So you prefer end to side or side to side anastomosis?
Sir, I think you may tell better that when we remove the spleen, so it is always beneficial to do an end to side, because the spleen is not there, we get the end of a splenic vein. And we have large Indian series that OPSI is very, very rare in Indian patients. So the risk of infection is very less in these patients. So we can do a safely end to side shunt.
So the side-to-side shunt was described and used frequently by Dr. Mukta and PJ. And he used to do it, he started doing it in children, but then because he started doing adults as well, he started doing it on adults as well. And this was done by mobilizing the splenic vein and bringing it close to the vein and doing a side-to-side anastomosis without removing the spleen. The issue only with not removing the spleen rates which are in the range of about 45% of these patients don't come down completely. You don't eliminate it. It comes down to about a third to about a fifth. About half the patients would improve. The others would continue to move like hyperstony. So that's the advantage of removing the spleen. Effectively, so side-to-side shunts are generally better for patients who have intracranial ascites. But most patients with extracardiac venous obstruction or non-cirrhotic fibrosis or even hepatic venous outflow tract obstruction usually have well-controlled ascites. EHO and CPF don't have it or have minimal. Hepatic venous outflow tract obstruction, where it's hepatic vein block alone, will have ascites, but usually manageable. And in these also, if you do proximal spleen renal shunt, is end to side, it functions like a side to side in the sense that the ascites is not
is your technique? I have three questions, sir. What is your technique of assessing the orientation of a splenorenal shunt? Because once we start doing, we orient it, we keep the superior and we to the lateral part. But once we keep the pancreas down, it looks like there is some curvature, some twist. So what is the best way of assessing that, okay, my orientation is good, even if I see that the pancreas is down, even if I see that some twist, this is the best thing I can get.
So the easiest way of doing it is to, the simpler way of doing it is that you get the upper edge of the splenic vein down to the lateralmost part of the renal vein incision, and the lowermost part of the splenic vein to the medialmost part of the nick on the renal vein or the opening on the renal vein. Okay. So this is how your anastomosis. Degree or a 10-degree twist around, which becomes apparent to you when you let the clamps come off. At that point in time, what we try and do is to fix the pancreas in a position. So the pancreas tail, one of the reasons we don't do a caudal pancreatectomy, which what the JIPMA group advocates, is that you can use the pancreas at this stage to hitch it towards the retroperitoneum and remove that angulation on the splenic vein and allow a good flow to happen. The only times we've done a caudal pancreatectomy is in some patients with NCPF who have had some ascites in a post-bleed period. They tend to have a little bulky pancreas, and that interferes with getting the anastomosis done. And that's the only time we remove the tail of the pancreas. Otherwise, we try and get a smooth angle of the splenic. So that's what we try.
Sir, in patients who underwent multiple episodes of endoscopic sclerotherapy, there'll be some plaques in the splenic vein. So whenever we try to loop the small tributaries, though that will inadvertently injure the splenic vein, and we just go on losing the length of the splenic vein. So are there any technical aspects?
So in these kind of patients, you just need to be a little more slow. Just go a little more carefully and try and remain away from the splenic vein. When you hook a tributary of the splenic vein, which is of the pancreas, which is draining into the splenic vein, just try and tie your suture a little away from the splenic vein. If you do that, then you're unlikely to lose length of the splenic vein. However, having said that, there are and in those situations, little you can do except keep mobilizing till a point that you say, okay, now this is all I'm going to try and do the anastomosis with this. So those are situations where having mobilized the renal vein well enough or having a long length of the adrenal vein available helps you to do an anastomosis to whatever length. Even a centimeter of a mobilized splenic vein is available to you. You can go ahead. Third question.
Nephropathy, sir, following shunt.
So we've seen nephropathy happen in patients with non-cirrhotic portal fibrosis. We haven't seen clinical nephropathy happening in patients with extrahepatic portal venous obstruction. We initially thought it was related to the shunt, similar to the nephropathy that you see in patients with cirrhosis who develop a shunt nephropathy. But at that time, there were no ethics committees. You could go ahead and do, literally anything that you wish to do. So we in fact had two residents do a thesis. They did kidney biopsies just prior to or just after the shunt was done. And these biopsies, as well as post-operative biopsies, had similar changes. So these were almost like a pre-op biopsy, but they were done intraoperatively just to decrease the incidence of complications of the kidney biopsy. And we saw changes of mesangial proliferative, membranoproliferative glomerulonephritis in these patients. with IgG, IgM deposition as well as C3 deposition, complement deposition in the basement membranes, suggesting that this was something which is part and parcel of the disease process rather than because of the shunt per se. Because the shunt was either created 5 minutes before the biopsy or not created yet. EHPV. We had in fact lost on a long term treatments to to chronic kidney disease. Patients with NCPF on the limb.
Sir, one last question. Sir, do we have any patient selection criteria whether the patient has to go for SPSS or to go for TIPS on behalf of prior imaging? On your part, if patient first encounter to you, you do an imaging, then you decide whether the patient has to go for SPSS or to go for TIPS. Is there any patient selection criteria on your behalf?
So all patients with extrahepatic portal venous obstruction, non-cirrhotic portal fibrosis, that means non-cirrhotic etiology, would have a side-to-side, would have a porto-systemic shunt. The preference for us is a PSRS. All patients who have underlying cirrhosis, if they were basic B or C, they probably get a TIPS. If they were A, they could remain on endotherapy and not even have a TIPS if they didn't have refractory ascites or recurrent bleeds.
Okay, so we move on to the last session of the day, but very important because gallbladder cancer, at least in North India, is a frequent problem that we see. And to deal with surgical anatomy of wedge versus 4B and 5 resection, we have Dr. Ashok Kumar, who is my young colleague at SGPGI, doing a lot of good minimal invasive and robotic work. And the discussers are Dr. Anand Kumar, who, as I mentioned earlier, is the pillar of Jaipur Surgical Tutorial, and probably the youngest faculty of the Jaipur Surgical Festival, Dr. Krishna Rao Gurana, who's my former fellow from SGPGI and is now an assistant professor at in HPB surgery at CMC Vellore. Ashok.
Good afternoon, sir, and everyone. I want to say thank to Professor V.K. Kapoor sir and organizing committee. He called me for this topic to present and given this opportunity. So my topic is surgical anatomy of the wedge versus segment 4 and 5 wedge resection of the liver. So there are so many learning points, but we already have a short in time. So we should learn about the CAGB carcinoma gallbladder, when to do the liver resection, and what extent, surface anatomy of the liver, segmental anatomy of the liver, surgical anatomy of the bile duct, arteries, and portal vein, and abnormality in these structure, and the surgical anatomy related with the liver, wedge, or segmental 4B when we are resecting all these, and take home messages. As we know that we are living in the North India, we're seeing every fifth, sixth patient we have a locally advanced CAGB where you could not do anything. Only 20 to 30% patient we may get.
Ashok, your slides are not changing. Please put it on slideshow mode.
Oh, okay, sir. Okay. Okay, sir. Now you could see, sir.
It's still not in the full screen mode. Yeah, staging. Now I can see the staging slide. Now you can.
Okay. Okay.
But
okay,
slideshow nahi hua abhi bhi.
Slideshow nahi hua. Now can you see, sir? अभी ठीक है सर?
नहीं, वो कई बार ये प्रॉब्लम आती है.
ओहो.
Stop.
Okay, now.
नहीं, I think you stop sharing.
Okay, okay.
And then share again.
Okay, sir. Okay.
Presentation को बंद मत करो. Presentation खुला रहने दो.
Okay, okay, sir.
But वो green जो नीचे बटन है उसको stop share करके दोबारा share कर दो.
Okay, stop, sir. Okay, done, sir. Now.
Share again.
Now I can say. What it now, sir?
Now go to the slideshow mode.
Yeah, I've done, sir.
नहीं कई बार ये problem होती है. Anyway, let's continue.
Okay.
Double click on the screen.
Okay, sir.
Anand is suggesting on the main slide. जो ऊपर टॉप बार है उसमें स्लाइड शो में देखो.
Yes.
हाँ. Yes.
Yes. From current slide.
नहीं.
Now.
नहीं. I think we can continue like this. It's okay. It's okay. Yeah.
So we every fifth, sixth session we have a locally advanced CHEV, and only 15 to 30, 20% patient have opportunity to operate in form of doing 2 centimeter wedge resection or 4B and 5 resection. And nowadays we are doing have to do some extended kind of hepatectomy in a hilar kind of CHGB also with the jaundice. So here we could see that the depth of the GV is very important. When it is involved, only the mucosa can cause the lymph nodal metastasis is only 2% patient. As the depth increases, the chances of the lymph nodal metastasis increases 20 to 25%. That's why the T1A can be managed by the cholecystectomy only by taking the cystic plate. Some people in the Japan also taking the with the cystic plate also is called total cholecystectomy is maybe enough for the T1A, but T2B, T1B and T2 require all these kind of 2 centimeter wedge resection or 4B and 5 with all standard lymph nodal dissection around the CBD, cystic duct, portal vein, and 13 is called the retropancreatic lymph node. So here we can suggest the treatment for the CAGV that the T1A could be managed with the lymph cholecystectomy, but mostly patient come after the where the already cholecystectomy and the patient have come with the incidental CAGV. Upfront, we never recommend that the patient should have a cholecystectomy only. So here T21, T1B and T2 could be managed by the 2 centimeter wedge. However, the tumor situated at the neck may require the more extensive kind of liver resection, even CBD excision also. So every surgeon have a complication. If you are not having the complication, some people may start saying that you are not doing the surgery. So it's very important to have recognize these tragic surgical error to minimize your complication. It's most important is to recognize a failure to process sufficient knowledge of the normal anatomy and the function. And second, the failure to recognize the anatomical variation and when they are present, or a failure to ask to help when uncertain or unsure. So first two can be read or learn from the book. All are the cold kind of anatomy, but there is the controversy with the surgeon that we all require the hot kind of or warm kind of anatomy and deal with the pulsatile anatomy as studied Professor R.A. Sastry has mentioned. So failure to ask the help when the uncertain, unsure, the people or surgeon learn by the humility and when they anticipate and realize their own failure. The mastery of the segment anatomy of the liver as well as the comprehensive understanding of the both normal and anomalous arterial, venous, biliary anatomy are the prime important for performing the safe hepatic resection. So before knowing the anatomy of any organ, this is important to have a embryological information also. So the liver developed from the hepatic bud and divided in two parts. Pars hepatica form the liver parenchyma, and pars cystica form the cystic duct and the bile duct. And later on enlarges, and all the peritoneum fold around the liver may provide some landmark over there, so that we can these landmark can help the surgeon to have an idea before the surgery and make a roadmap also. So liver have a very important ligament called the falciform ligament, divided liver in two parts. We already have discussed, but still is required for the any kind of resection, liver resection. So liver divided into lobe, left lobe, right lobe, and there is coronary ligament, which is bifurcation of this ligament and form the lateral two ligament called lateral ligaments. And if we are seeing the inferior surface of the liver, there's a four lobe, right lobe, left lobe, caudate lobe have a dual supply of the every arteries, vein, and the duct, and the caudate lobe, because of this shape is called a caudate lobe, is segment 4 lobe. So deep anatomy is also important for the surgeon, for the functional anatomy and surgical anatomy is for especially doing when you are doing any resectional surgery in the liver. So the liver have three main vein: hepatic vein, which is connecting with the IVC main middle hepatic vein, left hepatic vein, and right hepatic vein. This divided the liver in four sections: left lateral section, medial left lateral section, medial left section, and right anterior section, right posterior section, which and the Cantley's line imaginary is important imaginary line which connect between the middle of the GV fossa to left side of the IVC. Is divided liver into the liver, two part of the liver, one called the left liver and right hemi liver. So these four section further divided by the main portal vein, right and left main portal vein. Portal vein is the main inflow to the liver as supplies in about 75% of the liver blood supply and 25% from the artery. So these lobe further divided into segment 2 and 3 on the left side, segment 4A and 4B, and right anterior segment 8 and 5, and posterior 7 and 6. So all we have the information that the patient, the liver have an inflow and outflow before doing surgery. These information is important, and taking control on the inflow and managing the outflow is prime important. So here this is also important anatomy to know that the CBD or confluence of the CBD is not situated in the middle of the main hepatic fissure, is on hilar fissure. It is situated on the most on the right side of the hilar fissure, and just anterior to the right portal vein, not in the middle main bifurcation confluence, and the right artery on the right side and inferior to the veins. So in the CT, we could very well recognize, and before doing surgery, all is required to make a idea of the lesion and the segment we are going to resect. So here we can see the left hepatic vein, middle hepatic vein dividing two section, left liver, right liver, and here we started the right portal vein, where we could see that the lowermost segment could appear at this level. Segment 4, segment 3, segment 4, segment 5, and segment 6 can be seen at this level. So hepatic duct divided into main confluence, divided two ducts into left hepatic duct, which is more horizontal, and the longer extrahepatic length, and there is right hepatic duct which is shorter and more vertical, have divided into two duct, right anterior, right posterior, which is more vertical, we already said, and there is another third level confluence which have arises the duct to the given the duct to the segment 8, 5, and 6 and 4. So all these the segment are arranged in the anti-clockwise 2, 3, 4, 5, 6, 7, and 8. So here we have a fibroconnective tissue all around the hilar plate, which is very important, wrapping the all three structure together. And as we said, that the hepatic confluence is more situated on the right confluence. It's very important when you're looking for the duct in a bile duct injury for the anastomosis. So here we have the plate is called the cystic plate on the right side, and fissure plate on the left side, and main hilar plate in all continuation. All this covering going with all the way in the liver, and there is another covering is called the Lennec capsule. This is not the Gleason capsule. This is different capsule on over the liver, all over the liver, and coming with together all these Gleason capsule, and provide the spaces potential plane to the surgeon to take the control over the pedicle. So all the gap between the Lennec capsule and the Gleason capsule provide the gates. This is called the gate theory. The gate are situated here in the left side. The third number gate somewhere here, and second gate and third gate provide the control over the left hepatic pedicle, segment 2 and 3 pedicle. Here here is gate 3 somewhere, gate 3 here, and gate 4 at the hilar area, and the gate 5 here. So we can have a control over the right anterior duct by pulling the mobilizing the gallbladder and pulling down. We can take the pedicle here, and pulling the gallbladder towards the opposite side, left side, can take control over the left this right posterior pedicle also. So here we should know about the anomalies of the biliary tract. We already have discussed. This is the most common variation we have: right and left, anterior and posterior. This bifurcation, sometimes you have a problem during the reconstruction also. This is very prone to bile duct injury because right anterior duct connecting in somewhere in the extrahepatic area, and the right posterior arising from the left side. This is rare most. And the Hong classification of the left side is also important before doing all these surgery, because the most of time the segment 4 duct arising from the left hepatic duct, but it may arise from the right hepatic ducts also. Ascending right anterior ducts can give this segment 4 duct, and sometimes is also from the CSD segment 4, and may form the confluence on the left side ducts also. And this is the variation of the segment 4, which is less common. So here have a hepatic arterial variation, which is less important for the segment 4B and 5 resection, because this, however, this is more common, more important for doing the surgery for the gastric tumor and doing the Whipple procedure, because all these variation because here the left hepatic duct can be arises from the left gastric duct, which may have a danger when you are dissecting at the level of this hiatus or doing the surgery for the gastric tumor. And there are the other variation, right? Replace hepatic duct which arising from the superior mesenteric artery may have a accessory artery, may not have a much problem, but replace artery, you always should be have a worry and anticipated these variation. Here we could see that one have a here we will have a accessory right hepatic artery, and we already have a right hepatic artery here. And here we could see that this arterial branch is coming from the left side, is arise from the left side, and root of the segment 4 is reaching up to the hilum. The portal vein have a comparatively less variation, and its form the confluence at the neck of the pancreas, where is formed the splenic vein, IMV, and multiple may have a multiple SMV, superior mesenteric vein. Anteriorly, it has no tributary. Right side definitely have a tributary in a in an uncinate process, caudate veins, and given the right anterior and right foci on the right side, and branches to the segment on the left side also. There are the variation, this most common anatomy we found, and there is a trifurcation where the right anterior on the approaching toward the anterior cranial, and this is posterior cranial, and this inferior caudal branches. So liver was the resection indicated when the tumor are small, situated at the border of the liver and have a multiple involvement of the segment. So these are non-anatomical kind of resection. Initial dissection should be perpendicular on to the surface, and inverted pyramidal shape should have an inverted pyramidal shape. Resection should not be very enthusiastic. Try to take the 2 centimeter everywhere, starting from the fundus, and try to take the 2 centimeter at the neck level also. You may injure the main pedicle at the hilum. And terminal branches and portal hepatic vein branches need to be divided. Here in the small video I have done in this laparoscopic, but could not be skip the video further. He has to be on this way. So here we already have done the staging laparoscopy and taken the frozen section found to be negative for arterocable lymph node, making 2 centimeter marking all around the growth, all around the gallbladder. Luckily, gallbladder is hanging type, not the intrahepatic. Taking 2 transparenchymal suture itself to direct our specimen and body side liver when we are resecting the liver, and also provide some initial hemostasis when is starting the dissection. We can take 2-3 millimeter of the liver without having much bleeding, and very important to have a help from the anesthesia people to keep the IVC low. If they start giving the fluid, lot of fluid, so you may have a venous bleeding. This area is very important. Here we should be very careful. This is root of our and the top of the inverted wedge, and should be away from the hilum, at least about 1 centimeter from the hilum. So here we are taking the all aspirating the parenchyma, identify the radicals, maybe vein, branches of terminal branches of the portal vein, and superior part of wedge, mostly the hepatic vein encountered, and taken care by the placing the clip on the body side and divided with the harmonic. So this way we can do the bloodless liver resection without having any problem. So here we could not escape or increase the speed so that it will be on this one way.
Ashok, you have about 2-3 minutes more.
Okay, sir. Okay, so anatomy of the segment 4B, and the segment 4 is bounded by the falciform ligament on the left side, middle hepatic vein on the right side, subdivided by the portal vein at the level of the portal bifurcation at 4A and 4B inferior, and segment 4 pedicle lie in the umbilical fissure, can be taken care easily, and middle hepatic vein run in the plane between the segment 4B and the 5, and the segment 5 is demarcated from the segment 6 by the right hepatic vein laterally, and root of the resection margin can be bordered by the rubeus sulcus on the undersurface of the liver. Segment 5 is separated from the segment 8 by the portal bifurcation. So here we could see here we can make a demarcation line sub-centimeter from the umbilical fissure. Here we need to have a intraoperative ultrasound so that we can make a demarcation medial to the right hepatic veins, and here we should keep ourselves away from ventral to the rubeus sulcus. So further superior demarcation could require the demarcation of main portal vein on the superior side of the resection. So rationale of doing the segment 4 and B, anatomical boundary of the individual segment are relatively avascular, not crossed by the large portal pedicle, avoid leaving the behind devitalized parenchyma in the remnant, avoid risk of the infection of the biliary fistula. By proper pre-operative planning, one can guarantee the adequate resection margin and preserve the maximum non-tumorous parenchyma, and good oncological rationale theoretically. So here I just want to show the small video of the segment 4B and the 5. So here we have ligated the cystic duct, divided. So segment 4B demarcated by the 4B pedicle identify on the umbilical fissure on the right side of the falciform ligament, can be looped or clamped. So and here we can mark on the right side of the umbilical fissure, both on the superior surface and inferior surface of the liver. Segment 5 demarcated by putting the T-probe of intraoperative ultrasound, marking here, and superior marking require the identification of the portal vein on the surface. So here we started the resection. We have taken care of the 2-3 pedicles coming from the left side of the liver. We've taken care of the small branches of the veins.
Ashok, I think you will have to conclude because we need to give time.
Okay, sir. So it is very important to take very much take care when you are having resection near to the hilum. So always be aware about here we are clipping and dividing on the right side of the demarcation line. And on the superior demarcation line, when we start resecting, should have a branches from the middle hepatic vein on the both lobe. 4B and the 5 should be ligated and divided. After doing dissection, all the lymph nodal dissection all around the cystic duct and the pericholecdochal lymph node, periportal lymph node, and retropancreatic lymph node should be taken care and removed for the sampling and the radicality of the procedure. To take home message, it is important to have a knowledge of the liver anatomy in order to reduce the post-operative morbidity and the mortality. Should have a clear knowledge of the surface landmark around the round ligament, hepatic hilum, gallbladder, and deep landmark also hepatic vein, portal vein, and hepatic artery and the bile duct. And the liver is divided into 8 segments, each of which is an independent functional unit. And CT scan, 3D reconstruction, and perioperative ultrasound are indispensable tool to obtain the dynamic evaluation and of the anatomy during the hepatectomy. Thank you. Thank you, everyone. Thank you, sir.
Anand.
Minimum millimeter margin which will require for the carcinoma gallbladder patient when we are doing operating or doing radical calling in this patient, and why the concept of wedge resection to the millimeter lesser than size of the liver parenchyma resection is shifting there. Why this concept is there?
So mostly people think that the vein from the cystic vein may drain about 1 to 2 centimeter all around the vein from the liver directly into the liver parenchyma. So it required 2 centimeter. However, there is no well consensus on this. The Japan, some South Korean, Japanese also recommend that if the tumor is situated on the anhepatic side, in a smaller size, can be taken only the few sub-centimeter or 1.5 centimeter. There is very recently, I have read the article from the Chile, they have compared the 1.5 centimeter to 2 centimeter hepatic vein resection. They calculated the volume or the both. One have a 105 and another had its 85 cc, and both have the same outcome. So there is even with the segment 4 and 5 resection, there is no difference in the overall survival or disease-free survival I've seen in the even in the meta-analysis also.
And so regarding that, when we have an incidental CA gallbladder, when the patient comes to us with a biopsy finding or report of CAGB, and the histology or the stage is T2 T2A or the T2B, so in which case we need to do a liver resection in these patients.
So, however, the liver resection require both two situation. So this the how much you want to remove, that could be the different opinion. If you have an anhepatic site, you may limit your resection to 2 centimeter, and you have to see the other factor of in the patient. Suppose you have a patient with a 80 years old patient have so many comorbidity, have a high risk. So why you do so much recession in the liver? So you should take your decision depend on the so many factor. Where is the tumor situated? What is the size of the tumor? And what who is your patient? And what are the what is the feasibility of the surgery and what you could achieve with the surgery? I think these points should be
the
taken.
Koreans are in the Koreans, and they are in the incidental CAGB. They usually don't resect the liver if the
How they don't this is may not be that they don't resect the liver. They all taken the decision, as I have said. However, when the liver already infiltrated, how you could leave the liver behind? If it's already infiltrated, is beyond the wall, you may require some kind of the liver resection.
Yes, sir. We in the when the patient is having a T2B on the peritoneal side, the hepatic side, we'll go and resect the liver. Here the
Definitely.
same concept when the comes here, the what should be the exact margin we need for the to resect the liver. Till now we don't know, but the when the tumor is situated on the peritoneal side, so should we resect the liver or not?
This all I have said. This all depend
If
on
the patient general condition is fit to go undergo surgery, or we can resect, so should we resect or not? Or when we are thinking the pre-operative gallbladder is there, and as a Kapoor sir paper regarding anticipatory extended cholecystectomy. So in the Kapoor suggested that we need to only take 1 centimeter margin. So can we go just we can take only millimeter margin, take only cystic plate. We can remove only cystic plate. We don't need liver section there. Can we do this when we have?
That we can do, but all the paper have published by the sir is all mostly have a 90% have been found was benign, and the all way we have excluded the possibility of the malignancy in these cases. And these thickening was symmetrical thickening. We already done the CT, we already done the liver tumor marker also. So all I think that you can do if you have a small tumor on the hepatic anhepatic side. Even you can take it 1 centimeter margin. Why not? However, we are living in the very aggressive zone, so we should take all the decision in a very careful mindset.
Thank you very much, sir. You have covered most of the topic. Extended cholecystectomy or segment 4B5, we feel that they are very safe surgeries, except maybe some patient will require some very hepatic collection, which will need a PCD. Most of the people do well. So how I was just thinking how we can improve the quality, like how we can decrease the morbidity of these patients. So sometimes we see that intraoperatively only some liver is congested, but we take it granted that okay, that's okay, we can do it better. We cannot do it better, but at the end maybe these are the maybe 1/3 of the patients will develop some bilioma requiring the can I? So
Ashok, you can stop sharing.
Yeah. Okay, sir. So all if you want to avoid all these kind of the complication, it should be very meticulous. It should not be have the much bleeding because of unknowing the anatomy. And should if you are in a very initial phase of the surgery, you should select the good patient for you, and always place the drain. If you're especially when you're doing the wedge resection, should always place the drain, because the non-anatomical kind of resection have a more chances of the bile duct leak. So always should place the drain and keep the eye on the patient, how he's doing in the post-op. Any clinical sign you should look into and should be investigated by doing some ultrasound or CT. And
I think Krishna has a small presentation.
Sir, I just have 2 slides to show.
Okay.
So I'm very HPB surgery. So this all you have covered, sir. So beware of variations. So this is a paper. This is a systematic review of right anterior sectoral pedicles. So what we see as 5 and 8 can be 5 and 8, can be D and V, can be 8D and 8V, can be quadrifurcation also. So most of the time when we plan surgery for these patients, we see that how much is the liver volume, whether it is 2 centimeters or more than 2 centimeters. And after that, we start thinking whether the anterior pedicle is involved, right artery is involved or not. But we don't really know, go into the anatomy, distal anatomy, and see how many segment 5 pedicles we get when we wanted to do resection, and how is they originating. So if you see this one, this is also a systematic review of right anterior. And some can be anterior also, like some can be ventral, some can be dorsal. So we have recently seen one patient in whom we have seen that there is a quadrification of the right anterior sectoral pedicle. So because of that, what will happen is whenever we clamp the right posterior pedicle to see the demarcation line. So usually we don't try to loop the right anterior pedicle. When we want to do a segment 5 4B resection, we put a clamp on the right posterior and see what is the demarcation line. And then we start going with the transection line. But when there is a quadrification, that means we have segment 5 pedicle ventrally and one segment 5 pedicle dorsally. Okay. And when we are going along the demarcation line, we may injure the main trunk, which will separate the blood flow to the segment 8.
Definitely, it's very important information.
We had that problem. So this was just we did not know preoperatively. I was just trying to check are these anatomical anatomical variations are true or not. So we found one patient in whom there is a right dorsal pedicle and a ventral
pedicle also.
So
segment 5.
So when we get demarcation line, we may injure the main trunk, which will devascularize the segment 8. So my point is, whenever we are planning segment 4B and 5 to increase the quality, to decrease the morbidity, we should go into the tertiary pedicles and see how many 5s we get, how many veins we get, and whenever there is a vein, we should always see the confluence. We should not try to compromise the confluence, so that maybe if the segment 5 vein is joining into right, if we don't take care of the confluence with the segment 6, whenever we are planning segment 4B5, we should take care of all these anatomical variations also, and always clamp the pedicle and make sure we devascularize the desired segment. And I think we should not rely only on ICG. We should take the help of ultrasound also, and I feel that if we use both, we will get better results.
Yeah, definitely. That is very important. Then I have shown the video. The last part of the video is showing the same contain the same information as you're sharing. It's very important.
Okay, I think it's time to close. So you wanted to say something?
We were discussing that margin. So now a lot of paper are in favor of negative margin for CAGB, 2 centimeter, 1 centimeter. So that they shifted for the peritoneal malignancy, that just to dissect the gallbladder. But at the same time, I feel there is a risk of bile spillage. So what is harm? Spillage, because in general cholecystectomy also, although we do not care much, but we injure the gallbladder and bile spillage is there. So my take is what is harm to take some margin of liver just to avoid this bile spillage rather than going in cystic plate?
Just one quick comment. What is your technique of identifying the right anterior portal pedicle? Like, see, you're doing a straightforward segment 4B5 resection. You have taken down the 4B, maybe a single trunk 4A comes, you can safeguard that. That already black. What is your technique of going into the anterior pedicle? Because the variation, what you are saying, that you can injure the 8. While doing the segment 4B, you can injure the 8 or the anterior portal pedicle. But if you come down on the anterior portal pedicle, then you make a combination of anterior portal pedicle and cystic plate dissection. Along the anterior portal pedicle and see the leash of veins coming to the 5, 1, 2, 3. We have a paper not published, but presented in IHPBA last year.
we have shown that there will be at least 2 or 3 supply to the 5. You take down that, see how it is demarcating. And the problem what we face that we of these, even if you take down that, the segment 5 may not completely become black. So in that situation, you can clamp the 6, but that may be too much of ask in a straightforward situation. So you start dissecting, make a plane dissecting above the sulcus, the reverse sulcus, and you might encounter some pedicle from the 6 to 5. So that's what the anomaly may be there, but that is the easiest thing to do.
Yes, sir. But when we want it, usually we don't skeletize or we don't loop the.
On the anterior sector, because it is coming down. You are not going behind the anterior sector, is it not?
Thank you. Thank you, Ashok. Thank you.
Thank you, sir. Thank you.
Thank you, Anand.
Thank you, everyone.
We
Thank
also have a quick group photograph.